start now. I think you can hear me. For the questions of yesterday, we will discuss it on the break. Okay. Our next lecture will be presented by Professor Kate Remick. As you know, I think I talked about Catherine Remick yesterday, but just to remind you again, she is an associate professor, pediatrics and surgery, perioperative medicine, associate chair, quality, innovation and outreach director, National EMS for Children Innovation and Improvement Center, Dell Medical School at University of Texas at Austin, medical director, San Marcos Hayes County EMS system. Professor Catherine Remick, she will talk about pediatric cardiac arrest management strategies. I think this is very important. And you can start, please.
On scene for pediatric out-of-hospital cardiac arrest. So the reason we're talking about non-traumatic cardiac arrest is that when it comes to traumatic cardiac arrest, we know that the outcome is dismal. In fact, only about 4 to 5% of all children with traumatic cardiac arrest survive, and essentially all are neurologically devastated. There are now guidelines that exist regarding the management of these patients, either surgically or termination of resuscitative efforts, but this is not the crux of this particular talk. So my question to you is, what if we could save 1,000 more children suffering from non-cardiac arrest each year than we do now? And Daniel Kahneman is a Nobel Prize winning author who talked a lot about how we think and process, and specifically in his book, Thinking Fast and Slow, with the idea that when there are time-sensitive issues, it really helps to be able to think fast and respond efficiently, like if a ball were to come straight at your face, to catch it, but also to be slow and methodical when it comes to really considering the evidence or the ways in which we do things, particularly when the outcome is of critical importance, such as life or death. And oftentimes in the world of emergency care, we get so used to thinking fast and just doing things that we fall back on our habits rather than being much more strategic in our approach to certain types of care, including cardiac arrest or cardiopulmonary resuscitation. In the United States, there is a national registry called the Cardiac Arrest Registry for Enhanced Survival, and we've just hit our 1 millionth patient that was entered into this particular registry over the last year. And it really encompasses over 50% of the US population. Within this registry, there are about 2,300 pre-hospital agencies that are represented and about 2,500 hospitals that are represented. And it really looks at all attempted resuscitations for non-traumatic cardiac arrest. And just in the last year alone, approximately 150,000 non-traumatic cardiac arrest cases were entered into the registry. And among these, about 2 to 3% are pediatric specific cases. But it has allowed us to really glean a lot of insight into how we can improve care for this particular population. Among all comers, we do know that about 40% of patients, including adults, receive bystander CPR. And I'm sure, as many of you would suspect, there is a bias towards the adult population in that realm. And when it comes to management of patients on scene, only about 11% who arrested had an AED or automatic external defibrillator applied to the patient. So really helps us to understand and drive opportunities for improvement. Ultimately, about 25% of patients that were attempted resuscitation survived to hospital admission, which is great. But only about 9.5% survived to hospital discharge. And of those that were discharged, 80% had a positive neurologic outcome, which is wonderful because it speaks to really the importance of the work that we're doing, which is trying to save lives, not just the presence of a pulse and a heartbeat, but functional outcomes as well. When it comes to pediatric cardiac arrest in particular, we now know from this registry that there are about 23,000 pediatric cardiac arrests every year in the United States, many of which happen in the hospital setting, some of which happen in the out-of-hospital setting. And you can see the breakdown across age ranges. Ultimately, the incidence of pediatric cardiac arrest is about 15.5 cases per 1,000 pediatric pre-hospital responses. And you can see that in a large proportion of these cases, not surprisingly, about 38%, the cause is respiratory in nature, and as many as about 42%, the cause is presumed cardiac in etiology. And I would venture to say that the majority of those 40% are in the in-hospital setting, because in the out-of-hospital setting, we know that most of the time it's respiratory as the primary cause for cardiac arrest. Unfortunately, over the last several decades, we have not seen a huge shift in outcomes related to pediatric out-of-hospital cardiac arrest and survival rates, and this graphic demonstrates that here. Now, among infants, there has been some degree of improvement, but particularly when it comes to children, we've really tended to stagnate. And if you look on the right-hand side of your screen, at the analysis of survival to hospital discharge, you can see that among the adolescent population, we do fairly well, but when it comes to the infant and perinatal populations, we see significant differences in outcomes, with infants being one of the most challenging for many of our providers to manage, because their anatomy and size is just so very different. We also see a tendency, again, towards higher rates of survival to hospital discharge in those patients that do indeed have a shockable rhythm. The odds ratio here is 32. If they have a pulseless electrical activity, again, improved likelihood of survival. But in those patients with asystole, we know it really becomes a challenge to ensure the best outcomes for these children. Now, we often talk about kids as not being just little adults. They have different development, they have different physiology, they have different anatomy, they're sized differently. There's so many things about them that are different. But unfortunately, at least in the United States, this has caused some real challenges in terms of creating perhaps anxiety or nervousness when it comes to how we think about and manage these patients, because we think, oh my gosh, it's different. And it often causes our healthcare providers to pause and really rethink the approach. And therefore, going back to Daniel Kahneman's book on Think Fast, Think Slow, when suddenly we feel paralyzed and we lack guidance or practice in a particular skill, it becomes very difficult to perform at the highest level. So what we do know, though, is that when it comes to children, that airway management is definitely a priority. We do know that when it comes to drug dosing, we have to be especially careful because this is typically weight-based rather than a standard single universal dose. And oftentimes we have families present and really need to think about how we're communicating to the patients of that child, particularly during critical situations like when they're in cardiac arrest. But many of the same principles still apply. We need to assess the patient, monitor the patient, provide effective interventions, really track and follow the quality of cardiopulmonary resuscitation that's being delivered, and moving towards the best evidence-based outcomes, just as we would in the adult population. But perhaps because we've generated so much fear around the pediatric patient, or really tried to emphasize that children are not just like adults, that survival remains low and really our improvements have stagnated. The international consensus on cardiopulmonary resuscitation has come out with guidelines, a series of guidelines, the most recent of which were published in 2022. And what I'd like to do is try to highlight some of the key recommendations from that guideline. We know when it comes to management of non-traumatic adult cardiac arrest, there are some clear recommendations. One, early defibrillation, of course, and minimizing interruptions, ensuring full chest recoil and optimal compression rates and depth. A lot of thought put into this choreographed model of CPR where every person has a role and they know exactly what to do because it's been really orchestrated in a way that we often describe as a pit crew approach. That epinephrine during CPR and after the first defibrillation is critical. That we resuscitate at the scene rather than a scoop and run approach in order to provide the best high quality cardiopulmonary resuscitation immediately. And in drownings, there's really a consideration of whether it should be compressions first or not. And when it comes to these final recommendations, by the layperson, it's still compressions first. But in the setting of drownings for healthcare providers, we know that airway management is perhaps most critical. There are also guidance within this document that point of care ultrasound is really not a priority and may not be useful in diagnostics of cardiac standstill and or other interventions. And they advise against the use of vasopressin and corticosteroids in the setting of cardiac arrest. And last, when it comes to temperature management, really just targeted temperature management to less than 37.5 degrees Celsius. There are still questions about advanced airway management and use of mechanical CPR, which they really don't highlight. But we do know that there has been increased survival in adult patients over the last several decades because of attention to evidence-based practice guidelines. We know now that survival has improved from 7.5% to almost 18% in some cases overall. And for shockable rhythms like ventricular fibrillation and ventricular tachycardia, we see improvements in survival of up to as high as 31%. But when it comes to management of non-traumatic pediatric cardiac arrest, there are some other clear guidance that's being provided in the ILCOR recommendations. Namely, that automated electronic defibrillation should be used in patients over 1 year of age. Secondly, that pews should be implemented in hospitals to monitor patients who are at risk for deterioration and to identify children in cardiac arrest or peri-arrest states early. That epinephrine should be used for pediatric bradycardia that's otherwise unresponsive to ventilation and oxygenation. That atropine may be used for anticholinergic toxicity or those children with increased vagal tone. That pacing should only be used in the setting of complete heart block. That intraosseous access is acceptable. And in the pediatric population, they really do recommend against compression-only CPR because of the large percentage of children who are in cardiac arrest secondary to respiratory failure. And they also recommend against the routine use of sodium bicarb. Now, in terms of sequence of compressions and ventilations, airway management, and mechanical CPR, the jury is still out. But what we do know is that there has been no change in survival over the last decade, with survival rates for pediatric out-of-hospital cardiac arrest approaching 5 to 10%. When we look at pediatric simulated events, we know that the cognitive load is much higher. And this makes sense because we keep trying to state that children are not just small adults, they're different. And so indeed, in simulated studies, we find that it becomes much more challenging for healthcare teams or providers to optimize their processes of care, optimize cardiopulmonary resuscitation. And in this study, they gave 39 teams 4 different scenarios, 2 adult scenarios and 2 pediatric scenarios. Each were either a ventricular fibrillation case or a pulseless electrical activity. And what they found was when it came to the pediatric patients, none of the cases of pulseless electrical activity were defect-free, and only 13 of the cases of ventricular fibrillation were defect-free. Similarly, for the adult cases, though, they found that 28% at least of pulseless electrical activity sim cases were defect-free, and 70% in ventricular fibrillation cases were defect-free. So still room to improve when it comes to adult CPR, but far worse when it came to pediatric CPR. And part of that was suggested to be secondary to the higher mental load that's placed on these healthcare teams because of the need to administer weight-based medications, to change the energy dose for external defibrillation, to utilize pediatric-specific guidelines rather than the general adult guidelines, and that there were varied types and sizes of equipment being used for the pediatric population, all of which led to increased emotional stress and subsequently poor performance when it came to the pediatric population. But there is some information that we can glean from pediatric in-hospital cardiac arrest literature, some of which I would like to share here. So this was a study that looked at pediatric patients that were in the hospital setting who went into cardiac arrest. And they looked at how CPR was managed in these patients and divided these events into those that had a subpar depth of compressions and those that had an adequate depth of compression. And what they found was that in those patients where we had inadequate compressions, there was a lower percent of ROSC, only 31% ROSC. And in those with adequate compression depth, there was 74% ROSC. And subsequently to that, you can see the downstream effects in terms of survival to hospital discharge and subsequently survival with a good neurologic outcome of 18% for those with adequate depth compression versus 5%. And in this study, they took it a step farther and really looked at what percent of compressions achieve the guideline recommendations for depth and rate. And they found that only 26% of compressions that are being performed in the hospital setting achieve guideline recommendations for depth, and 83% achieve guideline recommendations for weight. And that only 60% of compressions resulted in the targeted systolic and diastolic blood pressure thresholds of 80/30 in the pediatric population. But what we know from the in-hospital cardiac arrest literature is that early epinephrine administration does indeed make a difference. In this particular study, they looked at about 1,500 pediatric patients, 31% of whom survived to hospital discharge. And they were able to demonstrate that when epinephrine was administered early, i.e. in less than 5 minutes, that it resulted in an increased rate of survival of 33% survival versus 21% survival for those that received epinephrine greater than 5 minutes from the time of recognition. And so this really speaks to the importance of early epinephrine administration in pediatric cardiac arrest. The second question might be, well, what about longer epinephrine intervals? Typically, we aim for 3 to 5 minutes for epinephrine intervals during a cardiopulmonary resuscitation event. And in this study, they looked at about 1,600 pediatric patients with in-hospital cardiac arrest, and they looked at the adjusted odds ratio for survival to hospital discharge for those patients that received epinephrine dosing intervals of less than 5 minutes, those of 5 to 8 minutes, and those of 8 to 10 minutes. And what they found was that those with the longer dosing intervals, actually as high as up to 10 minutes, had a 2.64 times the odds ratio of survival to hospital discharge. And so again, another point to take in is when we think about optimizing management of pediatric cardiac arrest, not only should we be thinking about early epinephrine administration, but perhaps we should be shifting to longer epinephrine intervals during cardiopulmonary resuscitation. A second study, or a third study, excuse me, looked at in-hospital cardiac arrest and the association of survival with intubation. And in this case, they looked at over 2,000 pediatric patients who went into cardiac arrest in the hospital setting. And they mapped out the time to intubation among these patients, 0 to 15 minutes and over 15 minutes. And what they found was that those patients with early intubation had a decreased rate of survival, 36% to 41%, which is further dictated or depicted in the table on the left, where you can also see that favorable neurologic outcome was also much higher in those patients that did not receive early intubation. So there may be something about early intubation that it leads to interruptions in chest compressions, or perhaps worsening hypoxia that leads to worsening brain injury and decreased neurologic outcomes. But what we do know from this study is that early intubation really should not be a priority. Really, the focus perhaps should be on optimizing compressions, both depth and rate, minimizing interruptions, and really postponing intubation until later in the resuscitation effort. This particular study by Sutton looked specifically at children in a pediatric intensive care unit. And again, as I cited before, that only 26% of the compressions were in line with guidelines for depth. 84% of compressions were aligned with guidelines for rate, and only 60% of compressions were in line with the goals for blood pressure. So really, this demonstrates that there's a lot of room for improvement, and really thinking about not just every single compression, but how do we maintain adherence to guideline recommendations during the entire course of the resuscitation event. And really beginning to think about what is the impact of only 75% of our compressions being adequate, and how do we really optimize that to 100%. One of the questions that we often wonder or ask about is, how long do we continue CPR? When does it become futile? And this was a study looking at over 3,000 children, and they were children who experienced cardiac arrest in the in-hospital setting. And they tracked them based on type of condition, whether it be surgical, cardiac, medical, trauma, etc., and outcomes or probability of survival to hospital discharge. And what they found is overall there was about a 27% survival rate, and nearly 20% had high or favorable neurologic outcomes. The median duration of CPR in those patients who survived was approximately 10 minutes, whereas the median duration of CPR in those who did not survive was much longer, closer to 25 minutes. And the adjusted probability of survival decreased significantly over time, where the probability of survival at 15 minutes was 29%, but at 35 minutes was only 19%, really helping us to understand how long should we continue CPR in the hospital setting before we know that the chance of survival becomes extremely low. And in this study, they suggest that that time point may be as far out as 1 to 2 hours, depending on your threshold for terminating resuscitative efforts. When they looked more specifically, though, at survival to hospital discharge rather than just survival from the event, and more specifically to favorable neurologic outcome, they found that the cutoff for CPR may be somewhat less, approaching closer to the 60 to 80-minute mark for favorable neurologic outcomes. This particular study also looked at the impact of quality improvement efforts on improving outcomes in children. And looking at 1,000 hospitals, 1,000 children in 12 hospitals that participated in the cardiac arrest quality improvement effort, they found that there were improvements in survival over time, in part because of certain strategies that were implemented, like rapid response teams to recognize children who are at risk for deterioration, early interventions, and high quality CPR. And over a 9-year period, they went from a 14% survival rate to a 43% survival rate, which is depicted in the graphic. All of this to show that indeed, if we are attentive to how cardiac resuscitation is delivered, that we can definitely shift the needle from 5 to 10% survival rates to much higher survival rates in children. Now, when it comes to out-of-hospital cardiac arrest, we know the challenges are greater because of the availability of resources and the time to initial response with healthcare teams. In the United States, we see about 5,000 out-of-hospital cardiac arrests in children. Again, the survival rate is low, and the majority are associated with respiratory failure. And sadly, we've seen no improvement in survival over the last several decades. We know, though, that those children who are transported to the hospital in active cardiac arrest, that the 1-month survival with a high or favorable neurologic outcome is extremely low, ultimately less than about 1%. However, if the arrest is witnessed or they have a shockable rhythm, the chances of survival are higher. And certainly if there's presence of a pulseless electrical activity, where we know there's also improved outcomes. But we do know that, especially compared to adults, that there's a higher proportion of children that are found in asystole. And typically studies have shown that it ends up being about 65% or more children are in asystole in the out-of-hospital setting. There have been a number of studies that have tried to tease out how we can improve cardiac arrest management in these settings. We know from in-hospital setting that early advanced airway intervention may not be advantageous. And indeed, in the out-of-hospital setting, it is infrequently performed. And success rates are extremely low, particularly in the infant age range. Studies suggest that bag mask ventilation may be better, and that longer scene times are often associated with increased survival, likely because we're delivering high quality CPR on scene rather than that scoop and run approach where, as I cited before, less than 1% of those children survive with favorable neurologic outcomes. We also know that even in children, a choreographed approach to cardiopulmonary resuscitation can lead to higher survival rates, where this study reported a 17% survival for pediatric out-of-hospital cardiac arrest. There are some clear factors that increase the chance of survival: bystander CPR, early compressions and effective ventilations, certainly high quality CPR with attention to compression depth and rate and minimizing interruptions, and certainly early defibrillation when a shockable rhythm is identified. But there are certain things that we could be doing better, and one of those for certain is bystander CPR and active assisted ventilations. In this study, they looked at children between the ages of 0 and 17, but separated between two age groups, 1 to 17, and those that are below 1 year of age. And they found that of the total number of children that were included in this study, that there was a higher rate of ROSC, higher rate of 1 month survival, and a significantly higher rate of a neurologically favorable outcome in those children who received bystander CPR. Additionally, they found that in that 1 to 17-year-old age range, conventional CPR, i.e. CPR with active assisted ventilations, is far better than compression-only CPR. Again, really speaking to the high proportion of these children that go into cardiac arrest because of respiratory failure. And if we can restore effective ventilations, improve oxygen saturations in the blood, then we have a high likelihood of being able to restore cardiac activity. In the infant age group, the impact of bystander CPR was less, but still advantageous in terms of overall survival and neurologic outcome when it was performed. And unfortunately, we know that bystander CPR is much less frequently performed in the pediatric population than the adult population. In this study, they looked at response times and delays to getting to the scene in children with out-of-hospital cardiac arrest. And for every 1 minute delay, they saw the potential for ROSC decrease by 5%. This study looked at 109 hospitals where the median age of the child was about 8 months. And they saw ROSC rates of about 20% overall. 60% of children who survived hospital admission and 9% who survived to hospital discharge. The median time to EMS arrival was about 10 minutes. And in those cases where it was unwitnessed, the median time to EMS arrival was much longer, about 30 minutes. Predictors of return of spontaneous circulation was the presence of bystander treatment before EMS arrival, the shorter time to EMS arrival, AED placement, so automated external defibrillators, and of course, epinephrine administration as demonstrated earlier. And similar to other studies, they found that older children pretended to have a higher survival rate, likely because our approach to them mimics much more of what we do in the adult population. Now, in the out-of-hospital setting, the question is much greater about how long should we be performing CPR in this particular population. And we see now that, similar to inpatient studies, that there is indeed a drop in likelihood of survival and favorable neurologic outcome as CPR duration continues. And the question is, at what point in time do we transport to the hospital, knowing full and well that there's less than 1% likelihood of a favorable neurologic outcome if we transport in active cardiac arrest? And so what this study did was to try to look at what point is it okay to perhaps stop resuscitation in these children in an out-of-hospital setting and terminate resuscitative efforts. And what you can see here depicted is when we look at all patients with survival and favorable neurologic outcome, that the time point, generally speaking, is closer to the 20-minute mark. And beyond that, we're unlikely to restore high neurologic function. Paramedics or pre-hospital providers really do experience a higher level of stress when it comes to pediatric cardiac arrest because the majority of them have only performed CPR in children very few times. Many have limited experience with terminating resuscitative efforts and how to talk to families. And many providers incorrectly believe that children have the same or perhaps even a better chance of survival than their adult counterparts. But we know that to be untrue generally. But overall, over half of pre-hospital providers felt uncomfortable with terminating resuscitative efforts in the field. That's all to say that we still need to focus on delivering high quality CPR on scene and working within the framework of our emergency care systems to decide what is most appropriate for pediatric patients who, despite 20 or 30 minutes of high quality CPR, fail to regain spontaneous circulation. Because of the challenges that are faced, there's now training on how to speak with families in the case of the loss of a child. It's called Compassionate Options for Pediatric EMS, or COPE. And in this training, they really try to help providers learn how to communicate to families in layperson language about the death of their child. It gives them the knowledge and the skills to help their families cope. And it also helps them to feel more confident in communicating the death of a loved one to a family member, since this is such an infrequent and challenging event. So the goal with pediatric cardiac arrest management is how do we begin to close the gap? When it comes to adults in hospital, out of hospital cardiac arrest, we've seen subtle improvement over the last several decades. But when it comes to pediatrics, particularly in the out of hospital setting, really no improvements. And in the in-hospital setting, some significant improvements when there are targeted quality improvement efforts that are implemented and real attention to how CPR is being delivered. But I believe that if we can leverage some of these best practices related to airway management, optimizing compressions, early epinephrine, early defibrillation, and improving the percent of children who receive bystander CPR, that we will indeed save 1,000 more children every year. And so these are, again, just some of those key highlights: optimizing or promoting bystander CPR, providing high quality CPR immediately, considering that choreographed approach to pediatric resuscitation, moving away from the scoop and run approach and racing to the hospital, but really staying on scene and providing high quality CPR, deprioritizing early intubation, including children in our termination of resuscitation protocols, and really beginning to foster family-centered care when it comes to communicating about the death of a child. And with that, I'm happy to take any questions. Thank you so much for the opportunity to talk about this important issue.
Thank you very much, Professor Remick. I think we'll leave the question till we finish from this session, because we are still having like 3 lectures ahead. Our next speaker is Professor Mohsen Saidi Najat, and he will talk about the state of the art of asthma and bronchiolitis management. As you know, Professor Najat, just briefly for those who did not know him, he's a professor of pediatric and emergency medicine, David Giffen School of Medicine at UCLA, Director Institute for Health Services and Outcome Research, the Lindquist Institute for Biomedical Innovation at Harvard, UCLA. Prof. Mohsen, you can start, please.
Nishad. I am a professor of emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA. I also serve as the director for the Institute for Health Services and Outcomes Research at the Lundquist Institute for Biomedical Innovation at Harvard, UCLA. And today I'll be speaking with you about state-of-the-art asthma and bronchiolitis management. I will first begin with a case scenario about an asthma patient. Then I'll give a very brief discussion of pathophysiology of asthma, talk about global epidemiology of pediatric asthma. We'll then get into the current state of practice in managing acute exacerbation of asthma. and then I'll add a little bit about technology and innovation in pediatric asthma care. And then for the remaining part of the talk, I will be speaking about bronchiolitis, start with a case discussion there, talk a little bit about epidemiology of bronchiolitis in children, as well as current trends in care of children with bronchiolitis, and a little bit about do's and don'ts of bronchiolitis treatment. So starting with my case, this is an interesting case we just very recently had in our emergency department. It was extremely challenging and very interesting. It was a 15-year-old male that was brought to the emergency department by pre-hospital personnel with acute asthma exacerbation, and he had received a single dose of albuterol by inhalation en route to the hospital. And so far, we see a lot of these. This is nothing unusual. On arrival to the emergency department, he was having difficulty breathing and had diffuse wheezing. And as you can see from his vital signs, he does have a little bit of tachycardia, a little bit of tachypnea, and his oxygen saturation is just at the borderline of acceptability on room air. In terms of his past history, he had a history of mild intermittent asthma that was already diagnosed. He has no maintenance daily medications that he is prescribed. He has no previous hospitalizations for asthma. And as I mentioned, he had 1 dose of albuterol en route. As he was in the emergency department and being assessed, he became very aggressive and started pushing one of the nurses to the wall. And then subsequently, he fell to the ground and became unresponsive. So I'll stop the case here. I'll come back to it and discuss a little more about this case. So asthma is one of the most, if not the most common chronic condition in children and accounts for a lot of hospital visits and admissions. It affects about 300 to 400 million people worldwide. In terms of mortality for pediatric asthma, the rate is somewhere between 0 to 0.7%, depending on where in the world and what severity of asthma. Asthma is a very heterogeneous illness. It is represented by several phenotypes, but in general, asthma is recognized as just being chronic inflammation, including a lot of inflammatory markers that are activated and result in the inflammation of the airway. This is a map of the world showing the burden of asthma. As you can see, asthma disproportionately affects different parts of the world. There's more asthma in the Americas and in Oceania and in the upper northern part of Europe in general. And the second map is going to show you the daily adjusted life years that are attributable to asthma. And as you can see again, certain areas of the world, there is more disability associated with asthma in children. And one of those being, for example, missed days of school and lack of symptom-free days. This table is very busy. I just wanted to point out that a very important comparison of asthma in 1990 versus 2019, right before COVID, generally, and if you break it by different age groups, the overall death rate from asthma from 1990 to 2019 has decreased. There's about 1/3 of the deaths that were in 2019 compared to 1990. But if you look at the incidence of the disease and the daily adjusted disability adjusted life years, those have not changed. If not, they have even gone up a little bit. But maybe we have better technologies, we have better ways to treat with medication. Our death rates are the ones that are impacted in a positive way, less deaths, but there's still more cases, and disability from asthma continues to be high. This is my obligatory one slide. Promise we're not going to get into too much detail on this one, but this is just pathophysiology of asthma. It generally shows that there are 2 major types of asthma. There are the eosinophilic ones, which are more prominent, more common, more complicated, and then there's a non-eosinophilic asthma. And as I mentioned, this is a heterogeneous group. It involves a multitude of different immune cells from mainly the T helper cells, but also B cells, mast cells, eosinophils, and the others. And basically, it involves the structural integrity of the bronchial cells, such as the epithelial cells and microfibroblasts and smooth muscles, that causes the disability and disease when it comes to asthma. Most common type of asthma is the type 2 inflammatory, which is an eosinophilic asthma with a lot of different cytokines predominating. So that includes activation of IL-4, IL-5, and IL-13, which is why the more newer innovations in managing asthma is targeting these interleukins for asthma relief. In terms of approach to pediatric asthma care, in the United States, we use two different scoring systems. Most hospitals use the pediatric asthma score. My hospital uses the same. We basically use that to determine the severity of our asthma in our patients. So as you can see on the left, these are different categories, and they differ by age in terms of respiratory rate and breath sounds and other factors such as retraction and dyspnea. If you score between 0 and 7, we consider that generally mild asthma. If you score 8 to 11, that's moderate, and 12 to 15 is severe. And that matters because we have different algorithms for managing asthma depending on your severity. And I'll just give you a simplified version of this. If a patient is deemed to be mild asthma, we usually start with 1 dose of inhaled albuterol, 2.5 or 5. I personally use 20 kilo weight as my cutoff. If patient weighs below 20 kilos, I give them 2.5. If they weigh more than 20 kilos, I give them 5. Some places use 30 as their cutoff. Dexamethasone, again, we always give to our asthmatic patients because they respond really well to a single dose of oral steroids. The dose is 0.6 per kilo, a maximum of 16. Again, my current practice is if the patient weighs up to 10 kilos, I give them 6 milligrams. If they weigh between 10.1 and 20 kilos, I give them 10 milligrams. If they weigh greater than 20 kilos, I give them 16. That takes away some of the calculation, makes it easier for me to figure out. So I have 3 doses only. Now, if a patient is moderate, we do the same as we were doing for mild, but we add ipratropium, either 250 microgram or 500 microgram. Again, 20 kilos of weight is my cutoff. And again, the same regimen for dexamethasone, that's what we do. And then if the patient is deemed to be severe asthma, we do add magnesium IV, and we give a infusion of 50 milligram per kilo to a max of 2,000 milligram. And that's our standard approach to the typical asthma that we get, mild, moderate, severe. And then the goal is that we treat them for about 2 hours, and after 2 hours, we make a decision whether they need to be hospitalized or discharged. That is ideal. We don't always get it that way, but ideally after 2 hours, we should be able to tell. And after 2 hours, if they still need further therapy, we will redo what we did for the first 2 hours. We might continue on albuterol. We obviously do not give additional dose of steroid at this time, and we do not give additional dose of ipratropium because the literature is very concording on the fact that ipratropium works best if it's given early. So terbutaline is one of our options. We basically give an intravenous infusion over 5 minutes or a subcutaneous infusion if IV is not available, but we definitely give a dose as intermittent. We don't give them as continuous terbutaline. There's no evidence to support efficacy of giving an ongoing continuous infusion, but you can repeat the dose every 15 to 30 minutes. Additional medications that you could use, but the evidence for that is completely mixed. Parenteral beta agonists, overall, they are not really indicated. Inhaled glucocorticoids, these are becoming more popular in the emergency department. We didn't used to use them at all, but as I say, we're now getting into the business of prescribing and doing inhaled glucocorticoids in the emergency department rather than just deferring it to the primary care doctor. There's also leukotriene receptor antagonists. We occasionally use ketamine on our sickest patients that are approaching refractory asthma. The evidence for ketamine is mixed. My personal experience with ketamine has been decent, but the literature doesn't really bear the significant improvement from ketamine. Heliox, also another way that we do. We have a new method that our hospital is using, which is delivery of albuterol by using a mesh, and we also use a high flow oxygen. These are additional things that are at our disposal. So when we get to refractory asthma, as I said, intravenous ketamine, here's the article that actually did a Cochrane database review on it, found that there wasn't really any evidence to really recommend it, is equivocal. Heliox, this article really goes through it really well. This is also a Cochrane review, does show Heliox is effective. It opens the airways. It decreases the asthma score much faster and reduces hospitalization if used in the emergency department. And then there is this other entity, which is anesthesia gases, which theoretically cause laminar flow and allow bronchodilation that way. In extremely sick patient who has been refractory to everything else, we have used anesthesia gas before. So just a little bit on this delivery by vibrating mesh. There's a really good article here on respiratory care that talks about how it actually improves asthma score. It decreases the total number of albuterol treatments that you have to give. We actually use it for our patients who have an asthma score of greater than 7. So if we start having them in a moderate range, we start them on the vibrating mesh. And the difference is that with vibrating mesh, after every dose, you reassess them. Usually for regular albuterol delivery, we don't necessarily reevaluate them until an hour of treatment has passed. This one, after every treatment, we do assess because they get better so much faster. And again, this study was a single-blinded randomized clinical trial of 217 children between the ages of 2 and 18 with moderate to severe asthma. They used the mesh versus regular jet nebulizer, and they found that the vibrating mesh resulted in fewer treatments, lower admission probability, and less time to reach mild score. So they also validate my personal thinking that we really enjoy using them in our emergency department. Then another, I'm just doing a little literature review now. So the next one was, we used to give prednisolone, then about, I'd say 15, 20 years ago, we started changing practice to dexamethasone after the Qureshi paper came out about how dexamethasone 2 doses was equivalent in efficacy to 5 days of prednisone with fewer side effects, fewer vomiting. So now the question is, since dexamethasone has such a long half-life, somewhere between 52 and 72 hours, should there be a need for a second dose, or should we just give 1 dose? And the reason this matters is because if you can actually give the patient a dose in the ER and then they don't have to go to a pharmacy to pick up a second dose, that improves, as a compliance issue that we're going to resolve by not making them take another trip to the pharmacy. So this study that was done recently found that a single dose of dexamethasone is not inferior to 2 doses in patients who are mild to moderate asthma exacerbation. Again, this was a prospective randomized single center study, 22 to 20-year-old children, mild to moderate asthma. The dose was, as we do in our hospital, 0.6 milligram per kilo, max of 16. 1 versus 2 dose, no difference in return visit, no difference in symptom resolution, and no difference in lost school days. So that was really a good validation that perhaps a single dose of dexamethasone in the ER is sufficient. Then we're going to look at what is the efficacy of ipratropium bromide. We know that we call it DuoNeb, that DuoNeb works better, but it's very hard to actually evaluate on the patient to see if they're actually working. So there was a recent meta-analysis that was published out of China, and this was one of the very few ones I saw that actually was, approached this topic with a nice meta-analysis format, randomized controlled trial of children less than 18. And they looked at all studies that were published up to 2020. They had about 55 studies that met the inclusion criteria with over 6,300 patients in it. They found that adding ipratropium to albuterol actually reduced hospital admission rate. And in a subgroup analysis, this reducing hospitalization was more significant in moderate and severe. And the ones who are mild, that difference wasn't so pronounced, which is kind of what we do with our practice. In a mild one, we don't use ipratropium. Moderate, severe, we do. So essentially, adverse outcomes, there was no difference between the 2 groups. So it wasn't the adverse outcomes that drove one or the other decision. Then question of epinephrine versus beta agonists in acute asthma. So I personally, I'm a user of epinephrine IM in early on cases of patients who are having trouble with air entry. So if I listen and I can't hear any air movement and I see respiratory distress, I give IM epi. Not everybody does it that way, but the question is, what is the comparative efficacy of epinephrine versus just jumping right into albuterol? So this was a meta-analysis of children and adults. The primary outcome was treatment failure. So they compared intramuscular epinephrine to inhaled beta agonists, and they found that there was really no difference between the two. Epinephrine treatment failure was lower in studies that included adult patients in their population, because this was a both adult and a children's study. Now, I want to share something really exciting. There's a research project that we had started in our institution. It was funded by the Blue Shield of California Foundation, or as a health insurance company, big company in the United States. We are doing the study at Harbor UCLA Medical Center, Pediatric Emergency Department. That's where I work. We are enrolling children between the ages of 5 and 18 who present to the ER with asthma exacerbation. And the inclusion criteria is that you are getting discharged from the ER and you're getting prescribed an inhaled bronchodilator beta-2 agonist and or an inhaled steroid. As you can see up top there, the sensor looks like a bottle cap that is GPS enabled and it's Bluetooth connected, and it attaches to the top of the inhaler. So every time you click on it to use your inhaler, it registers use. So you can actually connect that to a mobile device. And we at our hub center, we can actually see activities. We see which of our patients use their albuterol at what point, which of them use their inhaled steroid at what point. And then when they come back to the ER, we can actually share with them their pattern of use. They can choose to turn off the GPS location or they can leave it on. So the GPS location, the idea behind this proof of concept for us was that if we can see where they were when they used their albuterol, then we can get some Google Analytics on the location at the time to see what the temperature was like at the time, what kind of pollutants in the environment, and help build a biological profile of their specific asthma so we can treat them. So it's really, really exciting study. We're still in the middle of data collection for that. The study follows each patient for 1 year, and that is because the little battery in the sensor lasts for about a year. So really, really exciting. Hopefully at one point I can share our study outcomes for that. The last part of this medication management of asthma I wanted to talk about is the escalating of the pediatric asthma care using anesthetic gas that, it's a very uncommon thing to do, but when somebody is refractory and doesn't respond to anything else, literature had suggested that anesthetic gases could serve as the last line of defense. So I was looking at studies that look like at what anesthesia gases will do for life-threatening asthma. So this is a small sample size because there's not a lot of kids that end up that way. 7 children between 4 and 13, they were admitted in the Netherlands, this is a Netherlands study, to 2 pediatric ICUs with their PCO2 level range at the start, after 2 hours, and at the end of sevoflurane treatment, as you can see, decreased a significant from 14 to 9.8 to 6.2. Their median pH also increased from very acidotic to normal, and the peak pressure values declined from 30 to 20.4, and there was no severe adverse effect except for hypotension, which obviously these patients are intubated, and you can fix that hypotension with norepinephrine as needed. So that was a promising study, but I would say this is a difficult situation. You have to have an intubated patient, you have to have an operating room, you need to have anesthesia available. So it is really a last line of defense, but it does work. So back to the case that I talked about, the 15-year-old that had mild intermittent asthma, no prior major hospitalization, that came and suddenly fell to the ground and became unresponsive. So this patient, immediately we began bag mask ventilation. He was very difficult to bag, and his end-tidal CO2 ranges were very high. As you can see, his blood gas is also showing the same. His PCO2 was 98. His bicarb was elevated because he was compensating for his respiratory acidosis. O2 saturations, we really could not get him above 77%. That was really challenging. We gave him methylprednisolone as opposed to dexamethasone for quick action. We gave him IV magnesium. We gave intramuscular epinephrine, which is, like I said, what I like to do a lot. Endotracheal intubation because he was having respiratory failure. He was difficult to bag, and we had really no other option. As you know, we don't want to intubate asthmatics unless we absolutely have to. And this patient was basically decompensating and becoming more and more concerning, so we had no choice to do that. We also used ketamine for his rapid sequence intubation because, again, the ketamine hypothetical bronchodilatory effect with rocuronium. We intubated him. O2 saturations continued to be a problem. We still couldn't get him ready. I had heard about this use of anesthetic gas. So since anesthesiology was at bedside and ET tube was correct placement, no leaks, and we couldn't ventilate, I asked him, is there any chance we can get sevoflurane for this patient? And lucky for me, he is one of the only anesthesiologists who is agreeable to something like that. He said, sure, we'll do it. So they took the patient up to the operating room to start on sevoflurane. He remained on that for about 4 hours in the operating room and gradually began improving. Then he was transferred to the ICU, stayed there in a couple of days, then I was discharged finally from the hospital, full recovery. This was a bad case of a type 2 inflammatory asthma. This was probably the sickest asthmatic that I have ever had. Not ever, but in the last few years at least. So this was proof of concept that anesthesia gas was going to work. And again, I wanted to look at the literature to make sure that this was actually evidence behind it. So a couple of quick notes about asthma in Saudi Arabia. I was just looking around the internet trying to see if there is any interesting articles or anything like that I can find. And I ran into this really cool initiative, the Saudi Initiative for Asthma. And this has it's a comprehensive document that really provides guidance on how to diagnose, how to manage, and how to care for children and adults with asthma. If you haven't seen this, I really recommend it. I don't have time to go through all of it, but I think this is a really, really great resource, and it's local to you guys, and it's a really nice resource. In terms of asthma prevalence in Saudi Arabia, it looks like overall the prevalence of asthma in Saudi Arabia is anywhere between 8 to 25% among children, and depends on what region you're looking at. And there's this really nice article, The Burden of Asthma Among Children and Adolescents, basically looks at variation in geography. And this map here shows areas where asthma is more prevalent versus areas that are not. And I thought this was really great because just like anywhere else in the world, prevalence of a disease is not universally the same. There's various factors that come into it. I would assume, again, there are many causes of something like this, but I assume some of it has to do with rurality, with how dry it is, how windy it is, pollens in the air, access to medication, income level, and things like that, which is always the case for asthma, because as I said, it's a very difficult, it's not a one disease that you can figure out what to do about. It has a very customized, tailored to each person kind of properties. So again, last thing about type 2 inflammation I wanted to say is this global initiative for asthma called GINA that has a lot of great information about asthma. It actually recommends using biological agents such as anti-IgE, anti-IL-5, IL-4 treatments for really, really refractory case of asthma. Again, I did not really want to highlight these too much because we don't use these in an emergency department setting. These are more like ongoing care. And also the anti-IgE medications are becoming more common, one of them being the omalizumab, which is for refractory asthma used in children. And this was the very first targeted biological therapeutic that was approved for refractory moderates to severe asthmatics. But it was approved for children over 12 and for adults. And this article here, actually, there was a study that looked at efficacy and safety of this medication, and they found that this could be safe and effective in children as young as 6. So hopefully that will be something that's also available to younger children. But there's a lot of these biological, biomarker-related treatments that are up in the horizon. I don't think any of them is going to make it to the emergency department anytime soon, but these are for ongoing management of asthma. So now I'm going to shift gears to talk about bronchiolitis in the last few minutes that I have. So 8-month-old female comes into the ER in the wintertime with respiratory distress. As you can see, tachypnic, febrile, tachycardic with hypoxia. Diffuse wheezing on exam, use of accessory muscles, but most importantly, she looked very dehydrated and cap refill time was 3 seconds, so moderately dehydrated. And per history had fever symptoms and cold symptoms for the past 2 days and become more respiratory distress today. So bronchiolitis is one of the most common causes of admission among pediatric patients during the winter months. 150 million new onset bronchiolitis cases are reported each year in the world. Admission rate is 2 to 3%. In the United States, we have approximately 100,000 bronchiolitis hospitalizations per year. RSV is the most common cause of bronchiolitis, with parainfluenza virus and metapneumovirus being the others. It worldwide 3.2 million hospitalizations and 60,000 deaths in children who are less than 5 years of age. And majority of them, between a third to a half of them, will go on from the bronchiolitis and end up with persistent airway hyperresponsiveness, suggesting that possibly there's an inflammatory contribution from bronchiolitis that also persists. In terms of management of bronchiolitis, the state-of-the-art management, the take-home lesson from all of this is that there is really no magic bullet for this. You provide feeding, hydration, oxygen delivery. You use minimum nasal suctioning, no more than 3 to 4 times a day, and minimal handling. Don't avoid agitating the baby. Hospital admissions for oxygenation and for monitoring only. High flow oxygen is a consideration. Hypertonic saline has been tried with variable success. There's some literature that actually supports it and some that didn't find any difference. But bronchodilators definitely have not shown any promise, and the American Academy of Pediatrics does not recommend their use. I know some physician, based on their previous practice, say, well, you know, it might work, so I'm going to give a dose. If it works, I'll use it. If it doesn't work, I won't give another one. And systemic steroids, definitely, this is the Cornelli article from a few years back that found that there's absolutely no benefit to the use of steroids, and it's not worth the trouble. And racemic epinephrine for really, really severely bronchiolitic patients does provide short-term benefits, but it's not going to be sustainable. It's just for the very sick ones very early on. And then the next thing is what is going to be the combination of effects of nebulized epinephrine with hypertonic saline in infants with bronchiolitis. The combination therapy, the combination of the two shows a decrease in overall length of stay, and showed within 48 to 72 hours a lower overall score, but there was no difference in oxygen saturation, and overall there was low rate of adverse events in combination of the two, with mostly any symptoms that I was finding was going to be mild and transient. So there is no problem with using the combination of those. Again, they're not recommended for every patient. There are considerations for the ones who actually have a little bit more distress and look more sick. And question of high flow oxygen versus regular oxygen. This study published in British Medical Journal found that in a multi-center randomized control trial, that there was really, and it's a 5-year study, there was really not a whole lot of difference between low flow and high flow oxygen in terms of outcomes, adverse effects, supplemental intervention, and hospitalization. So even though I personally like high flow oxygen, and I feel like if a child is on it for a few hours, they'll turn around and get better, but the literature does not really support that a great deal. And this is actually a very good study, big scale, 5 to 6 years worth of study, and good study methodology, and it's a randomized control trial. So I believe that the outcome is that there's not a lot of difference between high flow and regular nasal cannula oxygen. And then use of corticosteroid in asthma in bronchiolitic patients who end up developing later asthma. This was a study of almost 2,500 children that were admitted for bronchiolitis. They were prescribed corticosteroid, and it actually showed longer length of stay after being on steroids. But among the previously healthy children with moderate illness, it did show some benefit, but the ones who had severe illness or mild illness, corticosteroids did not seem to help. Overall, there's no recommendation for ER-based to use corticosteroids in the management of bronchiolitis. And this study was early use of bronchodilators, and a multi-center study of under 12 months of age. You know, we define bronchiolitis, classic bronchiolitis, as age under 12 months. So they look at 49 children's hospitals, almost 9 years worth of study, primary outcomes were ICU admissions, hospital admissions, ED returns, and invasive and non-invasive ventilation. They found that use of bronchodilators early did not affect any of those outcomes. So there was no use in starting bronchodilators early. Again, big size study, big power, and it's really clear findings that use of bronchodilators did not really help babies with bronchiolitis. So back to the case, this patient who was 8-month-old with dehydration, highly febrile, tachycardia, tachypnea, wheezing, comes in with cold symptoms. We initially focused on antipyretics, hydration, oxygenations. We did lab viral panel and urinalysis because there are studies that show that even with bronchiolitis, UTI bugs don't respect bronchiolitis, so they show up with the same frequency. So if you have RSV, that does not mean you cannot have a UTI. So every child who's hyperpyretic, who meets the criteria of under 1, female under 1 with the hyperpyrexia, we do urinalysis. That urinalysis did come back negative. The viral panel was positive for bronchiolitis. She continued to have increased vocal breathing and hypoxia, was started on oxygen and IV hydration. Monitoring, was admitted, no bronchodilators, no steroids, no racemic epinephrine. She stayed in the hospital for about 48 hours, recovered fully, and went back home. So just to summarize, asthma is one of the most common chronic diseases of childhood, affects a lot of children, heterogeneous, part of a heterogeneous disease. The mainstay of therapy is steroids and bronchodilators, although many other medications are useful. Bronchiolitis, the take-home lesson is just supportive care, oxygenation, hydration. There's no need for steroids or bronchodilators. Evidence doesn't suggest high flow is any better than low flow. And that's it. Thank you very much. If you have any questions, please feel free to contact me. My email address is mohsenmd@gmail.com. So mohsenmd@gmail.com. Thank you so much.
Thank you very much, Professor Mohsen. We will also collect all the question in the question and answer box, please. And for the question and answer yesterday, it is ready. It will be on the screen, the answers after the last lecture today. I mean, after the next lecture during the break. Our next speaker now is Dr. Tim Driven. He will talk about upper airway emergencies. You can start, please.
My name is Tim Driven, and I'm a pediatric emergency medicine faculty member at Cincinnati Children's Hospital Medical Center. The title of my talk is The Management of Upper Airway Obstruction. It's an honor to present to you today. My funding is shown here. I have no conflicts of interest to report. I want to thank Josh Nagler, who's the Fellowship Director at Boston Children's Hospital and is a pediatric airway expert, for providing some of the content for these slides. The objectives of today's talk are to use a series of cases to make teaching points about upper airway obstruction. I want it to be relevant for everyone. This includes a focus on common and high acuity etiologies, also to discuss approaches to specific management issues, highlight potential pitfalls. So now we're going to start with case 1. This is an 11-month-old with upper respiratory symptoms for 2 days. The patient awoke with gasping for air, was stridulous, and had a barky cough. The parents report that the patient has a history of croup in the past, but the family says that this presentation is worse than prior presentations. Back to case 1. Again, we have an 11-month-old with barky cough and stridor. On exam, the patient was febrile, had a normal saturation, the oral pharynx was clear. There was noted to be inspiratory stridor at rest. There were moderate retractions, including belly breathing and intercostal retractions. So what would be the treatment at this time? The patient was given racemic epinephrine, given there was stridor at rest, and also oral dexamethasone. There continue to be residual stridor despite the first treatment of racemic epinephrine. So what are the next steps in the management of this patient? The patient gives an additional racemic epinephrine, and also neck films were obtained. The AP and then the lateral neck x-ray is shown here. And as you can see, there is that steeple sign, or the narrowing or the pointy finding, which is consistent with croup. So this slide is, I think, a really helpful thing to kind of show why young kids are predisposed to croup, but also why young children, especially infants, are predisposed to upper respiratory obstruction when they get edema of their airway. On the left, the circles show an adult airway, and on the right is an infant airway. And what this table demonstrates is what would happen if there was 1 millimeter change in edema on airway resistance. So the first column shows the change in cross-sectional area by this 1 millimeter change. In an infant, this would result in a 44% decrease in the cross-sectional area, and this would then result in a 200% increase in the resistance. And that's why young children, especially babies, when they get croup, are going to be stridulous, whereas an adult, they would not be. Whereas an adult, if you get that same change in cross-sectional airway, it would just result in a 25% decrease in cross-sectional area, and then that would result in a 40% increase in resistance. So, adults, when they, get the same virus that a kid would not develop stridor. As I noted before, in this case, the patient had a reassuring oxygen saturation. When I have residents present to me, I always ask them, oh, is this a reassuring sign for you or not? And they usually say, yeah, this is reassuring. And I say, yeah, it's better that the saturation is normal than not normal. But a reassuring oxygen saturation or a normal saturation does not tell you that the patient does not have potentially life-threatening upper airway obstruction. This is just a review of some of the etiologies of hypoxemia. There's V2 mismatching, shunting, diffusion defects. There can be decreased FiO2, and then there can be severe hypoventilation. So the one thing that we always want to reiterate to our trainees is that severe hypoventilation with profound upper airway obstruction can result in hypoxemia, but that would be a very late finding and an ominous finding. There can be plenty of patients who have pretty significant upper airway obstruction that still have normal oxygen saturations. Again, infants are incredibly at risk of this, given that they have a smaller airway to begin with, and even a small amount of change in their edema and the caliber of their airway can lead from partial airway obstruction to complete airway obstruction. So if there's a bad saturation abnormal, again, very late finding, very concerning, need to intervene. But a normal oxygen saturation does not mean that the patient is fine. So that's why the oxygen saturation always has to be used in combination with other signs and symptoms and physical examining findings and potentially laboratory evaluation as well to assess adequacy of oxygenation and ventilation. So the treatment for patients with stridor at rest, obviously they get racemic epinephrine, Decadron. They're usually observed for 2 to 3 hours post that racemic epinephrine to make sure there's not a recurrence of symptoms necessitating a second dose of epinephrine. Patients with stridor just with agitation, where when they're calm, they're not stridulous, they get Decadron or do not require observation. And then those patients who may just have barky cough, no stridor, frequently in our emergency department, they get Decadron and then go home. Steroids can be oral and intramuscular. Both routes are equivalent. Some patients who aren't going to tolerate the oral, we give intramuscular epinephrine, which works very well. Radiographs of the neck for routine croup are not indicated, but they may be indicated if there's concern that there could be, airway foreign body or potentially another etiology that may be concerning to the clinician, such as tracheitis or something else that may predispose to similar or overlapping presentations. Now I'm going to move on to case 2. This is a 4-year-old, previously healthy boy who presents with 2 days of fever and anterior neck pain. There's pain with swallowing. There's no drooling. And then 1 day prior to the presentation, there was noisy breathing, and the patient also had abdominal pain. The patient was seen by their primary care provider, and they had negative testing for both strep and influenza. The patient awoke, though, on the time of presentation with an increase in noisy breathing The patient was also had inability to lay down, which worsened their respiratory status, and the parents noted a change in the patient's voice. The child threw up one time. The past medical history was unremarkable, and all immunizations were up to date. Now moving on to the physical exam, the patient was febrile, tachycardic, tachypnic, a saturation of 96%, and that was on room air. He did look uncomfortable, slightly anxious in the sniffing dog position. Sniffing dog position with the patient sitting upright in the position of comfort, leaning forward with their chin extended forward. And these are the patients that we always say when they come into our trauma bay, we reiterate to everyone, whether it's the respiratory therapist or trainees, that there's always this inclination that people want to put the patient supine. We always say, please keep them in their position of comfort. We always try to minimize painful procedures, given that that may provoke or aggravate their underlying respiratory condition. The patient was managing his secretions well. There was neck tenderness anteriorly to palpation, and there was a little bit of faint stridor notice when you auscultated the chest, but it was not significant stridor. There was the chest was clear on auscultation. There was no wheezing, and the patient had a normal cardiac exam, and it was warm and well perfused. In this patient, AP and lateral neck films were obtained, giving concern about an upper airway involvement. This is the lateral neck X-ray. As you can see, this lateral neck X-ray is pathognomonic for epiglottitis. There are three characteristic features: a swollen epiglottis, thickened epiglottic fold, obliteration of the vallecula as well. Because normally the epiglottis is a thin, curved silhouette that kind of looks like a bent finger, but here you can see how thick it is. Back to kind of management of critical upper airway obstruction or, concern for this. Most hospitals, including ours, have a critical airway protocol. Here, if we are worried that there's an upper airway obstruction or a need for emergent intervention, we have a page that goes out, and with that page, anesthesia comes to the bedside, as well as ENT as well. And then they can decide there. They have a cart that they can use for advanced airway maneuvers, or they can decide if it would be best to manage the patient in the operating room, where they can do a controlled induction. It's also important, though, that in some scenarios, you may not have access to subspecialty care, so the emergency department clinician needs to be able to be prepared to manage the airway if the patient's condition continues to deteriorate. This includes having appropriate materials at the bedside and planning for worst-case scenario in case the patient cannot be intubated from above. So this includes consideration of what would happen, what materials would be needed if the patient required an emergent cricothyrotomy. Back to our case, the patient was taken to the OR for laryngoscopy, and this is the appearance of the epiglottis that was thickened, indurated with mottled erythema. There were edematous retinoids bilaterally. The glottis, though, was unremarkable, and there was no subglottis or no obstructive lesions or masses in the subglottic area. So this confirms the diagnosis of epiglottitis. The culture grew back and was positive for H. flu type B. The patient was remained obviously inpatient and remained intubated in the intensive care unit for 4 days, and then was transitioned to the floor. The patient required intubation for 3 days while the edema decreased, and then when the patient was extubated, ENT was at the bedside just to make sure that there was no complication with extubation or the patient didn't need reintubation, and fortunately that went beautifully. The patient was initially treated with IV Vanco in unison and then transitioned to ceftriaxone when the microbiology and susceptibility were back, and completed a 14-day course of this antibiotic regimen. He also received 1 day of IV Decadron as well to help with airway edema. Now moving on to case 3. This is a 2-year-old who choked on a hairpin while with a babysitter. The parents report that the coughing and choking lasted about 15 minutes, but it did resolve with back blows. The parents were very astute and knew what to do in this situation. However, the parents later noted that the patient had a hoarse cry and noisy breathing. In the emergency department, there was mild distress but no drooling. There was expiratory wheezing and stridor at the upper chest, and there was no wheezing at the bases with good aeration bilaterally. So what was the next steps in this patient? This patient was stable, but there was high concern that the patient could deteriorate based on the significant exam findings, including the wheezing. Chest X-ray was obtained. You can see here that's remarkable for that hairpin. And the next steps in this was before the X-ray results were even obtained or resulted, ENT was consulted given the concern that the patient would need to go to the operating room for definitive management, given that there was concern that there was an airway foreign body. The decision was made in consultation with ENT and anesthesia, who came to the bedside as well, that an IV was not placed in the emergency department to avoid crying or agitation, which could provoke or worsen the patient's underlying respiratory condition. However, if a patient was at a facility without an ENT or ability to go to the operating room, it would be prudent to place an IV, given that in case that a respiratory or the patient's status would deteriorate, you would need IV access to administer resuscitative therapies. The patient, like I said, was taken to the operating room, and there they found a hairpin lodged in the left mainstem bronchus. After the removal, there was a little bit of erythema in the posterior and left and upper tracheal wall. Fortunately, there were no perforations or purulence, and there was some edema of the tracheal lumen, about 10%. So this was a very fortunate outcome. So to place an IV or not, I mentioned this, that classically we're taught with patients with concern for upper airway obstruction and critical airway, including epiglottitis, not to place an IV given it could worsen the respiratory status. However, there becomes a point, and there are some situations where there's not the ability to take the patient to get to definitive care, or patients status deteriorates so quickly that life-saving interventions have to be initiated, including potentially CPR and emergent airway procedures. And in that situation, it's vital to have IV access to administer those therapies. So frequently, we teach our trainees here and our fellows that they should not hesitate to put in an IV. They need to be cautious about it and have a conversation, but if the patient needs an IV, that they should go ahead and do that while being prepared to monitor the patient's respiratory status, and when placing the IV, to try to maintain the patient in their position of comfort. I want to also bring up that a couple of these cases have brought up patients with stridor on inspiration, stridor with on expiration, and to help use that exam finding to help localize the site of the obstruction. And classically, we're taught that inspiratory stridor, such as a patient with croup, is consistent with an extrathoracic obstructive lesion, where if you have expiratory stridor with wheezing, it's more consistent with an intrathoracic or obstructive lesion, whereas if you have biphasic stridor, it may be in a glottic or subglottic or a fixed narrowing, so it's not dynamic. So if you have a foreign body in the glottic region, that would result in biphasic stridor. So these exam findings are very helpful for when we're assessing patients, especially in our trauma bay, that you can make rapid decisions to try to say, where is the site of the obstruction, who do I need to call, and then what do I need to prepare for in case the patient deteriorates. Now moving on to case 4. This is a 2-year-old with a witness choking episode while eating peanuts. The patient was stridulous in ambulance, and they actually called us ahead of time to say they were transporting this patient, and the patient choked, and they were in respiratory distress. So we were prepared to meet this patient in the resuscitation area, and we're also prepared in case the patient did have upper airway obstruction. The patient did come into triage with respiratory distress and was immediately moved to the trauma bay. And just as you go to see the patient, you notice that the stridor stops, the patient turns cyanotic and slumps over, which is an ominous finding. And this raises the concern that the patient had partial upper airway obstruction with stridor, and then when the stridor stops, that obstruction has now moved to a complete upper airway obstruction, which is consistent with the patient turning cyanotic and a change in the mental status. So this patient requires emergent intubation, and is probably one of the most concerning, frightening cases to deal with as an emergency department clinician. So what are the next steps in this patient? I just want to review a foreign body airway algorithm here that highlights the most, a very logical approach. It seems very reasonable and makes a lot of sense, but in the stress of the moment where there's a lot of chaos in the scene, it's always helpful to have this in the back of your mind to know how to manage this, and also how to guide the team that is trying to save a child's life. So from the top, you can see if there's a partial obstruction, there is no need for an intervention. Sometimes doing more can result in worsening patient's condition, can worsen their stress, anxiety. So those patients should go emergently to the operating room. If there's concern for complete obstruction, such as in this patient where they become cyanotic, there's no longer stridor, you need to do emergent relief measures, whether it's back blows or chest thrust, and hopefully that relieves the obstruction. If there's no relief with those maneuvers, you need to use laryngoscopy and to try to remove the foreign body if it's in the glottic area. Hopefully that's successful and the patient can be admitted and observed. However, if that's not successful, you'll need to use bag mask ventilation or potentially a supraglottic device. If that's successful, the patient should still go to the operating room. However, if that still does not work with the bag mask ventilation, you'll have to try to intubate and potentially advance the foreign body to bypass the obstruction. This is just another algorithm kind of showing how to proceed, and the clinician always has to be made aware of if they would need to be able to do a cricothyrotomy and what procedure would be appropriate for which patient age. In children less than 12 years of age, you would have to do a needle cric, and older patients may be candidates for surgical cricothyrotomy. And I do want to bring up the important point that hardly any pediatric emergency medicine doctors that I know have ever performed this procedure. It's something that we do in simulations, but in the moment, it would be usually someone's first time doing this procedure under an incredibly high-stakes situation. Advancing the tracheal foreign body. This was on that prior algorithm that I showed. And what the concept is that if you have an airway foreign body here that you can visualize in the trachea, you're passing the endotracheal tube, and you're trying to force that foreign body into the right main stem bronchus so that you can then ventilate and oxygenate through the left bronchus. A little stressed after talking about that case. Let's move on to case number 5. This is a 5-year-old who developed a staccato cough, facial flushing after eating a cookie. Who knows what's in that cookie? Maybe there were some nuts. The patient had some stringy vomiting. On exam, they're afebrile, they're a little tachycardic, blood pressure looks reassuring, so does their respiratory rate and their SATs. There is noted mild lip swelling or tongue swelling, which kind of clues you into, could this be an allergic reaction? There is stridor at rest. No wheezing though, the lungs are clear to auscultation bilaterally, and there's no increased work of breathing. And then skin exam is consistent with diffuse hives, which also kind of clues you into could this be an acute allergic reaction, and specifically anaphylaxis with the respiratory involvement. And anaphylaxis is one of those conditions that fortunately resolves very well with epinephrine. Most reactions respond to at least to 1 dose of epinephrine. About 10% of reactions require 2 or more doses of epinephrine, and it's very rare, less than 5%, that need 3 or more doses. However, there are some patients that are refractory to anaphylaxis, and it's incredibly important for clinicians to be prepared for that patient with upper respiratory obstruction from anaphylaxis to decide early in the course whether that patient is going to require definitive airway management with placing an endotracheal tube. And the worry is that if you wait too long, the patient's condition can deteriorate. They can have become hypoxic, their ventilatory status can worsen, and the airway edema can be worse as well, which would make placing an endotracheal tube more difficult. So one of the hardest decisions to make is that you have to be prepared for the patient's condition to worsen and to try to intubate that patient earlier in their course, which will optimize your chances of a successful intubation. Also, when intubating these patients, again, managing their airway early is better than waiting too long. That's different than some conditions where you are confident that it's going to be responsive to the therapy and that you have time to see if the therapy will work. That's an important thing also to note with something like anaphylaxis or conditions that are going to have more airway edema, is that when you're planning to intubate those patients, you need to have endotracheal tube sizes that are downsized, anticipating that there's going to be airway edema, and you may have to place a smaller tube than originally planned. This just reiterates that important point about expectant versus early intubation or early intubation. It's helpful in these situations to have your critical airway team at the bedside. There are some conditions where you have to intervene right away. There's some where you think that you may have time to intervene to wait, that it could be worse, but it can be done in a controlled setting. And then there are those conditions, like I said, with like anaphylaxis or even burns, where you know that if you don't intervene early, the underlying pathogenesis is going to lead to a worse situation where it may be a harder intubation and the patient's condition may worsen. So conditions with burns or anaphylaxis or even trauma, that's why it's a good idea to try to intubate those patients earlier rather than waiting. So we've now gone over these cases that hopefully will illuminate some important teaching points in the management of patients with upper airway obstruction. So some key points: stridor. Inspiratory stridor is usually extrathoracic, whereas expiratory stridor is consistent with intrathoracic obstructions. Normal oxygen saturation should not be reassuring. It's better than if the saturation is abnormal, but that it does not preclude a patient from having a partial upper airway obstruction, or that patient won't progress to having complete upper airway obstruction. Foreign body aspiration always has to be on your radar. Young kids will not tell you that they choked on something frequently. So with every patient that I have with croup or with signs of upper airway obstruction, even if I think it's unlikely, it's always a routine part of my history to ask parents about, is there any possibility that they could have choked on something? Have you witnessed them choking? And then also we always have to say, if someone's not following the expectant course of our treatment, they're not responding, to get further imaging or diagnostic modalities to make sure that we haven't missed something. So if a patient's not responding to those therapies, to get an X-ray to make sure that there's not a foreign body that we could have missed. For patients with partial obstruction, they can be challenging to manage because it's a high-stress situation. Patients are having trouble breathing, but we want to make sure that our interventions do not worsen their underlying respiratory condition. So these patients, every effort should be made to keep the patient in their position of comfort, to minimize painful procedures, and to try to expedite the patient getting to the operating room where they can get definitive treatment. However, there are those situations where there may not time to get into the operating room, may be delayed, or the patient may need to be transferred, where a clinician then needs to make the determination that there has to be an IV placed or other interventions done to make sure that that's done in a safe manner. Epiglottitis is very uncommon, but it's not gone. So clinicians still need to have it on their differential, and they should always be familiar with their critical airway protocols at their institution. And then anaphylaxis. Yes, most cases of anaphylaxis are not life-threatening, but clinicians need to be attuned to those signs and symptoms that portend a more severe course. So patients with stridor, that's rare, but if they occur, if a patient has stridor and the patient's not getting better quickly with epinephrine, they need to be prepared to intubate that patient early so the disease does not progress. That's the same with patients with burns or trauma, that early intubation in some situations is the correct management strategy. I want to thank you for being able to speak with you today. It's been an honor. Please reach out with any questions that you may have. Have a good day.
Thank you very much, Dr. Driven, for this important information regarding upper airway emergencies. Our next speaker will be Kathleen Adeliges, and she will talk about approach to respiratory failure in children. You can start, please.
Hi, I'm Kathleen Adeliges, a professor of pediatrics and emergency medicine at the University of Colorado and Children's Hospital Colorado. And in this talk, we're going to discuss the approach to respiratory failure in children. You've heard about severe bronchiolitis and asthma from Dr. Mo Sadinejad. You've also heard about the approach to the child with upper airway obstruction from Dr. Driven. And now I'm going to cover pediatric respiratory failure and what to do when all of your other efforts start to fail you. The objectives of this talk are to review some of the causes of pediatric respiratory failure, which aren't always respiratory in nature, to understand the anatomic and mechanical features of the pediatric respiratory system, to review options for managing respiratory failure in children, and finally to discuss best practices for rapid sequence intubation in the emergency department. Respiratory failure is defined as the rate of gas exchange between the atmosphere and the blood being unable to match the body's metabolic demands. It's an important cause of morbidity and mortality in children, and respiratory arrest remains the most common cause of cardiac arrest in children. The causes of respiratory failure are numerous, including primary respiratory causes, the ABCs of pediatric respiratory disease, asthma, bronchiolitis, and croup. However, there are non-respiratory causes, including upper airway obstruction, such as anaphylaxis or foreign body. There can be catastrophic metabolic diseases, such as sepsis and diabetic ketoacidosis, trauma resulting in head injury or hypovolemic shock, and primary CNS issues, including stroke, metabolic encephalopathy, and or CNS infections, can all be a cause of respiratory failure in children. It's important to understand the underlying cause because the underlying cause is going to impact how you proceed to manage these patients. It's also important to note that in general, infants are not very efficient breathers. They do not have as many alveoli at birth. The number of alveoli is exponentially grows over the first couple of years of life. Their chest wall is very compliant, which causes a decreased elastic recoil and exhalation to work. And children can be abdominal breathers. As the diaphragm goes down, it pushes the abdominal organs out, but the chest wall pulls inward. The chest wall of children is also more box-like, with ribs already horizontal, unlike adults where the ribs are angled down and lift up, acting as a bellows. They have limited lung expansion as they breathe and limited tidal volume increases. And also the muscles are not very rapid twitch fibers, which also means that the fatigue leads to respiratory failure easily. Let's present a case. EMS is transporting a 3-year-old male with a known seizure disorder for a seizure. They gave an intranasal benzodiazepine and obtained vascular access. However, he continues to seize, and on arrival to the emergency department, you need to administer an additional benzodiazepine intravenously, and the seizure stops. He's postictal, and his oxygen saturation is 87%. So what do you do next? First things first, let's talk about basic oxygen delivery methods. There are various flow systems, including low flow and high flow. The standard nasal cannula is good generally for infants and offers approximately 24 to 45% inspired oxygen with flows between 0.5 to 2 liters per minute. The simple face mask increases the amount of inspired oxygen up to 50% and can be given in flow rates of between 6 to 10 liters per minute. The non-rebreathing mask can deliver up to 90% oxygen with typical flows between 10 to 15 liters per minute. And the Venturi mask, which is very common and seen in the slide over here on the left, is a cone-shaped mask with different ports that can allow a tailored delivery of more precise oxygen concentrations. It's really important to be goal-oriented and not procedure-oriented when we're thinking about how we're going to support ventilations in children. The goals are adequate oxygenation and ventilation, and also to not do harm. Adequate oxygenation and ventilation can really be achieved by multiple methods. Non-invasive options include bag mask ventilation, heated high-flow nasal cannula delivery, and continuous or biphasic positive pressure airway, such as CPAP and BiPAP. Invasive options involve supraglottic airways and endotracheal intubation, often done as rapid sequence intubation in the emergency department, assuming that most children have not fasted before they became sick and required advanced airway management. Let's talk about those initial options for ventilatory support. Heated high-flow nasal cannula. This is an option for delivery of oxygen with a little bit of nasal cannula pressure. You can give between 1.5 and 2 liters per kilogram. However, it's critically important to warm and humidify the oxygen as it's being delivered. It works best when it's started high and can recruit ventilatory and tidal volume in the child, and then weaned down as needed. Often the flow and not the fraction of inhaled oxygen is actually what is benefiting the child, and it can be as effective as other positive pressure modalities if you can adequately occlude the nose. Other options include positive pressure airway management as a whole, CPAP and BiPAP. What this allows for is a dead space washout, which is critically important when we are trying to recruit dead space in the lungs, either from something such as an obstructive disease, such as asthma or bronchiolitis. The air also needs to be heated and humidified here, and that can help thin secretions, and it can potentially increase tidal volume. Importantly, this type of airway support can stabilize the chest wall. What's critical to know in these children is that they must have intact airway reflexes, so they must be awake in order to be on these types of ventilatory support. And how do you know it's working? The decreased, mainly you're going to see a decrease in your respiratory rate and overall work of breathing, and hopefully you'll see improved gas exchange. The decrease in oxygen delivery and maintaining, but at the same time maintaining pulse oximetry saturations is one example, and also an improvement in CO2 retention relative to the tachypnea. Which brings me to capnography. Capnography is a critically important way to do monitoring of these patients with early respiratory failure. Whether you're doing bag mask ventilation, endotracheal intubation, or supraglottic airway, the end tidal CO2 often tells you more than just about the lungs. You will see a low end tidal CO2 in children with diabetic ketoacidosis, given the degree of generalized acidosis and their exhalation of CO2 as a compensating mechanism. A rising capnography is a good sign of early respiratory depression and soon to be apnea. So it's not just the actual plateau of the CO2 number that you're looking at, but it's also critically important to evaluate that waveform. And when you see the waveform start to rise greater than 10 milligrams of mercury, it's a sign that they are likely to go apneic soon. So learning capnography is a very important skill, and being able to interpret not just the end-tidal CO2 value, but also the waveform is critically useful to supporting these children. As this case progresses, your patient's respirations become more sonorous. His respiratory rate drops to 6, and his oxygen saturations drop to 75%. So what do you do next? This is a case of respiratory failure. And again, it's critically important to be goal-oriented and not procedure-oriented. So our recommendation is to choose your weapons carefully. The options for advanced airway management carry significant risk. There's a risk of increased hypoxia and/or hypotension. There can be detrimental effect on ventilatory techniques following intubation, and repeated attempts or prolonged interruption of chest compressions, particularly in those patients who require cardiopulmonary resuscitation. Supraglottic airways are one potential device to use for advanced airway management, and they're more commonly used in the out-of-hospital environment and also by anesthesia. There is some data that there is potential utility in the emergency department, particularly in a patient with cardiac arrest, as it will potentially reduce hands-off time. It's also useful when you anticipate a difficult airway to ensure that you're able to effectively ventilate. The other nice thing about supraglottic airways are they're relatively easy to learn and have a very high first pass success rate. But intratracheal intubation is truly the ultimate procedure that is done to support the airway in the patient who is in respiratory failure. There is a time and place for everything, and intubation may be a benefit in certain scenarios. It provides longer-term airway protection. It also allows you to place the patient on a ventilator. And then finally, it allows for tracheal suctioning. However, you need to consider the reason intubation is the answer before you decide to intubate. You have to also ensure that it's going to be appropriately timed during any resuscitation. And then finally, as a program as a whole, you should ensure that you have a high quality improvement program to really track your intubations, your success, to set yourself and your team up for success every time. Pediatric airways are different. Be prepared. Pediatric airways are small. They have a large tongue relative to the size of the oral cavity that can make visualization of the back of the posterior pharynx difficult. They have large heads and occipits, which naturally flexes the head forward and kinks off the airway. They also have an anterior airway. So as you have a kinked airway, it's also harder to see when you're putting in the laryngoscope. They have a floppy epiglottis, and they have a short trachea, often resulting in right mainstem placement of the endotracheal tube. All of these are factors that make pediatric airway challenging and difficult. And given the utility of positive airway pressure support, such as BiPAP and CPAP, we find ourselves doing intubation less frequently overall. And that is the reason that you must be really prepared and really thoughtful as you move towards this in your emergency department. So if you think you're ready to intubate, you should guess again. This is an example of a simple key driver diagram for reducing adverse events in one program at Children's Hospital Colorado. The Breathing Easier team took it upon themselves to look at all the factors involved in preparing to do intubation in the emergency department. And their take-homes were that education, the need for familiarity with the equipment, the variability in medication choice and dose, the variability of staff in the emergency department, the infrequency of the event, and the unreliable documentation of safety events were all things that needed to be standardized before we could really ensure a high quality intubation program in our emergency department. So there are 5 top ways to avoid any pediatric airway complications. Number 5, resuscitate before you intubate. Number 4, maximize oxygenation. Number 3, be prepared. Use tools you have to support success. Number 2, aim for a single attempt. Number 1, know and use your backup options. Resuscitate before you intubate. This was a multi-center study done in the US among 8 large children's hospital pediatric emergency departments where they reviewed cardiac arrest events around intubation, and they found 5 main factors that were all associated with a peri-intubation cardiac arrest, including the presence of hypotension, the presence of any cardiac dysfunction, any persistent hypoxemia, any acidosis with a pH of less than 7.1, and in patients in which there was cardiac arrest and they now had had return of spontaneous circulation. In this multi-center study, patients meeting any one of the high-risk criteria had an 11% risk for cardiac arrest in the emergency department around this intubation, and long-term, a 25% in-hospital mortality. It's critically important that you ensure euvolemia and good perfusion pressures to the heart before you proceed to intubate, that you've corrected any acidosis to the best of your ability, and that you've corrected any hypoxemia as well. So maximizing oxygenation, this is a graph on apneic oxygenation showing in 4 different kinds of patients how long they will keep their oxygen saturations up with pre-oxygenation. The curve that goes out the longest is the normal 70-kilo adult, where they are able to maintain their oxygenation up to 10 minutes with 100% pre-oxygenation before intubation attempt. The moderately ill 70-kilo adult can maintain their oxygenation for about 6 minutes. However, you can see that the normal child and an obese adult will only maintain their oxygen saturations up to about 4 minutes out. So apneic oxygenation, which has become the mainstay of preparing for intubation of adults, does not provide as much benefit to children, but still a critically important thing to prepare and do for your patient. And again, being prepared. The Breathing Easier team, after their key driver diagram and identified multiple different factors, really sought out to standardize the equipment process for the emergency department. They created an airway by Brownlow chart. And as an example here, they matched the color of the Brownlow with both what should be gathered and then also a small diagram that is placed on the intubation tray to ensure that the respiratory therapist at the bedside gets all of the necessary equipment and is prepared. They also developed and use a checklist. The checklist walks the team through team roles, the risk of a difficult airway and the risk for peri-intubation arrest, underlying diagnoses, a medication plan, a backup airway plan, a post-intubation plan, particularly for sedation, and a timeout reminder. The other key thing in this checklist is just the preparation of the patient itself, including ensuring there's a shoulder roll under the shoulders to ensure that the occiput is not causing an anterior kinking of the airway, making sure the head of the bed is clear, the monitor in place, access is in place, the chest is exposed, there's pre-oxygenation, there's capnography, and frankly, that there's a backboard and Zoll pads in the event of a cardiac arrest. In being prepared, you also have to be thoughtful about your medication choices for rapid sequence intubation. For the sickest of patients, those with sepsis, the key induction medications are ketamine and fentanyl. This is not a patient that you're going to give etomidate to. Rocuronium is the paralytic of choice, and it's also recommended to use adjuncts such as atropine. In asthma or primary respiratory disease, ketamine is also your go-to for induction medications given its bronchodilating effects. And then in trauma, etomidate is the drug of choice. What about rocuronium and the fact that it's not typically reversal? Sugomedics is now available as a reversal agent as needed. And succinylcholine, however, does still have a role in intubation of the child. The pros are that it's very rapidly reversible. And if you think you have a difficult airway, this might be the drug of choice for you. It can also be given intramuscularly in the event that you don't have access. However, there are multiple contraindications, including burns, any chronic muscle disease, or risk for malignant hypothermia. And so given that there's now a reversal agent for rocuronium, there are very few reasons for why you would need to use succinylcholine in the emergency department. It's very important to aim for a single attempt. What will happen if you have to have multiple attempts at intubation of a child in the emergency department? First, ill children have very little pulmonary reserve. They have rapid oxygen desaturations and can become easily bradycardic. The longer time than it's expected to recover from oxygen saturations mean that you are taking even longer to get somebody pre-oxygenated. And this is a patient who now has a paralytic on board and is not able to breathe on their own. There's also a risk of developing atelectasis and a need for lung re-recruitment. And you have to be very prepared for making appropriate changes to the ventilator, including prolonging the inspiration time on the ventilator and also increasing your end expiratory pressure, which could ultimately result in barotrauma. The other thing is that there are faster desaturations on subsequent attempts. So even though you've done that pre-oxygenation, you often don't have as long before their oxygen saturations begin to drop with every attempt that you have to make to intubate a child. Let's talk a little bit about the role of videolaryngoscopy. The evidence is a little mixed, but there is some suggestion that it may help with getting to that single attempt. First, the Cochrane review that was performed did show that the videolaryngoscopy may lead to a prolonged intubation time with an increased risk of failure. However, this review was done some time ago, and the reviewers did note that there was very poor quality evidence in making this conclusion. Subsequently, a study by the NEAR for NEOS group did a multi-center study of NICU videolaryngoscopy for intubation of neonates. And in this study, they found that videolaryngoscopy was not associated with the first attempt success, but was associated with fewer adverse events. In follow-up to that, a video-assisted laryngoscopy study for pediatric tracheal intubation in the emergency department found that there was high variability with the use of videolaryngoscopy across sites, but among those sites where it was used regularly, there was an increased odds of first attempt success. So in other words, if you are choosing to bring in a videolaryngoscopy program to your emergency department, you should make sure everyone is trained on it and use it regularly, and there is likelihood of increased success in your setting. Finally, it's very important to know and use your backup options and predict the difficult airway so that you have anesthesia at the bedside or ENT or others who are able to help you. Anatomic factors associated with difficult airway at baseline for children, even above how children have smaller airways and are already considered difficult, is a high body mass index, a Malapati score that shows poor airway posterior pharynx ability to see. The inner incisor distance can also impact the risk of a difficult airway. But what was found in this study was that the frontal plane to chin distance to be the most commonly associated with a difficult airway. You can see this across all age groups, including infants, toddlers, and children, where as the frontal plane to chin distance went down, or was smaller, the airway was more difficult to obtain. So in summary, pediatric respiratory failure is uncommon, but a very high-risk situation. There are lots of tools in your toolbox to optimize outcomes. And again, be goal-oriented and not procedure-oriented. Use the right tool for the right condition, and you'll always be successful. Thank you so much.
Thank you very much, Professor Kathleen. And I think we should go now for a brief break. And we will start after the break. I already made the answers, and I put it in the screen for all the questions of yesterday. And our speakers, they are nice enough to answer all these questions. So if you have any more question, you can just send it in question and answer box, and we will continue giving you the answers. Okay. Now we'll take a break for just like 10 minutes, and then we'll be back soon at 10:10, please.
We'll start our first speaker, Dr. Prof. Mariana Ghosh-Hill. She's a professor of the clinical emergency medicine and pediatric. Prof. Ghosh-Hill, she's the director of the emergency medicine medical service and director of the AMS and pediatric emergency medicine fellowship at Harbor Oakland Medical Center in Torrance, California. She's nationally known for her work as a AMS researcher and educator, and for her leadership in the field of the pediatric emergency medicine. She will speak about very important approach for that patient. He's presented with the multi-system trauma in your department, and how to approach for this patient. Welcome, Prof.
My name is Dr. Marianne Ghosh-Hill, and I'm professor of emergency medicine and pediatrics at David Geffen School of Medicine, and the interim CEO and president of the Lundquist Institute for Biomedical Innovation. Today, I'm going to talk to you about approach to multi-system trauma in children. Let's get going. First of all, I have nothing to disclose. Today, we're going to discuss the approach to critical pediatric trauma. We'll outline CT imaging and other imaging modalities, including ultrasound, and discuss some of the limitations and utility of labs in the pediatric trauma patient, as well as I will describe the National Pediatric Readiness Project and its impact on outcome for injured children. First of all, as we know that injury is the leading cause of death in children, and there's really 3 peaks of injury death. And this is seconds to minutes, and really the only strategy that's effective is going to be prevention. The next is something in our wheelhouse as emergency physicians, and this is secondary prevention. And what that means is once injuries occurred, we want to prevent any secondary injury, and thus rapid resuscitation, being ready to care for children is going to be critical. And then finally, days to weeks, and this is early definitive care, to trauma centers, nursing care to prevent multi-organ failure. All right, probably the most important things we think about initially is airway management. Obviously, if the patient is hypoventilating or hypoxic, critical to add oxygen therapy and also to support ventilation. Hyperventilation is only indicated for children who are demonstrating herniation syndromes. The next is going to be blood loss and hypotension, and we'll get into this in a second, but blood transfusion is going to be critical, and use of TXA may be helpful. Hypertonic saline can be used for patients with severe brain injury to assist in the edema that occurs secondary to injury, including axonal injury. Imaging will talk about seizure prophylaxis, and one always has to consider child maltreatment. All right, the H's, these are going to be critical in terms of control. Hypoxia, hypotension, hypo or hypercarbia are all deleterious, and we know this in the care of the trauma patient. In addition, hypo or hyperglycemia should be controlled. I will state that it is not uncommon for children after trauma to have hyperglycemia. Typically, this is going to be less than 250. All right, some of the guidelines that are important for traumatic brain injury management is maintaining oxygen saturation. And what that level is not entirely clear, but I would state somewhere above 92%, probably even higher. So adding supplemental oxygen is not necessarily deleterious, and empiric oxygen may be appropriate, especially for children with multi-system trauma or significant head injury. The data thus far demonstrate that maintaining normocarbia is going to be critical. And the only time to consider hyperventilation would be, again, in herniation syndromes. We want to maintain the hemoglobin above 7 grams per deciliter. If at all possible, maintain the head in neutral, a midline position, and as soon as able to elevate the head approximately 30 degrees. ICP monitoring if the GCS is less than 8, and you would work with your neurosurgeons for this. ICP treatment if there's elevated ICP, and again, this would be in conjunction with neurosurgery. And then cerebral perfusion pressure target is greater than 60. And really that's critical to maintain mean arterial pressure in order to maintain cerebral perfusion. And then again, normal glycemia and normothermia. In regards to the herniation pathway, if there's signs of herniation, pupillary dilatation, hypertension, bradycardia syndrome, or posturing, especially extensor posturing, these may be indications to consider hyperventilation. And you would do that with 100% oxygen. The other thing would be bolus of hypertonic saline, and somewhere between 3 and 5 mils per kilo, and then emergency CT. So in terms of airway management, there's a few myths, and I'll talk about that and what the current recommendations are. If the GCS is less than 9, the indication really is to consider rapid sequence intubation, and certainly hypoventilation or an unprotected airway, you would consider rapid sequence intubation in those settings. You should start fluid resuscitation immediately, because as you add a neuromuscular blocker that decreases the adrenergic drive, and that can result in either bradycardia or potentially cardiac arrest. So starting fluid resuscitation or transfusion with blood products, especially in critically injured patients, is recommended. In terms of RSI, Etomidate could be used as a sedative. It has a pretty good cardiovascular profile in terms of change in BP. Ketamine may be used even with head trauma because it maintains cerebral perfusion pressure. And you see the dosing there on the slide. And then one could use either succinylcholine, and I recommend for children 2 mg per kg versus the 1 mg per kg that we use for adults. And the reason is children metabolize succinylcholine fairly quickly, and so you may not achieve paralysis by the time the airway is secured. Rocuronium also could be used, and that's because we do have a reversal agent now with Bridion or Sugamedics, and then followed by either midazolam and fentanyl for drip for continued sedation. In terms of hypertonic saline, the recommendations now favor the hypertonic saline. I said, approximately 5 mils per kilo. You can do that over 20 minutes. Typically, we do that with severe brain injury, and it should be considered if the GCS is less than 9. In terms of seizure prophylaxis, prophylactic treatment is suggested to reduce the incidence of early, and this is within the first week, post-traumatic seizures. And there really isn't great evidence to recommend one drug over the other. Levetiracetam or Keppra can be used, as well as fosphenytoin. Hypotension is to be avoided at all costs. We know this. Hypotension is a predictor of patient outcome, meaning that a patient, even if it's transient hypotension, decreases discharge rate 4-fold. And the most sensitive time period is in the first 6 hours. So supporting blood pressure with 20 mils per kilo, you can use normal saline or Ringer's lactate, and then move quickly to blood products. It could be 10 mils per kilo of packed red blood cells or 20 mils per kilo of whole blood. An absolute indication for transfusion would be a hemoglobin less than 7. Although you may consider it even before that. And the goal would be to get the hemoglobin, let me back up 1 second, to be 10 milligrams per deciliter or greater. What about massive transfusion protocols? There's no great data to suggest it improves survival. However, there is this significant concern if it's not initiated. And so typically we would, if the estimated blood loss in 24 hours is the total blood volume, you can see in terms of infants, children, adolescents, what the total blood volume is relative to weight. And then certainly you would consider replacement of greater than 50% of total blood volume in 3 hours. So we would give it 1 to 1 to 1. So packed cells, platelets, and generally FFP or cryoprecipitate could be used. In terms of the shock index, there's definite evidence that utilizing the shock index may be helpful in identifying early on adult patients that are going to have significant morbidity or mortality. The shock, there is some evidence, there's a number of studies here that I've placed on the slide, but there may need to be an adjusted, so pediatric age adjusted shock index, or SIPA, is generally what's recommended. And the SIPA was shown to really perform better and identify the most severely injured children following blunt trauma over a shock index. Typically we use for adults, if the heart rate is greater than the systolic blood pressure, that indicates a shock index that is not favorable for outcome. But the shock index, pediatric adjusted, you can see would be based on age, because infants, as an example, tend to be have higher resting heart rates. And this is why an age adjustment is so important. What about tranexamic acid? There are few data in children, but likely similar findings. I'll talk about this in a second. It can be given 1 gram if the patient is 12 or older. The actual dose for younger children, it's not clear. Some use 15 milligrams per kilo intravenously over 10 minutes. And then an infusion of 2 mg per kilogram per hour over 8 hours or until the bleeding ceases. This was a nice review done by Dr. Borgman and Nishijima from UC Davis, looking at tranexamic acid in pediatric hemorrhagic trauma. And there you can see the review of a number of studies. I've got them up here. There was 2 retrospective studies and 1 prospective study. And there's some indication that it provides benefit in terms of lower mortality for children. Really, it is critical to do either a randomized trial or a large clinical trial to fully understand the impact of TXA on pediatric trauma outcomes. Would we use it? I would say yes, especially patients with multi-system trauma with significant hemorrhage. Fluid resuscitation is critical. I mentioned 20 mils per kilo. You can do rapidly ×2. Blood transfusion, absolute indication less than 7, hemoglobin less than 7. And for females, you would use O negative blood and O positive for males. 10 mils per kilo is what could be done. And again, TXA, it's not clear, but we would consider using it. Now, in terms of blood tests, you know, in the beginning, they're not very helpful. Obviously, trending hemoglobins could be more useful. Certainly, we would get a hemoglobin in the beginning. Obviously, any multi-system trauma patient, we'd want to get renal and liver function tests, electrolytes, lipase, of course, glucose, coags, and lactate. Lactate may be helpful, again, in trending. A UA for patients with any deceleration or multi-system trauma to look for significant hematuria, and for females, pregnancy test. And then tox screen or alcohol level really as indicated. This is a study looking at 5 variables as a clinical prediction rule for identifying children at low risk of intra-abdominal injury after blunt trauma. And I think this is really helpful. Complaint of abdominal pain, abdominal wall trauma, tenderness, or distension. And you can see a seatbelt sign demonstrated in the right corner. Abnormal chest x-ray, abnormal pancreatic enzymes, and then an elevated liver function test. And an elevated liver function test in conjunction with an ultrasound may be useful. How about the head CT? Certainly penetrating trauma, GCS less than 15, although the Canadians might argue with you on that. We typically, if it's 14 or less, would get head CT. Post-traumatic seizure, and as you know, children suffer impact seizures, but at this time, there's no evidence that the CT can be avoided in those settings. Basilar skull fracture, palpable skull fracture, or significant mechanism. This is the clinical decision rules for CT imaging. And it's a nice graphic for this. This is for children under 2. This was the large pediatric emergency care applied research network study of over 42,000 children. This is the only decision rule for head CT that really has a significant number of children under the age of 2 in it to guide our management. So when you look at it, if the GCS is less than 15, there's skull fracture, altered mental status. If you have yes to any of those, of course, do a CT. And there's about a 4.5% risk of significant TBI requiring intervention. If none of those are present, but they have scalp hematoma, loss of consciousness, they're not acting normally per parent, or there's a severe mechanism, and you can see the definition here. If there's yes to any of those, then you have an option. This is intermediate risk, so the risk of a significant TBI is less than 1%. So an option is to observe them. How long you observe them, it's not entirely clear. Some would observe 2 to 4 hours in the ED and then make a decision. If none of those are present, CT is not indicated, and you can observe and or discharge home with instructions. And again, you're going to have to use judgment. Some of the clinical factors used to guide decision-making, if there's multiple or isolated factors, worsening findings, as an example, severe headache, vomiting, and again, less than 3 years old, because the ability for the skull to be, with any impact, to be deformed is a high risk factor for intracranial injury. So you have to use judgment with any of these. This is for children over 2. There's a few differences. You can see if there's yes to anything indicating a basilar skull fracture or altered mental status. CT is indicated, and you can see the risk there. If those aren't present, but there's significant vomiting, loss of consciousness, severe headache, or severe mechanism, and you can see a fall greater than 5 feet, and some of the severe high impact object, such as a baseball or anything like that. If any of those are positive, then again, it's intermediate risk, and you have the option to observe versus CT. And again, using some of the clinical risk factors here that could help guide decision making. So if none of those are present, I would say the signs or symptoms or severe mechanism, if none, you can observe, and the risk is really pretty low. And one might consider, again, 2 to 4 hours in the ED and see if there's worsening signs or symptoms, then you might reconsider the CT. So this is a small study at a singular site, but I think it's nice because they did education, they did repeated interventions in order to reduce inappropriate CT scans for children. So you can see because of the interventions, and I'll show you this, they showed a decline after the initiation of the guidelines and the training, reduced charges, so significant savings over the time period, and almost 150 children were spared excessive radiation. So they did guideline implementation, they did some resident training within a web app, so that was launched, that includes the criteria. They did resident training again as well, not only the head, but cervical spine, and did direct feedback. And you can see how they lowered pretty significantly the rate of inappropriate scanning. All right, so in the past, we used C-spine plain films. We know that you can miss significant fractures with that, but we want to try to prevent inappropriate scanning in this particular population. At this point in time, we do not typically do any plain films, but just do CT imaging. So in terms of the decision rules, you can see there's a nexus that was published. It's really an adult study, very few. The Canadian C-spine rule, again, you're going to see some similarities and some differences. And finally, the PCARN rule, We typically, in our pediatric ED, use a pecan rule. So if they have one or more of the risk factors, then imaging is indicated. If they have none, then no imaging is indicated. And so you can see altered mental status, focal neurodeficit, you can see complaint of neck pain, torticollis, substantial torso injury, so a patient that has a significant mechanism enough to have injury to the torso may be enough to consider that it's a severe mechanism with high kinetic injury to consider imaging. And then predisposing conditions, this might be a patient, as an example, with Down syndrome or juvenile rheumatoid arthritis that may have abnormal C-spine anatomy, a high-risk MVC, and then diving, so an axial load. So here's my proposed approach to C-spine imaging in children. If under 3 years, it really at any age, if the patient is obtunded or significant head injury such that there's altered mental status and you're doing a CT of the head, I would do a CT. And then I would consider in a child under 3 to go to the top of C3. That's typically what we do if they're getting a CT of the head anyway, and the GCS is less than 15. If it's a normal exam and low mechanism, a young child, I would just examine. If there's neurologic abnormality, again, all of the rules suggest doing CT or MRI. And then I would CT if they were ejected, they have torticollis, substantial torso injury, predisposing factors. And again, I mentioned if we're going to obtain a head CT. You can apply for 3 to 8, the Nexus or Pecan rule, and greater than 8, the Nexus or Canadian rules can be used. If those are negative, you can remove the collar. If it's positive with neural findings, of course, CT, and positive without neural findings, meaning you apply the rule and there's no neural findings, I would consider a CT, and positive without neural findings, plain films may be used as a screen. However, I would say in our shop, we typically would go to CT. So let's talk about PAN scans for a minute. And as we go through this, PAN scan, one of the biggest problems is that a patient with multi-system trauma comes in and the trauma surgeon wants you to scan everything. But we try to be a little bit selective, based on mechanism of injury, what you find on physical exam, and the utilization of plain films, let's say chest x-ray, may be helpful in limiting what CT scans can be used. As you can see, chest CT increased 7-fold in the last 15 years, and this is typically due to PAN scans. The key is to establish protocols, and it's really those who have very high risk of injury. The other to consider, because of the mobile mediastinum in a child, that a severe deceleration, fall from a great height, head-on collisions, as an example, are severe deceleration injuries. And we'll get back to this in a little bit as well. So utilizing protocols are going to be critical here. What about use of ultrasound? This was published in JAMA 2017 by Dr. Holmes at UC Davis. And really, they looked at the utility of the ultrasound in trauma patients to really help in discerning intra-abdominal injury. And they found that really in hemodynamically stable children, that utilizing the FAST compared with just standard care didn't improve clinical care. it didn't include clinical care, use of resources, length of stay, and really did not help significantly in terms of missed abdominal injuries. So they say that do not support the routine use if indeed they're hemodynamically stable. That is, again, FAST could be used in the hemodynamically unstable patient. So how do we increase the sensitivity of the FAST? Combining it with physical exam, so evidence of significant abdominal tenderness as an example, along with elevation in liver function tests, AST and ALT, can increase the sensitivity and specificity. And I think that's important. It's kind of multimodal in terms of utilization of the FAST. Some of the issues in terms of the management of trauma, and I just wanted to bring this up, so some of the errors that are made are missed cases of non-accidental trauma, missed blunt cerebrovascular injury. As an example, you could have a cerebrovascular injury such as a dissection. This can occur with torsive mechanisms, and they often present with vertigo. And then the other error that's made is overuse of CT scans. So using clinical decision rules, both for head CT, abdominal CT, and chest CT. Missed small bowel injuries. Remember, children who are belted can result, if they have a chance fracture as an example, or basically a seatbelt sign. This is something to consider. And children that have signs of significant abdominal injury, even if this abdominal CT is normal, could still have small bowel injuries. And those are generally observed with serial exams. And oftentimes you can pick it up within 24 hours. And then unrecognized hemodynamic stability. I'd be remiss if I didn't talk about the National Pediatric Readiness Project in the United States. It's an effort to ensure that all EDs are ready to care for children, and there are guidelines. You can see the reference there. And what has been shown is that in high-ready hospitals, those who score 88 or above, and the National Pediatric Readiness Project, have 2 times less or half the mortality of non-ready hospitals. Children treated in high readiness trauma centers after injury had not only a lower risk of death initially, but it persists for a year. And the American College of Surgeons has made a decision to include readiness as part of their standards. The last thing I would say is incorporating trauma-informed protocols. This is addressing pain and anxiety with the IV access. And so you don't need to place an IV on every trauma patient. The other thing is you can reduce pain with that. You really need to gather and make a decision whether urinary catheter, rectal, or genital exam are necessary in children, because it causes undue stress, support of the family, and then engage again with the family and the PICU team. So here's our conclusion. Trauma is the leading cause of death in children. Targeted resuscitation, obviously to prevent secondary injuries such as control and modification of hypoxia by adding supplemental oxygen, hypotension, hyperventilation, only with signs of herniation. That the shock index with pediatric age adjustment may assist in recognizing significant injury. TXA is still not prime time, but is a consideration. Utilize decision rules, ensure your ED is pediatric ready, and initiate trauma-informed care. And with that, I will stop. I'm going to go ahead and turn on my video. And thank you so much. I appreciate the opportunity to be able to speak to you today.
Thank you, Prof. Mariana. Actually, this is very informative lecture.
Hi there. My name is Dr. Mary.
Next speaker would be Prof. Mahsen. Prof. Mahsen Said Injad he's a professor of emergency medicine and pediatric at David Giffen School of Medicine or at Oakland. He is also serves as the director for the Institute for the Health Service and Outcome Research at the Landquist Institute for Biomedical Innovation at Harvard, Oakland. He will speak a very important topic about mental health emergencies in the children. Welcome, Prof.
I'm a professor of emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA. I also serve as the director for the Institute for Health Services and Outcomes Research at the Lundquist Institute for Biomedical Innovation at Harvard UCLA. Today, I'll be speaking with you about mental health emergencies in children. Global health-wise, mental health is one of the most important problems facing the healthcare system. So my content outline will start a little bit on the global burden of mental health in children. I will speak a little bit about inequities in pediatric mental health throughout the world, the role of COVID-19 in the worsening of mental health problems. Then I'll shift into the United States struggles with mental health issues, as well as infrastructure challenges that we face here. Then I'll talk a little bit about the rising problem of suicide among children. I will then share with you some resources from the Emergency Medical Services for Children that I have been involved with creating, specifically mental health resources related to suicide and agitation. And then I'll close by talking a little bit about the new mental health policy statement for children, which is a joint policy statement between the American College of Emergency Physicians, the American Academy of Pediatrics, and the Emergency Nurses Association. So 1 in 7 children between the ages of 10 and 19 worldwide are experiencing some form of mental health condition that meets certain criteria for diagnosis. Mental health disorders also account for years lived with disability and disability-adjusted life years. As many as 50% of all mental health disorders begin in the children younger than 15 years of age. And we also know that mental health affects certain groups within the population disproportionately. Worldwide, suicide is one of the most common causes of death in children between age 10 to 19. It's number 4. And we also know that COVID has had a negative impact on mental and behavioral health problems by creating additional anxiety, depression, suicidality, sleep disorders, and things that really have to do with lockdowns and social isolations. And also an important point to consider is children with mental health issues will take those issues far into their adulthood. This is the map of the world looking at disability-adjusted life years for 100,000 attributable to mental health. So 100,000 people per 100,000 people in 2019. So if you look at the map, the majority of that is the colors of red and orange, and those are the ones with the greatest effect on daily adjusted life years impact from mental health. And considering that many of the countries probably are underreporting, there probably should be much more areas of red and orange than actually is. So this could be a little bit more significant than even this map shows. So one of the problems that we have encountered with mental health is that mental health is becoming more complex. Children who have mental health, they show up earlier, they show up more frequently, and they have comorbid conditions that go with their mental health. Some of them stem from their social environment. So this is a problem that continues to increase in its scale. But the healthcare system infrastructure to support mental and behavioral health is not expanding to support this. So at the same time that you have increasing demand, you have same supply, maybe even decreasing supply in many cases. And as I mentioned, a lot of times due to some social factors, stigma associated with being diagnosed with a mental health disorder, mental health is underreported. Sometimes it's not even reported. So the problem could be even bigger than what we see. And the impact of COVID-19, there's a great deal of literature showing how COVID-19 adversely affected mental health of children, especially because of the lockdown and social isolation. But we're only a couple of years out of the height of COVID. So many of the impacts related to COVID are yet to be fully understood. Also, areas where there is less access to mental health professionals, such as rural areas and lower income urban neighborhoods, are disproportionately affected by the problem of mental health. Specifically, adolescents who live in countries that are low to middle income are vulnerable, but at the same time, we don't have much data about how they are dealing with this. 90% of over 1.2 billion adolescents that live in the world live in one of these middle to low income countries, where only 2% of the mental health data is available. And there's very few randomized controlled trial research going on for us to better understand what has occurred in those societies. And as I said again, social factors, the stigmas are much more popular and more common in low to middle income countries, where societal pressures to hide mental health is very prominent. In addition to that, because of lack of access to resources and education, pediatric mental health continues to go unchecked and unrecognized in many cases. There's also no sufficient funding for infrastructure development and for education programs to build interventions. In addition to all of the other things I mentioned, there are specific considerations with respect to gender, race, gender identity, neurodiversity, family structure. For example, if you live in a group home, or if you live in a foster care facility, if you're incarcerated, or you're a new immigrant to another country, you are more likely to have mental health related issues. Going back to COVID, I think it was pretty clear that COVID had a negative impact on mental health, but it is thought that the majority of this has to do with children needing to have routines. They need to wake up in the morning, look forward to school. They need to go to bed at a given time. They also need to go outside and play. They need to have face-to-face interaction with their friends. They need to have communications within the family. And a lot of this was lost during the lockdown periods. But we learned that not only that COVID affected children in a negative way, but there are certain groups of children who are disproportionately affected. Namely, girls were more affected than boys by mental health issues, and the adolescents were more affected than the younger children. So if you're an adolescent female, you had the highest rate of increase in mental health problems during the COVID pandemic. Now, I want to talk a little bit about the United States. We probably have it much harder in the United States than many other countries. The problem is much more significant. In the United States, about 1 in every child has a diagnosable mental or behavioral health condition before the age of 18. Suicide is the second leading cause of death in the United States between the ages of 10 and 24. But the scariest part is that now suicide is creeping into the top 10. It's becoming a top 10 cause of death in children as young as 5 to 9 years of age. These are children who are in kindergarten, in elementary school. I have a child in this age group, and it's very scary to think that I have to worry about something like that. And we also know that pediatric mental health problems during COVID increased in terms of emergency department visits, 24% between the ages of 5 to 11, and those who were adolescents, there was a 31% overall increase. And as I mentioned, adolescent females were disproportionately affected. We also know that additional problems such as anxiety, depression, and agitation have also increased during this period. This is a map of the United States access to mental and behavioral health. So this map looks at the number of psychiatrists for every 100,000 population in the United States. This is not child psychiatry, but it is all psychiatrists for all individuals, adult and children. The areas that are in gray are counties within the United States where there is not one professional psychiatrist who's licensed that's practicing. So as you can see, more than half, and actually 55% of all counties in the United States do not have a single licensed psychiatric professional. If you take this to the pediatric psych and look at a map of child and adolescent psychiatrists per 100,000 children under 18, you see a lot more gray even here. About 75% of all counties in the United States do not have even one trained, licensed psychiatric professional who cares for children specifically, so pediatric psychiatrists. This graph that comes from the American Academy of Child and Adolescent Psychiatry was the one that actually brought this home for me, made me better understand what the problem was. If you look at the United States, there are 75 million children under 18 who live in the United States. And for all of those children, there's roughly just over 10,000 child and adolescent psychiatrists that are available. That means for every 100,000 children, there are only 14 licensed child psychiatrists. And if you look at the graph near the bottom, you see many of the states in the United States don't even have 14. The only one that's in the green is the Washington, D.C., District of Columbia. But the rest of the country is not having sufficient coverage. And depending on what studies you look at, to cover the needs of children with mental and behavioral health, we would need somewhere between 50 to 100 child psychiatrists for every 100,000 patients, children. So that means we're probably needing sometimes between 5 to 10 times as many as we currently have. This map also, again, on the left, you will see the two maps. The one on top shows where the children are who have healthcare, mental health care needs. So the darker it is, the more that state has mental health care needs. The one in the bottom left is the one that says which states have less children with mental health who get the cares they need. For example, the dark blue one, those states in dark blue, and Texas, for example, in the middle down is one of those. Somewhere between 50 to 75% of the children in that state with mental health problems do not get the services that they need. And if you look at the map to the right, that is shortage area, where all of the counties in that state are shortage. The entire country, with the exception of the west coast of the United States and the northeast of the United States, is a shortage area for mental health. This is similar to the map I showed you before, where the grays were the only areas where it had less gray was the west coast and the northeast, big cities of the United States. There was a study recently published by a good friend of mine that talked about the importance of getting follow-up by a psychiatrist after an ER visit. So she looked at almost 30,000 children between the ages of 6 and 17 who were discharged from the ER with a mental health related diagnosis who needed mental health service follow-up. And she found that only 30% of them were able to get a psychiatry appointment follow-up within 7 days, and 55% got it within 30 days. And of all of those patients, more than a quarter of them came back within 6 months. So she found that timely follow-up within 30 days with a mental health professional caused a reduced return visit to the ER. But at the same time, the majority of children did not get those services that they need, suggesting that there's a big gap in the supply and demand. This map is from the CDC. It's looking at children between the ages of 5 and 17 who received any medical care for mental health, took medication, or received counseling. As you can see, and this is broken down by this age group of 5 to 11 and 12 to 17, less than 20% of children with mental health received the care they needed here. Only 10% of them, on average, between 5 to 10%, took their medication, and only somewhere between 8 to 15% of them received counseling or therapy. So that means, again, this was a deficiency in the United States back in 2021, and this is right in the COVID area. So the problem of emergency medicine is that because there is no infrastructure to support the mental health needs of children, and because at the same time, we are getting better at identifying a child with mental health problem, there is more referrals happening now. Schools are referring children for mental health evaluation. Parents are bringing their children for mental health evaluation. Primary care doctors are doing the same thing, but there is not enough psychiatric offices, clinics, hospitals. So everybody ends up in the emergency department. And because of that, the emergency department becomes a crowded space where a lot of these children end up staying for a prolonged period of times, as much as 12 to 24 hours, and sometimes even days, to get psychiatric services and care that they need. And that is the problem of boarding. They board in the emergency department, and not only that they're boarding, but they're also taking up an emergency department room, which means we have less room to care for acutely ill and injured medical patients. This is a map from before COVID, so it just shows you how mental health is increasing in children between 2007 and 2016. But most importantly, if you see the deliberate self-harm diagnosis, which is the suicidality, it is increasing out of proportion to all of the other mental health related visits. This again shows how the problem is most significant in the ages of 10 to 14, but even the adolescents between 15 to 17 are also increasing. And that compared to adults, the rate of rise is more than it is with adults. This is a very interesting graphic. It's from the COVID time and before and after comparison. As you can see, on the left side of this map, you'll see females in solid line, males in dotted lines. The ER visits for females and males was very close to each other. They followed the same pattern. But after COVID, you can see that a visit by females is increased a lot more than visit by males. And that is what I was saying before, that the COVID impact on mental health seems to have affected girls more than boys. This is actually an interesting study I came across that is in Saudi Medical Journal. This was a local Saudi research that looked at parents of children between the ages of 6 to 12 and asked them to complete a survey related to anxiety. And this instrument was translated in Arabic. And of this 468 parents, they identified that 77.8% of their children had at least one anxiety-related disorder. And as you can see, some of them even had 2, 3, or 4, or 5. And only 22% of them didn't have anxiety. And because this study was published in 2021, it was at the beginning of COVID, where the data collection was probably happening. I wonder if that's even increased from this point. But that's interesting because we talk about screening for anxiety, and this would be a good reason to do such a thing. So based on everything that I have discussed so far about the problem of mental health, it is really out of control when it comes to the ability for us to manage it. So it caused, at least in the United States, many organizations to start coming to action and trying to do something to help. So in 2019, the part of the federal government, the Maternal Child Health Bureau of the Department of Health and Human Services, has an area called HRSA, the Health Resources and Services Administration, that is actually part of the federal government that I have my federal grants from. They came up with this really nice 104-page PDF document called Critical Crossroads, which outlines all of the actions that needs to be done for a child with respect to screening for things like suicide, ER management, how to do assessment, how to provide activities for children who are boarding in the emergency department, how to provide safe discharge planning. And it basically was a very comprehensive multidisciplinary effort. In 2021, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association made an initial declaration that they published that declared a national emergency in mental health in children, which then prompted several organizations to get together and send a letter to the Biden administration asking for more funding, more infrastructure of mental health support, and more policies and legislatures. And then in the meanwhile, a year later, the US Preventive Service Task Force started recommending we actually screen adolescents and children for anxiety and depression. As I mentioned, the Saudi study was a good reason why we want to do screening. But before I talk about the screening, I wanted to say one more time how scary it is that according to the Center for Disease Control and Prevention in Atlanta in the USA, 1 in 6 children between the ages of 2 and 8 years have a mental, behavioral, or a developmental disorder. And again, I mentioned this before, but you can see how suicide is now in the top 10 causes of death in the younger children between the ages of 5 and 9. So let me talk about screening a little bit now. So the United States Preventing Task Force started looking at recommendations for suicide screening, anxiety screening, and depression screening. They felt that they wanted all children between the ages of 12 to 18 years to be screened for depression. They also felt all children between the ages of 8 to 18 should be screened for anxiety, but they were not able to find enough evidence to support screening children for suicide, so they did not make any recommendation related to that. But in the meanwhile, the American Academy of Pediatrics, based on their own experience, decided that they feel all children between the ages of 12 to 18 should be screened for suicide universally every time they show up for a healthcare appointment. And children between the ages of 8 and 11 should be screened if they have any risk factors, if they come for a mental health related problem, if they have a history of family mental health disorders, or the clinician based on the exam feels like there may be a mental health component. So that's targeted screening, but no screening to be done for children under 8. So this was out of the AAP's Blueprint for Suicide in Youth document in 2022. And the recommendation is that as of January 1st, 2025, that universal screening is recommended. So all the different organizations are trying to get ready for that. So in terms of screening, there are a couple of different validated screening tools that are used in the United States quite readily. And this is one of them, the ASQ, or Ask Suicide Screening. Very simple. It has 4 questions. If you answer yes to any of them, then you get a 5th question. And if the 5th question means, are you having thoughts of killing yourself right now, is yes, then you are deemed to be acutely suicidal. So this is great because if you have 20 patients, for example, that you screen and only 2 of them answer yes to the 5th question and 18 don't, then you know your limited psychiatric resources needs to be prioritized for the 2 who answered yes to the 5th question. And then there's another one similar to this called the Columbia, similar in scope. Questions are a little bit longer, maybe a little bit more involved. And then there's a 3rd one called SAFE-T, that's even more involved. And sometimes this could be thought of as second-line screening. So if you screen positive on one of the other 2, then you do this one because it has more questions, it's more in depth. So I wanted to spend a couple of minutes talk about my own work and working with the AMS for Children Innovation and Improvement Center. This is my disclosure that I'm funded by HRSA through a grant totaling $2.5 million with $0 from non-governmental sources, and everything I say related to that is my own opinions and not an endorsement from HRSA or the US government. So I work with the Emergency Medical Services for Children. We develop open access educational resources that you can download, you can share. It does not have any password or any fee. It is free for everybody to use. The way we do this, we actually either identify high quality educational content and we just share that, or if there's content that needs to be modified a little bit, we curate, modify it. And if there is no content for a given topic, then we create that. And we make content for a variety of audiences, for pre-hospital personnel or paramedics, for clinicians in the ER, for nurses, for patients and families. And we develop them in a variety of different ways. So for example, if you like a simple 1-page algorithm, or if you like a pocket card or an infographic, we do that. If you like to get more in-depth information, we have interactive learning modules that take about 30 minutes or so. So we have a good variation. We have a process of a 3-step. The first step is searching the literature, making sure we have the right evidence for everything we publish. That we do at Texas Children's, Baylor College of Medicine. Then the content development and management, that's under my side at Harbor-UCLA, the Lundquist Institute in Los Angeles. And then the content dissemination, which is, media marketing, website, and things like that, is at Yale in New Haven. So we generate the evidence, we create the content. We have about 1,000 or so subject matter experts who we can ask any of them to review content for us. They review it, they make edits, we make improvements. And once it's ready to be published, we publish it as PEAK, the Pediatric Education and Advocacy Kits. This is an example of PEAK for mental health. As you can see, timeline is roughly about 6 months from when we start brainstorming, deciding what we want, until it's published. For mental health, we had a subject matter expert group of multidisciplinary put together, and we identified suicide and agitation as the 2 most important areas to do our work on, which is why we have a PEAK on suicide and a PEAK on agitation. This is an example of what you see under, if you go to the page, I have the QR code here, you can scan it, takes you right to the page. We have that HRSA Critical Crossroad document that I mentioned, that PDF is there, you can access it directly. We also have a bottom line recommendation. Here you can see more content. We have a very nice podcast with Lisa Horowitz, who developed the ASQ suicide screening tool. We also have a podcast on how to deal with a patient who tested positive on the ASQ screening test. Again, here's a bigger version of that bottom line recommendation. Here, simple things like infographic cards, ABCDs of suicide. There's also an infographic on which patient who comes in with mental health can be easily discharged home, which one should be close follow-up, and which one should probably not be discharged. And we did it like a traffic signal, red, yellow, and green. I know for those who are colorblind, the red and green are hard to see, but we also have another version of this that the colors are a little bit less strong like this. So if you're interested in that, at the end of my talk, I have my email. Just email me, I'll send you that version. This is agitation. We have a lot of resources there. 2 things I want to point out about that. One is a really nice podcast with Dr. Alice Kuo, who's our expert in autism and neurodivergence. She actually did a podcast on how to manage those children in the ER, including medication choices. And then our own Dr. Marian Gashri-Hill, who many of you know, and is another speaker at this conference and has been involved with this conference for a long time. She has a very nice 7-part webinar on managing agitated child in the emergency department. This is, again, some snippets of what you will see on that page. There's a nice infographic that could be used as a poster, verbal de-escalation, because we do believe that majority of agitated children do not need to be restrained. They can be managed with verbal and behavioral de-escalation. And so we have a lot of emphasis on teaching how to do these verbal de-escalation skills. And we have a learning module, an active learning module that is on that page that you can also access. And then we also publish this on ASAP Now, which is what you see here. More content here is the algorithm for managing agitation. And then we have a medication table in here, but in case you need to use medication. We don't have droperidol in here because in the United States, droperidol was black boxed. We couldn't use it for many years. It just became available again. It has apparently really good side effect profile. It works really well for pediatric agitation, but there's not any significant recent evidence-based research to support its use, so we kept it out. Maybe in the next version of this table, we'll include it if we have enough evidence. Just quickly, a couple of collaboratives that we're involved with, the ED Stop Suicide and the Pediatric Readiness Quality Collaborative. This is 2 initiatives where many hospitals decide to join up and work with each other, and they come up with ideas for quality improvement projects. For example, in the Pediatric Readiness Quality Collaborative, one of the 4 areas is suicide. So the group of hospitals that pick suicide as their intervention, they work together and they decide whether they want to work on a screening tool, do they want to work on safety planning, And it is a really great way for our EMS for Children program to bring all these hospitals together so they can share knowledge. And then we also have our own subject matter expertise. We give them what we call fireside chats and webinars and share all our resources that we have so they have what they need to work on their intervention bundles. Finally, I want to close by talking a little bit about the new policy statement for mental and behavioral health. This was published last August. I was lucky to be the lead author. It took 2.5 to 3 years almost to do, but it provides really comprehensive recommendations for managing children with mental behavioral health emergencies. It also is accompanied with a technical report, which is a lot more detailed. So this is a QR code for that. I'll let you read that. I'll not go over it too much. So to summarize, pediatric mental health is a growing public health problem. COVID made things a little bit worse. We just don't have enough resources to keep with the increasing demand. Because there is no infrastructure for pediatric mental health, a lot of these children end up coming to the emergency department where we also don't have the resources to care for, and therefore they end up boarding for prolonged periods of time. Organizations such as EMSC have been working very hard to try to come up with resources to help clinicians help children with pediatric mental and behavioral health issues. And the quality collaboratives that I mentioned, they're also a very good way for hospitals of different sizes. You know, the collaboratives we have, they are from Children's Hospital all the way to rural critical access hospitals. They all get to work together and learn from each other. So with that, I will close. This is my email. If you need to contact me, please feel free to do so. Thank you very much for listening. I really appreciate it.
Thank you, Prof. Mohsen. It is a really excellent presentation, and it's very important. Mental health, as you mentioned, is escalated after the COVID era. So it's very important to consider when you manage any patient present to the pediatric emergency, and you have to consider as a part of the management. We'll move now to important approach for, as you know, that's a neck trauma is not as common as with the adult, but it's very important to be more familiar which patient he have to be going for a radiological study and how to manage the patient with the neck trauma. Next speaker, Dr. Dr. Drebin is Associate Professor of the Pediatric Emergency Medicine at Cincinnati Children's Hospital Medical Center and the University of the Cincinnati Department of Pediatric in Cincinnati, Ohio. He finished the residency program in the University of the Washington School of Medicine at Seattle Children's Hospital, 2015. He finished the fellowship of Pediatric Emergency Medicine in Boston Children's Hospital, Harvard Medical School, 2018. Welcome, Dr. Drebin.
Hello, my name is Tim Drebin. I'm an Associate Professor of Pediatric Emergency Medicine at Cincinnati Children's Hospital Medical Center. It's an honor to speak with you today. The title of my talk is Neck Trauma and Management. My funding is shown here. I have no conflicts of interest to report. The objectives of this talk are to discuss cervical spine injuries and then to go into a little bit of detail about blunt and penetrating neck injuries. So now we're going to discuss cervical spine injuries. A little bit about epidemiology. Cervical spine injury is very rare, only occurring in about 1 to 2% of children with blunt trauma. The major causes of cervical spine injury are motor vehicle collisions, especially those that have ejection, death of an occupant, or significant intrusion into the vehicle. Other risk factors include patients who fall greater than 10 feet, or for younger children, 2 to 3 times the height of the child. Other risk factors including diving or axial load injuries, as well as clotheslining, as well as those patients with multi-system trauma. Location of the injury. In children less than 8, 75% of injuries occur from the occiput to C2, whereas children who are older, about 50% of those injuries are from the C3 to C7 location. There is a little bit of reason why some young children are more susceptible to injuries, especially those young children less than 8. One reason is that they have a relatively larger head than their bodies. They also have weaker cervical musculature and laxity of those ligaments. There's also an immature vertebral joint as well as immature growth centers. Another component is that the spinal column is more elastic than the spinal cord, so there can be more distraction before rupture of the spinal cord. Additionally, there are some conditions that predispose children to cervical spine injury. Down syndrome is one, as well as osteogenesis imperfecta, as well as Marfan syndrome, and then Ehlers-Danlos syndrome are some other risk factors. The initial management of patients with suspected cervical spine injury is first and foremost spinal mobilization. Emergency medical services personnel do a great job of doing this, and when patients come into the emergency department, we do a good job of trying to transition care to maintain cervical spine immobility and potentially replace the collar with a better fitting collar. Initially, like all trauma patients, an ABC assessment is key. One of the first things is airway management. And for those patients with significant polytrauma, including head injury, as well as those patients with bad cervical spine injury that may predispose to respiratory insufficiency, patients may require intubation. For patients with intubation, it requires a coordinated team effort to do inline cervical spine immobilization. That can be done from up above, or if the patient is being intubated, to have more access to intubate, someone below the patient can immobilize the spine with 2 hands as shown in the images to the right here, and removing the collar. Other initial management things that clinicians need to pay attention to is for signs of neurogenic shock. Patients may have bradycardia, they may become hypotensive. This can also be very challenging in patients with polytrauma to figure out, could patients have hemorrhagic shock and could they also have neurogenic shock? Those patients with neurogenic shock may require vasoactive medications as well as pacing if they remain, if significant bradycardia is concerned. Additionally, there's need for subspecialty consultation, patients with neurologic involvement, including weakness or concern for neurotrauma. Neurosurgery will need to be involved right away to make sure that they can be there to review imaging and then to make any determination about going to the operating room for definitive care. The initial physical exam after the ABC evaluation is done also includes monitoring vital signs for those vital signs that may show signs of impending respiratory failure. Patients may become bradypneic. Patients should also be monitored on end-tidal CO2 to show signs of respiratory insufficiency. This also they could also be assist with assessing the ventilatory status by obtaining blood gas as well. And then, as previously mentioned, clinicians also need to monitor for neurogenic shock and to intervene quickly, given that if it's not assessed and intervened with vasoactive medications, the patient could continue to deteriorate. Neurologic deficits are a key component of the trauma assessment, and most clinicians are very familiar with this. One of the next questions, once the patient has been stabilized adequately, and if they are able to undergo imaging, whereas those patients who are critically ill may need to go to the operating room with trauma as well as neurosurgery. So for patients that are stable, the question is always who to obtain imaging on, and then what is the initial imaging modality that is preferable. Who to image has been a challenging question in pediatrics. There's more robust data in adult populations about which patients should undergo cervical spine imaging. The data on this slide is from a 4-site prospective observational study that was conducted through the Pediatric Emergency Care Applied Research Network. It enrolled over 4,000 children, of which 1.8% had a cervical spine injury. There was a retrospective model and a de novo model that was derived, and the results below, the risk factors below are from the de novo model. This model had a 92% sensitivity for detecting cervical spine injury, and as is expected, the specificity for the model is lower at 50.3%. But any clinical model for cervical spine injury, you'd want it to have a higher sensitivity to make sure that you don't miss patients with cervical spine injury, recognizing that it's not going to perform as well to accurately identify those patients who do have injury. The risk factors for cervical spine injury in the study was diving, axial load, neck pain, inability to move the neck, altered mental status, intubation, or respiratory distress. So as you can see, high-risk mechanisms, as well as those patients who are critically ill and very sick, are at risk for cervical spine injury. There's another ongoing study that's already finished data collection, and it's very exciting to see what the result of this is. This study was also conducted through PCARN, where they're deriving a cervical spine injury risk assessment tool. So hopefully this tool will also help inform practice about which patients need to undergo cervical spine imaging versus those who do not, or who maybe are less at risk. The next component is, what is the preferred initial imaging? Commonly, X-rays are performed in children, including a lateral, AP, or odontoid view. The kids, unlike adults, are not osteopenic, so it's more likely for fractures to show up on X-ray compared to adults. So children who are stable, who are well-appearing, X-rays is a great initial modality. In contrast, CT is preferable for those patients who have neurologic deficits on the initial exam, as well as those critically ill patients, patients with abnormal Glasgow Coma scales of 8 or less, as well as patients who are concerned that there could also be significant neurotrauma. So patients with altered mental status and a Glasgow Coma scale of 9 to 13, it may be reasonable to obtain the CT head and a CT neck. It also would be prudent to obtain a CT for those patients who have an abnormal X-ray on initial screening. MRI is not usually the initial evaluation, given it's not going to be as good for looking at fracture, but MRI, given it's less sensitive for fracture than CT. The performance of MRI in severely injured children is also hampered because it requires extended time to perform the study, and for young children or children who will not tolerate an MRI, they would have to undergo sedation under anesthesia to perform the study, which is also another barrier. Now I want to speak a little bit to the condition spinal cord injury without radiographic abnormality, and the abbreviation for that is shown here. What this is a neurologic findings despite having a negative X-ray or CT scan. However, with the advent of MRI, 2/3 of children with this condition were found to have injury of the spinal cord, or having soft tissue components of the spinal column, or even having vertebral body end plate evaluations. When children present with transient neurologic symptoms and normal neurologic exams, it may be difficult to distinguish between cervical brachial plexus injuries, such as burners or stingers, versus spinal cord injury without radiographic abnormality. MRI should be performed in children who are suspected of having spinal cord injury, but have normal plane radiograph or have CT of the cervical spine. Protection of the cervical spine to prevent worsening of an existing spinal cord injury requires restricting motion in both the neck and the body, and the neck should be placed in the cervical collar and the body placed in the supine position. The initial management of these patients beyond spinal motion restriction should include admission to the hospital for ongoing evaluation to make sure that there's no significant findings that require a surgical intervention, and to make sure that the patient's neurologic status does not worsen. The definitive management of spinal cord injuries is obviously based on what the imaging findings are and in consultation with the subspecialist. Patients at our institution with neurologic findings are always, neurosurgery is always involved with those patients, with all patients with neurologic deficits. One of the questions that come up is for patients with reassuring imaging, which patients can have cervical spine clearance. Part of it is based on how reliable the exam is. So when a patient or a child with a reliable exam, they can be cleared of their cervical spine from their cervical collars. In our institution, what we do is if patients have a reassuring plane radiograph, we try to clear their spine clinically. If we are not able to clear the spine clinically, we keep them in the cervical collar, and then they follow up in our trauma clinic at least a week later to determine how they're doing. If the patients at that time are asymptomatic, the collar comes off. If they remain symptomatic, the trauma team decides whether the patient should undergo an MRI. However, those patients with unreliable exams are usually going to be admitted to the hospital, given that there may be other deficits that need to be monitored, and those patients should remain in the cervical collar, given that it's difficult to clear their spine. Now I'm going to move on a little bit to discuss the next topic, which is blunt and penetrating neck injuries. These are very rare in the pediatric populations, and we don't have quite as much experience in recognizing or managing, diagnosing and managing these injuries. One common condition that we are seeing more and more of, unfortunately, is hanging injuries. Suicide attempts and mortality have been increasing in the United States, with suicide surpassing motor vehicle crash mortalities. Initial assessment of these patients includes a thorough ABC evaluation consistent with other trauma care, with a special attention made to the airway management because patients could, with significant hanging injuries, have laryngeal fracture or tracheal trauma. Laryngeal injury only occurs in less than 5% of hangings, but still, it could be a significant complication. The other things that clinicians need to monitor besides airway management is the potential for post-obstructive pulmonary edema. Patients may have respiratory failure with hypoxemia, and with intubation, there may be frothy secretions when the patient is trying to intubate them. With all cervical spine injuries, patients who do require intubation should undergo intubation with inline stabilization. Good communication among all team members is essential to make sure that the cervical spine is immobilized and that the airway intubation is successful. Video laryngoscopy is a key adjunct to facilitate this, given that intubation may be more difficult than with direct visualization alone. In these patients, like other patients with cervical spine injuries, every attention needs to be made for looking for other signs of trauma, but also there's concern for spinal cord involvement. Patients may have neurogenic shock, monitoring for signs of hypotension, bradycardia that may require more urgent interventions. Initial imaging is decision should be based on the patient's clinical status. All patients should have an X-ray of their chest to make sure that there's no signs of pneumothorax, and in most patients, a CTA is preferable to make sure that there's no vascular injury. I'll now move on a little bit to talk about penetrating neck injuries, which are less common in the pediatric population. The neck anatomy is incredibly complex, with the aerodigestive and neurovascular structures confined to such a small area. The following illustrations conveys the complexity and depicts the structure of the neck in detail from the anterior and lateral perspectives. Clinicians generally describe penetrating neck trauma according to the zone of injury, with the neck being divided into 3 zones as shown here. We'll start with Zone 1. Zone 1 is the most caudal, includes the base of the neck and thoracic inlet. It extends from the sternal notch and clavicles to the cricoid cartilage. Zone 2, above that, is the mid-neck. This continued cephalad from the cricoid cartilage to the angle of the mandible. And finally, Zone 3 is the upper neck. It includes the region above the angle of the mandible up to the base of the skull. Zone designation carries important implications for management and prognosis. And these management decisions have changed over the years, and part of that has been influenced by the advent of newer and improved imaging modalities that has obviated the need for surgical exploration. Zone 1 injuries can involve the mediastinum, where vascular control can be very difficult. Zone 3 vascular injuries, especially those more cephalad injuries, can also pose a significant surgical challenge. And then penetrating neck injuries can cross different zone boundaries, which is very important to recognize. And it can depend on the implant of the projectile as well as the angle that it penetrates the neck. Thus, an external wound in Zone 1 can be associated with an internal injury in Zone 2 or the mediastinum. Like I said, the management of penetrating injuries, particularly in stable patients, has remained a source of debate, and it's often up to local practice at different institutions based on the guidance of trauma surgeons. Given the controversies about the management of penetrating neck injuries, limited evidence base, and the variability in resources and experience, decisions about whether to use a selective zone-based management approach or a no-zone approach will vary based on local expertise as well as those resources that are institution-specific. The management of penetrating neck injuries, particularly in stable patients, like I said, has remained controversy. And those decisions have to be made in consultation with the trauma team at the bedside. A very important tool that has improved the recognition of injuries is multi-detector computed tomography, or MDCT, with angiography. These results have been, this imaging modality has been very helpful in further delineating the extent of the injuries and guiding surgical management. The management is often is informed based on this imaging and with discussion with the surgical consultations. It's important to know, though, that even this imaging modality can sometimes not be sensitive enough to detect injuries to the pharynx or the esophageal. So patients who are more stable may require additional imaging to ensure that there's no injury to these structures, given that delayed recognition can lead to increased morbidity or mortality. In some studies, the sensitivity of MDCT for pharyngoesophageal injury is reported to be as low as 53%. So direct esophageal studies such as contrast swallow endoscopy can provide definitive diagnosis and have sensitivities up to 100%. However, a patient obviously has to be stable enough to tolerate a contrast swallow and be stable enough to undergo endoscopy. I now just wanted to show an interesting illustrative case of a child who had a very good outcome despite a high-risk injury. This is a case report of an 11-year-old girl who suffered a serious vascular injury when she fell on a pencil. This is the image from the case report that you can see of the pencil that penetrated her left neck. And based on the location, the clinicians were astute to recognize that she needed to undergo advanced imaging to exclude vascular injury. Fortunately, on arrival to the emergency department, her vital signs were normal, and there was no evidence of respiratory distress or stridor, so no worry about upper airway obstruction or the need for intubation in the emergency department. Because she was stable, she had a neck CT angiogram performed that resulted in the final diagnosis and then ultimately informed the surgical approach. The CT demonstrated that the pencil was lodged in her left common carotid artery, causing total occlusion. Unfortunately, the remainder of the neck was unremarkable. This is an image of the angiogram that demonstrates that the pencil lodged in the left common carotid artery resulted in total occlusion, as seen on the axial and the sagittal views. The patient was taken to the operating room for a left neck exploration, and then they removed the pencil, and using therapeutic doses of heparin, the arteries were clamped, the pencil was removed, and then there was anastomosis performed by the surgeons. The patient had an uneventful recovery in the hospital, and she was discharged home just on the second postoperative day, which was amazing. She was maintained on aspirin for 3 months following surgery, and they continued to monitor her with an ultrasound at 6 weeks, and then every 6 months for 1 year for nearly 2 years. And fortunately, 3 years later, the ultrasound showed no abnormalities, and the patient had a great recovery. In summary, we've talked about the initial management and recognition of patients with cervical spine injury, including some of the epidemiology of patients that are at higher risk of having cervical spine injury, including those patients who have significant mechanisms of injuries, as well as those patients upon arrival to the emergency department are critically ill, including those patients with abnormal Glasgow coma scales. Area management of these patients is also key. There needs to be a coordinated effort between the person who is intubating as well as the team who's maintaining inline cervical immobility to ensure that any injuries that occurred from the injury are not worsened during the intubation attempt. It's also key to monitor for other signs that may portend a worse prognosis or may be evidence of spinal cord injury, such as neurogenic shock that needs aggressive resuscitation with vasoactive medications, and for those patients who are bradycardic, potentially pacing. The imaging modality we've also discussed. A lot of it depends on how stable the patient is. For patients who are stable and not critically ill, in children, initial imaging with plain x-rays may be prudent. However, for those patients with neurologic deficits or those patients where there's concern for significant neurologic injuries, CT of the neck would be the initial imaging modality. MRI is not helpful in the initial assessment, but should be done in patients with neurologic deficits, depending on the patient's stability and if there's any concern that the patient has neurologic deficits, but despite having reassuring CT imaging. We also reviewed the management of blunt and penetrating evaluation based on the zones of the neck, including initial imaging modality that can be helpful, as well as consultation with subspecialists to determine definitive care and management. It was a pleasure to speak with you today. I appreciate it, and please reach out if you have any questions about this lecture or anything else. Thank you very much and have a great day.
Thank you, Dr. Draven. It is a very informative lecture and very important to be familiar how to approach any patient present with the neck trauma. The next speaker and the last in this session will be talking about very important issue related to the emergency, who's working in the critical area. What is important to be familiar about medical legal principles, how to protect yourself from any legal issue. Dr. Abdul Salam Al-Shehri, he's the consultant emergency medicine physician, and he's lawyer in the Prince Mohammed bin Abdulaziz Hospital in Riyadh, Saudi Arabia. He will be talk about some medical legal principles to be avoided in the medical lawsuit. Welcome, Dr. Abdul Salam.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for the organizing committee to give me this chance to present in one of the most well-known international conferences on pediatric emergency medicine. I hope my talk will be of benefit for the audience. So my talk actually is touching my legal part, which is about medical legal principles to avoid medical lawsuit. So starting with this well-known famous saying in our legal field, there will be always a loser, unfortunately, or two losers in any lawsuit. Even if you win the case, you still will lose something, so better not to go in such cases. So starting with the definition of medical malpractice, actually in medical field, most of the healthcare professional, their action is legal. So if I treat a patient or if I perform a surgery or a procedure, my action is legal because I'm certified, I'm licensed, and so on. So sometimes this legal action may cause harm, not because of the nature of this procedure, because if this is the case, it's a complication. However, if I deviate from the standard of care, it means that I made a mistake, and if I caused a harm to a patient, it means that this constitutes what we called medical malpractice, and I am liable, and most of the courts will give the verdict that I have to compensate the patient for his or her damages. But what is the standard of care? If we say that you have to deviate from the standard of care to say that you made a medical error or malpractice, so what is standard of care? Is there any way to measure standard of care? Actually, it's to some extent a little bit subjective. However, there are some objective measures can be used, because usually we are measuring the behavior or the action of any healthcare professional based on the reasonable, careful healthcare professional would act. So if I believe that the healthcare professional in the same circumstances that he was made a mistake, it means that if another healthcare professional in his circumstances should made the right thing. This is what we call the standard of care. It's, yes, sometimes we have guidelines, sometimes we have protocols. However, we need to take into consideration the level of the physician, the backup that he has, the difficulty of the cases, the number of cases that he's facing. Is he facing one case, or is he facing, for example, 5 cases and he's alone, and so on? So these circumstances should be taken into consideration to decide that this physician actually deviate from the standard of care, and a reasonable, careful physician, if he's in his place or her place, would do better. The professional liability actually is not limited to what we call the civil liability. Actually, it's more than that. We have 3 types of professional liability. One of them is the civil liability, which is the medical malpractice. You will do an error, you will harm the patient, and this patient harm was a direct cause of your error. So this is what we call the civil liability. You have to compensate the patient. The second one is the criminal liability. If you take an action which the law state that this is considered a crime, yes, you will be liable from criminal point of view, like practicing medicine without getting the appropriate license. Even if you are capable and you are certified, you have to take the license. If you violate this, this is considered as a criminal act and you will be liable. The third liability is what we call the disciplinary liability. Actually, the disciplinary liability is somehow related to the ethics in general, or even the negligence. Even if no harm happened to the patient, still you will be liable. Sometimes you will be, for example, have to pay fine for the country. Usually in Saudi Arabia, our law actually will pay fine for the government because you made what we call the violation of the medical ethics or bioethics, or you act negligently even if the patient is doing fine and no harm was there. And to speak about civil liability, which is all of us as physicians are afraid of, 3 elements actually has to be there to constitute the civil liability, and the court will give the verdict that you as a physician or healthcare professional should compensate the patient. Number 1 is the malpractice itself, or the mistake, or the deviation of standard of care, whatever you call it, has to be there. Number 2 is the harm. Harm should be there, or damage, because if no harm or damage to the patient, nothing will happen. Yeah, disciplinary liability may be there, but civil liability is not. And the third thing is the proximate cause. It means that your malpractice or your mistake should cause, or should directly cause the harm to the patient. If any one of these elements is not there, it means there will be no civil liability at all. Sometimes the patient will have damage or even die. However, you did not make any mistake. You did your job perfectly. So no civil liability is there. So speaking about Saudi Arabia, our country, do we have medical law or not? Actually, we do have medical law. It's called Law of Practicing Healthcare Professions, and it's dated back to 2005, and it's still valid. However, some updates is ongoing but not finalized yet. And we do have the executive regulation, or the implementing regulation of that law, which is back to 1439 in Hijri. It's corresponding, I believe, to 2019 or something like that. So Let's speak about some important article in the law and its implementing regulation, and how it can help us by knowing and implementing these articles. First of all, Article 5 actually, it speaks about the healthcare professions or professionals. He has to respect the dignity of the patient. He has to work to save the patient life. He has to work for the best interest of the individual, society, and trying to observe the customs and traditions of the country and to avoid exploitation. If you look carefully to this article, it's mostly speak about the general ethics in medical practice. And we know that in any country, the law usually does not punish any individual if he violates the ethics, unless it's public morale, of course. But generally, the ethical behavior is not punishable by law unless the law stated that it's part of the law, like what's happening now in this article, Article 5, stating that the ethics or the bioethics actually is part of the law. So by violating them, you are violating the law and you may be liable. So do we have any guidelines for that? Do we have medical ethics guideline? Actually, we do. We have a code of ethics for healthcare practitioners issued by the Saudi Commission for Health Specialties, and in the implementing regulation of the law, it's stated in Article 5.2 that this guide, and other guides approved by the Commission, which is the Saudi Commission of Healthcare Professionals or Practitioners, are applicable to all healthcare practitioners in the country. Article 5 actually has two paragraphs, paragraph A and paragraph B. Paragraph A that emphasize that the healthcare professional shall exert or work in the best interest of the patient, and the other paragraph speaks about the limitation of your practice as healthcare professional, that you don't have to work beyond your specialty or capability. If you read this article carefully and you think that it needs to be a little bit detailed in the implementing regulation, actually there is some details stated in the implementing regulation related to Article 9. And it states clearly in Article 9.1 that you are not allowed to perform any further workup, medication, admissions, or whatever if the patient does not need them. Even if no harm is there, still you will be liable. Article 9.2 speaks clearly about the privileges, and it states that the institute should give the healthcare professional privileges according to his specialties and accreditation. And the healthcare professional should not work beyond these privileges unless, of course, in emergency situation. When we move to Article 19, actually Article 19 speaks about the consent, that no procedure should be performed without any consent or from the patient, or, for example, representative, guardian, or whoever, in case of incompetent patient. And it gives also the permission to the healthcare practitioner to perform the life-saving or the limb-saving or necessary procedure to avoid major damage to the patient if the patient cannot give consent and no representative or guardian can be reached at that time. So if you have a patient with certain emergency and the patient by himself cannot give consent because of his mental capacity or because of his age, for example, we are speaking about pediatric emergency, and no one is there to give consent, you have to perform the life-saving or limb-saving measure. And at the end of this article, it speaks or stated about the ending the life of terminally ill patient. Should we or should we not? Actually, by Saudi law, you are not allowed to terminate the life of any patient, even if he's terminally ill and his case is hopeless. So does this contain or include DNR? We'll speak about it in a while, but let's dig a little bit deep more on the consent. So do we have a guide for the informed consent? Actually, we do. It was issued by the Ministry of Health, the Saudi Guidelines for Informed Consent. And we will speak a little bit in detail about who should give the consent by law. As a general rule, the patient, if he's an adult and competent, should give consent for himself, of course. And the agent with power of attorney can give also consent, provided that the client is an adult and competent patient. Then the custodian of a child or an incompetent person, the custodian of that child or incompetent person should give the consent, or he is the person who has the right to give the consent, and he's the first person who has the right to give the consent, regardless if he's male or female. Then the guardian or the trustee, the guardian of that child or that incompetent, or the trustee should give the consent if the patient, of course, cannot, no agent, no custodian, so the guardian will give the consent. If none of these four above is available, so the relative according to the degree, and we are going to speak about the degrees of relative in a while. When we read the civil transactions law, Saudi civil transaction law, Article 12, actually it stated that who is the fully competent person, and they specify actually the age even, and they consider the age is 18 years according to the Hijri calendar. So this is a unique thing actually in the Saudi law, that they choose the Hijri calendar to decide the competency of the patient. Yani, when he's 18 years in Hijri calendar, even if he did not reach this in the Gregorian calendar, still he is an adult and competent, and he can decide for himself. Family law, Article 124, speaks about the custody. What does it mean? And it stated clearly at the end of the article that the job or the missions of the custody, including the education and medical treatment of that person subject to custody. So if you move to Article 127 from the same law, it stated that the custody is the responsibility of both parents as long as they remained married. However, if there is separation, usually the mother, then the father, or whoever further, but the court can decide in contradiction to this article by law. So if the court believes that the child subject to custody in best interest is to have another person different than the mother or the father, the court has the right to do so. Then they divided the guardianship into two types, which is the guardianship over a person, which is our subject today, and the other one is the guardianship over the state, which has no role in our topic. And it stated in paragraph 1 that the guardianship over person, which means that the overall care of the incompetent person in a manner not inconsistent with the custodian's authority in managing the affairs of the person subject to custody. That means that the custodians has the priority to decide on behalf of the person subject to of custody, the priority over the legal guardian. So if you have a custodian and a guardian, who has the priority to decide? Actually, according to the Saudi law, the custodian has the priority to decide. Then you will move at the end to the relative, and according to the degree, starting with the first degree till the fourth degree, whoever is there, he can sign on behalf of the patient or can give the consent on behalf of the patient, if the patient cannot, of course. Starting with the first degree till the fourth degree, according to the priority. So if you have two relatives, one is second degree and the other is fourth degree, you will go with the second degree and so on, provided that the decision is going with the best interest of the patient. If you believe that someone is trying to decide for something harmful for the patient in a bad faith, it means you have to sometimes go against his will and try to get the court support. Then we'll move to our DNR or AND, which is allow natural death. Actually, we do have a national policy. It was issued by the Saudi Health Council and it was approved by His Majesty the King. And we are applying DNR in our hospitals following this national policy. Still, you are allowed to do a DNR with certain policies and procedures. Getting back to the law of practicing healthcare profession, Article 21 speaks about the confidentiality of the patient. We all know that you have to maintain the confidentiality of the patient. However, in certain circumstances, you are allowed to disclose the confidentiality, and Article 21 speaks about three situations. First one, if the disclosure is for the following purposes. First purpose is reporting a case of death. You believe that it's secondary to a crime, or you want to prevent the commission of a crime by disclosing this information. However, this information should be disclosed only to the competent authority. The second purpose is to report a communicable or epidemic disease. Again, it should be for the competent authority, which is Ministry of Health here in our country. The third purpose is if you want to defend yourself before the court. If you faced, for example, a lawsuit and a patient or his family file a case against you and you want to defend yourself, you are allowed to disclose this information in the court. The second situation is if the party or the patient or whoever agrees for that in writing. Like, for example, in research purposes, sometimes you get the consent to show the information of the patient or even sometimes the picture of the patient. This should be in writing, consent in writing. And if the patient family will help you to treat the patient, if you believe that disclosing such information to the patient family, not to everyone, to the patient family, is of benefit to the patient, you are allowed to do so as well. The third situation, if you received an order from the court, of course, you have to disclose such information. In Article 4112 from the implementing regulation, it speaks actually about the trainees, because some people believe that the trainee has no liability, which is not true, because the trainee is liable as well in healthcare practice. And here they The article stated that you are liable, or you have joint liability with the institute if you made any mistake which caused any harm to the patient. So please don't tell your resident or your fellows that you are not liable, you are 100% protected, which is not true. At the end, please don't practice defensive medicine, but evaluate patients and document in a defensible way. That's what I have for today. Thank you so much for listening, and thanks again for the organizing committee to give me this chance to present my lecture. Thank you so much.
Thank you, Dr. Abdul Salam. Dr. Abdul Salam with us.
Yes, sir, I'm here.
Assalamu alaikum. Dr. Abdul Salam, Allah يعطيك العافية. There is a lot of questions related to the legal issues. Very important to be familiar for how to protect yourself in your field, especially we are working in the critical area. So it's very important to be familiar what's the good and what's the legal issue and what's the important information. Your lectures cover most of the important points related to the legal issue in our practice. What about the consent? If you if the parent sign DAMA, the patient sign against medical advice, and there is harm for the patient, and you try to explain for the parent but refuse to accept our justification and explanation for that parent. Did the patient, if he signed this DAMA, you can protect yourself if there is a complication can happen for this patient?
Yes, actually, they both have the right to sign against medical advice for their child. However, there are some exceptions. If you believe that they are doing this, or one of them is doing this for bad faith, or if the case is you believe there are some child abuse or neglect, yes, you can ask the support of the court and go against their will. But as a general rule, generally speaking, they have the right to sign DAMA for their child. Even if you believe it's harmful for that child, and you did your best effort to give clear explanation in an easy language, and still they insist, for example, they want to go to another hospital, they believe on, what we call the herbal medicine, they believe on what we call the other, traditional, the other types of traditional medicine, yes, they have the right to do so. You cannot take the guardianship from parents with what you believe it's true. However, sometimes you can by law.
There is another question is asked about what's the appropriate age for the patient can be signed, and especially for pediatric age, I will ask. And that Minister of Health, pediatric age up to 14 years old.
It's 18 years in Hijri calendar, provided that he's mentally competent. So even if the Ministry of Health decided that 14 years, above 14 years should not be admitted in pediatric ward or pediatric hospital, it doesn't mean that after 14 years old he is a competent adult. No, it's 18 years in Hijri calendar by law.
Okay. There's other questions we ask about the privilege to protect the healthcare provider in the medical legal cases. Of the privilege protect can do.
Yeah, the privilege is actually like putting the limits of the healthcare practitioners not to practice beyond his specialty or capabilities. The privileges is the assignment of the institute to decide that this practitioner should not practice beyond these privileges, unless, of course, in case of emergencies. So these privileges should fit also his specialty. So you cannot, for example, because you are authorized by law as institute, you cannot give the cardiologist privilege to do endoscopy, for example, because his specialty from or his accreditation from the Saudi Commission for Health Specialties as cardiologist or general cardiologist or interventional or so on, so he should not go beyond his specialty. Then the privileges is like a narrower scope of his work that he should not practice beyond it. So if you practice within your privilege, you did not commit any mistake, any negligence, any, for example, practice without patient approval within your privilege, yes, you are legally protected. However, if you practice beyond your privilege and there was no emergency and you practice the true procedure, even if you did the true procedure, but it's beyond your privilege, anything happened to the patient, even if it's a complication, it will be considered a malpractice. So for example, you are not privileged, for example, to put chest tube, okay? The patient has simple pneumothorax, there is no emergency to do it now. You did chest tube and you did it in a good way, in the right way. However, any damages to the patient, even if it's considered complication in the literature, you will be liable for that.
Next question by Dr. Mohammed.
Okay, thank you, Dr. Abdel Salam, for this very informative and excellent lecture regarding this lawsuit in the emergency department. Just I want to clarify, because I think most of the audience, they have to understand and they have to appreciate that, for example, if you have like a very sick patient, pediatric patient in the emergency department, and you have to, you made already a decision to admit this patient, but the family, they refused. And they wish to take the patient to another hospital, but he is sick. Because we know that according to the child abuse guidelines, and if you feel like this is a very, for example, it's a dangerous decision by the family, you have the right to prevent them from leaving or taking the child to another hospital. So what do you think? Are we allowed to let them take the child? If anything happened to the patient, maybe we will be responsible. And what do you think, please, for this matter, if you can elaborate more on this issue?
Okay, it needs a little bit of details. For example, I have now an intubated child in my resource area, and they want to sign DAMA. I know that I cannot remove the tube. They are not allowed to remove the tube. If this patient is out of the hospital after 5 seconds, he will die. Of course, I can take the authority support not to allow them to do so. But for example, I have pneumonia child and he's tachypneic. He's to somehow desatting or room air and he should be admitted, but they insist to take him to another hospital. Here, it's a different situation. If I give clear explanation for them and it's harmful to the child, and he might, deteriorate in the way, anything might happen on the way, still they insist, still they can comprehend your message, but still insist to go. Here, it's not easy to say, no, I will not allow you to take your child, because still they are the legal guardian for that. But if this reached to a clear, for example, major harm like death, if they will take the intubated patient, of course, I will not allow them to do so. And I can ask for the support from the security or even the police not to allow them to do so. So it's the situation is not always the same. I have to individualize each case according to the harm, according to the faith of the parents, according to their, knowledge, how do they comprehend my message or not, and so on. So.
I see. Because actually, to be honest with you, I remember there was a patient who is like 2 weeks old with fever, and we have to do septic workup, and the family, they refuse, and they decide to take the patient, and he's not that sick, but like less than 1 month old with fever, he may be brought into sepsis. So we activate the child abuse guidelines, and they admit the patient at the end to the hospital, and they refuse to allow the family to take the child. Tomorrow, inshallah, there will be a lecture by Dr. Fadia Khattabi, and she will talk about the child abuse guidelines. And I wish you, please, if you could attend with us, because this is a very dilemma we are facing most of the time in the emergency department. I agree with you that intubated child, it is really difficult, and I don't think even the family, they will ask to move the patient outside the hospital to take him to another place. But this gray zone that we usually face for those children less than 3 months of age, looks septic, and the family, they don't care, they want to take him any other place, and sometimes when they refuse to do an important procedure, for example, lumbar puncture, okay, lumbar puncture will change the whole management. If it is positive, then you have to keep the patient for like a week or 2 for antibiotics. If they refuse, you don't know what you are treating, so you will keep the patient in the hospital. But there is some dilemma in this gray area. What do you think, Dr. Abdussalam?
But let me give you the other scenario, Dr. Muhammad. By the way, I faced a case of an intubated old man, and his son insists to take him against medical advice. And that case ended with physical fight between me and the son till the police arrived and they took him away. So some people will say so, it's not impossible. It's happening. They want to take the patient regardless, because they reach to the level that they don't believe you anymore. And they believe that you are killing their patient in a slow way. That's what they believe. So it can happen, actually. However, let me give you the other scenario. Let's assume that this case, when you activate the child abuse, and according to you, he was not that sick, and you did a procedure, and the baby died. Do you think it's easy to defend yourself before the court? Because you, according to you, that the patient was not that sick, you get the guardianship of the parents by force, and you did the procedure without their approval, and the patient died. Whom do you think will be liable? The parents or you? It's difficult. It's a difficult situation to decide. If you don't have strong reasoning before the court to defend yourself, mostly you will be liable, because the parents will come and they will prove that he was not that sick, and they are going to take him to another hospital which is 10 or 20 minutes away, and still they insist to take my child, and they killed him. They will say they killed my child. And your situation there will be a little bit difficult. So I will be happy to attend tomorrow with Dr. I forget her name, and inshallah we will discuss more. I will be happy to do so.
Thank you very much, Dr.
Dr. Abdussalam, I have there is 3 or 4 questions for you. I have good time. Someone asked asked me if the patient he has some necklace of DNR, and the patient he's unconscious, and there is no any contact information you can find in that patient. You have to resuscitate the patient or no need?
Yes, actually, till this moment, necklace is not considered an official way of documentation. So you have to resuscitate the patient till you have proved that he was really DNR, or if you have time, you can decide if the patient is DNR in your hospital according to the policy. So if you can get 2 to 3 consultants according to your policy, the national policy mentioned that I believe 2 to 3, one of them should be consultant. Maybe your internal hospital policy said no, they should be 3 consultants. Okay, no problem, but it cannot contradict the national policy and put it less. For example, if the national policy said 2 to 3, one of them is consultant, you cannot say in your internal policy, no need for the consultant, or only one can decide. You cannot do this. If you said 3 consultants, it's okay, but you don't have to contradict the national policy. So if you have time to decide for his DNR status, you can do it in your hospital, but don't rely till this moment in our country on necklace.
Okay, there's another question he asked about the clinic. There is simple procedure in the clinic like ear washing or backing. Need to make a consent?
Okay, actually, there is no clear black and white situation in which procedure need to be consented or not. And it's related to somehow to the hospital or institute policy, because I've seen some hospitals, they believe that the sutures, simple suture of the wound, they are taking actually written informed consent. However, other hospital, they said it's only verbal consent. But as a general rule, major procedure like chest tube, like intubation, if it is elective, like surgeries, like central line, if it is not crushing patient, needs consent. However, simple procedure that can be done in the clinic, mostly no need for written consent, verbal consent is enough.
Okay, Dr. Abdeslam, there is another question. If you decide to admit one patient under a certain subspecialty, and that specialty decide to discharge the patient at home, but in the patient deteriorated at home, and you will be who will be accountable for this patient, the ER physician or that specialty that discharged the patient?
Okay, here I need actually more details about the case, but as general rule, and it's not always there, as general rule, the one who did the harmful act. So the harmful act here is discharging the patient. So the one who discharged the patient is the one liable. But some hospitals, like big hospitals, allow the emergency consultant to admit the patient against the specialty will. So if we had similar situation and that physician, for example, from, let's say, from pulmonary, discharged the patient, and the patient came back tomorrow with a more severe situation or pneumonia, okay, he will be liable. But let's assume that he decided to discharge the patient and patient came back, died after 2 hours. They will blame both actually. So they will ask the pulmonologist, why did you discharge the patient? You have the higher level of liability, and the emergency consultant, you had the right to admit the patient against his will and you did not use it. So both of you will jointly be liable of this mistake. So it's, again, it depends on the case and some details on each case.
Thank you, Dr. Abdeslam. Really, it's very informative talk and it's very important talk. So we'll stop in this moment for the lunch break. We'll come back for the third session after the lunch break at around 1 o'clock sharply. Thank you, Dr. About the questions not answered, we can send for Dr. Abdeslam. You will be answered and email it. Thank you very much. Get some I think, get a message from that case scenario. It's a very interesting case. We'll move to the third case, interesting case, challenging case. This will be with the Dr. Catherine Remick. She is one of the executive leads for AMS for Children Innovation and Improvement Center, assistant professor of the pediatric at Dell Medical School at the University of Texas at Austin. Medical director for San Marcos County AMS, associate medical director for Austin, Travis County AMS, system and the emergency physician at Dell Children Medical Center for Central Texas. She will present the third case. This will be one patient with 12 years old, presented with the recurring joint pain with fever. Welcome, Dr. Catherine.
Hello, my name is Kate Remick. I am a pediatric emergency medicine physician as well as an EMS physician, and I'm going to be presenting a case on recurring joint pain and fever. So in this case, we had a 12-year-old girl who presented to the emergency department with a 5-day history of worsening leg and left thigh pain. The thigh pain in particular became much more pronounced the day of presentation. She also complained of 5 days of persistent fever. Her symptoms initially began approximately 2 days prior with bilateral ankle and knee pain, and then also joint pain in 2 of her fingers. The joint pain resolved, and then 5 days ago, she started having this left thigh or leg pain. She reported that the pain was predominantly crampy. It ranged from about 5 to 9 on the pain scale of 10 in terms of severity. And that morning in particular, she started having some difficulty walking. At home, she was taking ibuprofen in order to manage her pain and her fevers, but she did report that her fevers occurred daily as high as 104. That morning, she complains that she began awakening from sleep because of the acute pain to her left inner thigh that she rated again as 9 out of 10. When she took acetaminophen, it did decrease to 5 out of 10. She denied any recent trauma or extreme exercise. She did report a respiratory infection about a month prior to presentation, but she had no history of rhinorrhea or cough, no sore throat, no vomiting or diarrhea, no abdominal pain or other symptoms, and no skin changes or rashes. She did endorse approximately 8 pounds of weight loss, and over the past 2 weeks had also had a decrease in her appetite. She had been seen by her pediatrician, and her pediatrician underwent a few diagnostic studies, including a complete blood count, which showed that her white blood cell count was slightly elevated, as well as elevation of inflammatory markers. A urine culture was sent, but no bacteria had grown at the time of presentation. She had no known sick contacts. Her past medical history was remarkable, predominantly for a history of migraine headaches. She had had a MRI done of her brain in the past, and that was reportedly normal. She denied any recent headaches. There were no seizures or heart disease, no asthma, recurrent infections, pneumonia, or skin infections. She took amitriptyline regularly for her migraine headaches. She had all of her immunizations up to date, and there was a family history of migraine similar to what she experienced. There was no family history, however, of any kind of autoimmune or rheumatologic disease. Socially, she lived at home with her parents and attends school, and there are no known exposures to infections or toxins. On arrival at the emergency department, her vital signs were relatively normal with a heart rate of 82, a blood pressure of 104/68, and a respiratory rate of 18. Her physical exam was remarkably benign, with the exception of mild tenderness of the medial left thigh and pain with hip flexion on the left side. There was no findings on lung examination or heart examination. She had no abdominal tenderness and no signs of any rash or neurologic findings. Her diagnostic workup showed a white blood cell count of 13.2, which was slightly elevated, as well as an elevation in her ESR and C-reactive protein at 3.4. A femur x-ray was completed, which was normal. A chest x-ray was also noted to be normal. She had a left leg ultrasound done to rule out the possibility of venous thrombosis, and that was found to be normal with no abscess nor clot. However, the MRI of her left leg did show myositis of the posterior medial left thigh with concern for adjacent thrombophlebitis. She was subsequently admitted into the hospital for IV antibiotics, initially started on ceftriaxone, as well as for pain management. And you can see in this image the enhancement and edema involving the musculature, as well as the left profunda femoris vein, which had some apparent flow voids within the vein, which is part of the reason why she ended up undergoing ultrasound to rule out possible venous thrombosis. The differential diagnosis at this time might include rheumatic fever, given the history of joint pain, systemic lupus and erythematosus, Lyme disease, bacterial endocarditis, a reactive or post-infectious arthritis, leukemia or other neoplasm, gonococcal infection, which can cause joint infections and pain, inflammatory bowel disease, and lastly, some kind of pyomyositis, abscess, or osteomyelitis. The next day in the hospital, she began to complain of tenderness along the plantar part of her left big toe, and notably was found to have a small, non-blanching red macule as demonstrated in the image here. The question at the time was, is myositis causing thrombophlebitis, or is thrombophlebitis causing myositis? And with the initial diagnosis of a possible lesion on the big toe, there was concern that this perhaps was a Janeway lesion, helping to secure the diagnosis. 2 days after admission, she was noted to have a new diastolic murmur that was heard, as well as a widening pulse pressure with a blood pressure of 102/48. The lesion on her left toe was suspected to be an embolic skin lesion, and it raised the possibility of a left-sided endocarditis with aortic insufficiency. As she was sent for an echocardiogram, they were able to identify a previous echocardiogram that had been done in the past, and on that found evidence of a bicuspid aortic valve with trivial aortic insufficiency. She was also noted to have a small muscular ventricular septal defect and a grade 2 to 3 diastolic murmur. On the current echocardiogram, they found that there had been progression of her aortic insufficiency to moderate, and there was a questionable small new density at the site of impact of the aortic jet. The next day, a transesophageal echocardiogram was conducted, which confirmed the presence of a thick echogenic non-sessile mass on the aortic surface of the right coronary cusp and on the ventricular surface of the left coronary cusp. Additionally, at this time, her blood culture grew out Streptococcus sanguinis, which is part of the strep viridans group. Her final diagnosis was bacterial endocarditis, with secondary diagnoses of aortic insufficiency, septic emboli to the toe, thigh, and hand, and a bicuspid aortic valve. The diagnosis of infective endocarditis is made using the modified Duke criteria, and this includes the presence of 2 major or 1 major and 3 minor criteria in order to make the definitive diagnosis. In this case, the major criteria are positive blood culture for typical microorganisms such as the Streptococcus viridans group, and or an echocardiogram showing valvular vegetation. Minor criteria for the diagnosis of infective endocarditis can assist with only one major criteria are present. And in this case, minor criteria should include three of the following: either a predisposing cardiac condition or history of IV drug use, a temperature over 38 degrees Celsius, embolic phenomenon such as the Janeway lesion, immunologic phenomenon such as glomerulonephritis, Osler's nodes, Ross spots, or rheumatoid factor, and lastly, a positive blood culture that is otherwise atypical in terms of the microorganism. Possible infective endocarditis is made when there's at least one major or one minor, and one minor criteria, or the presence of simply three minor criteria. Most cases of infective endocarditis are caused by the viridans group of strep, which includes Streptococcus sanguinis, as was identified in this patient. Additionally, the HACEK organisms of Haemophilus aggregatibacter, Cardiobacterium, Eikenella, and Kingella, as well as Enterococci, are common. If the organism is otherwise unknown, the initial preferred antibiotics are ampicillin along with gent and oxacillin. However, if a patient is penicillin allergic, then vancomycin and gentamicin is sufficient. However, if a patient has a new prosthetic valve or healthcare associated infection is expected, then the recommendation is for vancomycin, gentamicin, and rifampin. The typical presentation includes fever, but oftentimes these are accompanied by other symptoms such as chills, night sweats, malaise, headache, abdominal pain, etc. And lastly, in up to 80%, 85% of patients, cardiac murmurs are heard. Common findings on physical exam include Janeway lesions, again as pictured here, which is a hemorrhagic macular lesion. Predisposing factors for infective endocarditis include congenital heart disease, rheumatic fever, dental procedures which can cause a transient bacteremia, as well as skin infections in the setting of a bicuspid aortic valve. If you suspect infective endocarditis, a few clinical tips to consider. One is that ideally we should be collecting 3 sets of blood cultures separated by at least 1 hour and from separate venipuncture sites before any initiation of antibiotic therapy. If cultures remain negative after 48 to 72 hours, then generally speaking, additional blood cultures should be obtained. Echocardiography should also be performed, and a transthoracic echo may be the first imaging choice. However, it may not identify vegetations that are rather small, so those under 2 millimeters, or when evaluating prosthetic valves. And lastly, it should be noted that laboratory data in general are nonspecific. At this juncture, I'm happy to take any questions. Thank you so much for allowing me to present this case.
Thank you, Dr. Kathleen. It's a very interesting case.
My name is...
Now we'll go for the 4th case with the Dr. Kathleen. His patient is 2 years old with fever and knee pain. Okay, the next 4th case, please.
Hello, my name is Kate Remick. I'm a pediatrician, a pediatric emergency medicine physician, as well as and I would like to case of a 2-year-old child complaining of knee pain and fever. This 2-year-old girl initially came into the emergency department complaining of 2 days of worsening right knee pain and also difficulty walking. The day prior to arrival, she was unable to bear weight, as the parents noted, and she had developed a fever as high as 103 degrees Fahrenheit. At the emergency department visit, blood work was taken and they found her blood counts to be normal, as well as a basic metabolic panel or chemistries to also be normal. Her initial transaminases, however, were slightly elevated with AST and ALT values in the 300s. Her total bilirubin level was also elevated at 1.9 with a normal direct component, and a blood culture was obtained at that time because of the fever and difficulty ambulating. She was given acetaminophen and ibuprofen for pain and fever control, after which she was able to ambulate without difficulty, and she was subsequently discharged home to follow up with her pediatrician. Her primary diagnosis at that time was transient synovitis. The key point to note here, though, is that a normal CBC alone is not a reliable predictor of the absence of septic arthritis. At this time, you might consider, because the CBC alone is not sufficient, other infectious causes like septic arthritis, transient synovitis, osteomyelitis. Other considerations might include a fracture or child maltreatment, although the presence of fever certainly makes that less likely. And given her age, being only 2 years old, congenital hip dysplasia is also a possibility with subsequent avascular necrosis. The following day, however, she continued to have subjective fevers and worsening pain. She had one episode of non-bloody and non-bilious emesis, and now was complaining of calf pain, and it was noted that her right calf was now swollen. Notably, her blood culture returned with the presence of gram-positive cocci in chains. Her past medical history was otherwise unremarkable. She had no known allergies. The only medications she was taking were acetaminophen and ibuprofen. Her family history was otherwise not significant. There was no history of liver disease or hepatitis. Her immunizations were up to date. She had no known exposures to infectious diseases or toxins, and she lives at home with her parents. The review of systems was also negative for rash, conjunctivitis, lymphadenopathy, trauma, diarrhea, bleeding, bruising, jaundice, or sore throat. On physical exam, it was notable for a fever of 102.4 degrees Fahrenheit, a heart rate of 180, a blood pressure of 74/48, which is notably soft, a respiratory rate of 54. She was also noted to be acutely ill appearing and lethargic. She was tachycardic, as noted with her vital signs, and had a delayed capillary refill time of approximately 4 to 5 seconds. She was noted to be tachypnic with mild retractions. Her right knee and calf swelling were tender to palpation, and she had pain with passive range of motion of that right knee. Also notable was some mild erythema just below the right knee. The remainder of her exam was otherwise normal. Part of your differential diagnosis at this juncture might include leukemia or lymphoma, although you would expect perhaps pallor or petechiae, perhaps weight loss, rheumatic fever, with expectations of perhaps carditis, erythema marginatum, Sydenham's chorea, Lyme disease, but there was no known history of a tick bite, no evidence of erythema marginans, Hinox-Schönlein purpura, which you would expect to see the palpable and sometimes painful swelling to the feet that can make it difficult to walk. Guillain-Barré with weakness of the lower extremities and absence of the deep tendon reflexes. And last, potentially post-strep reactive arthritis, where you would have expected some prior suspected illness, whether it be febrile or not. Her lab and radiology results showed the following: a normal venous blood gas, blood counts that had a normal white count, but a significant leftward shift with 38% bands and 16% metamyelocytes. Her hemoglobin level was slightly low at 9.6, and the platelet count was also notably low at 74. Her metabolic panel showed a BUN of 24 and a creatinine of 0.6, as well as an elevated total bilirubin of 3.3. Last, her LDH was notable to be elevated at 1,286. Her C-reactive protein was also elevated at 14.9. Lactic acid was 6.9. Her creatinine kinase was 1520, and her urine analysis showed 6 to 10 white blood cells. During her hospital course, because of the soft blood pressure and the tachycardia, she was immediately given fluid resuscitation and started on a vasopressor infusion of norepinephrine in order to maintain normotension. Aspiration of the right knee was also attempted given concern for septic arthritis. However, no fluid was obtained with that attempt. She was started on antibiotics with vancomycin, ceftriaxone, and oxacillin, and at this time had the temporary diagnosis of sepsis. She was admitted to the pediatric intensive care unit. An MRI of the lower extremities did show subcutaneous soft tissue edema, as well as diffuse myositis involving the musculature of the right calf and the edema surrounding the right greater than left lower extremities. She was noted to have some trace right knee joint effusion without evidence of any pyogenic debris. After being started on antibiotics and the fluid resuscitation, as well as vasopressor infusion, she gradually improved over the following days. So the final answer in this case is a blood culture that finally grew out group A strep and a diagnosis of invasive group A streptococcus infection with a final diagnosis of toxic shock syndrome. Toxic shock syndrome is a known complication of invasive group A strep infection. It's characterized by rapidly progressive shock and multi-organ dysfunction, and it's caused by a superantigen exotoxin-induced cytokine that's released by certain strains of Streptococcus. Generally speaking, streptococcal toxic shock syndrome occurs in less than 5% to as much as 15% of invasive group A strep infections in children, and it can occur at any age. Some common causes of invasive group A strep infection or common diagnoses include bacteremia and meningitis, pneumonia, osteomyelitis, necrotizing fasciitis, and other deep soft tissue infections. In children, the skin is the most common source of invasive group A strep bacteremia, with pharyngitis-associated bacteremia also being a relatively uncommon occurrence. Risk factors for the development of an invasive group A strep bacteremia include cellulitis, minor trauma, wounds, burns, and varicella infections. In order to make the diagnosis of toxic shock syndrome, you should have presence or isolation of group A strep from a culture, ideally from a sterile site. That could be either blood, cerebrospinal fluid, peritoneal, pleural, or synovial fluid. The primary diagnosis is made when you have both the presence of isolated group A strep from a sterile site, as well as the presence of hypotension as measured by a systolic blood pressure less than 90, or in children under 16 years of age, less than the 5th percentile, as well as the presence of 2 or more signs of multi-organ involvement, which could include renal impairment, coagulopathy, hepatic involvement, acute respiratory distress, generalized erythematous macular rash that is often desquamates or peels, and lastly, soft tissue necrosis such as a necrotizing fasciitis or myositis. Probable cases of toxic shock syndrome are made in the presence of 1B, so isolation of group A strep from a non-sterile site, as well as hypotension and signs of multi-organ involvement. In the case of our patient, toxic shock syndrome was confirmed by the presence of group A strep in the blood, hypotension at less than the 5th percentile requiring fluid administration as well as vasopressors, and the presence of renal impairment, coagulopathy, as well as hepatic involvement. In the case of toxic shock syndrome, the cornerstones of management include fluid boluses, as well as monitoring of organ dysfunction to see if there's worsening, the administration of IV antibiotics, predominantly penicillin, as well as clindamycin, and the duration of that should be for at least 14 days. The administration of IVIG or intravenous immunoglobulin, which is recommended for 3 doses. The first dose, which should be 1 gram per kilogram, followed by 0.5 milligrams per kilogram on days 2 and 3. The data for IVIG administration, however, is somewhat limited. And last, management of any other potential complications, especially those that are surgical, like pyomyositis, osteomyelitis, abscess formation, necrotizing fasciitis, or other complications. Invasive group A strep doesn't carry a very high mortality rate that ranges between 2 and 38%. During the COVID pandemic, strep infections reached a historic low, but in late 2022, group A strep infections in children began to increase, and preliminary data suggests ongoing increased rates of invasive group A strep disease. I've shared a few resources here that you're welcome to note. And thank you so much for allowing me the opportunity to present this case.
Thank you, Dr. Catherine. It's a really interesting case. If you have any question for this case or previous cases, you can put in the question and answer box, and we will try to answer this question. We'll move now to the 5th case, will be presented by Dr. Tim Dribbin. Dr. Tim Dribbin, will present one case, very interesting, 2 years old with leg limping. Welcome, Dr. Dribbin.
Hi, my name is Tim Dribbin, and I'm an Associate Professor of Pediatric Emergency Medicine at the Cincinnati Children's Hospital. It's an honor to present today, and this is an interesting case that I had. My funding is shown here. I have no conflicts of interest to report. In the emergency department on an overnight shift, a resident came up to staff a patient and said, I have a 2-year-old male with a left leg limp that's been going on for 2 days. The patient had some tactile fevers, but the parent didn't measure the temp. They went to an emergency department before today's encounter and had a normal x-ray and was discharged home. And then they returned to that same emergency department because now they had fever up to 102. At the outside hospital, they had a white blood cell count obtained that was 24, an x-ray of the left lower extremity that was reported as normal, and then they obtained blood cultures, but no empiric antibiotics were given, and the patient was transferred to our facility for definitive care. The only noted history was of eczema. The resident reported the vital signs that the patient was febrile, tachycardic, low tachypneic, blood pressure and oxygen saturation were reassuring. The resident described the patient as being angry and upset, and the exam was very difficult to obtain due to patients being very uncomfortable. The resident said that he thought that the left lower extremity was abnormal and that there was pain when he was trying to examine the extremity, but it was difficult to determine the precise location of where the pain was originating from, given that every maneuver that the resident did seemed to elicit pain. What to do next? The resident wanted to continue with, the differential and what he thought the source of the pain was, and I stopped him and said, hey, what do you think is going on here? What do we need to do emergently? And I said, I think this kid's septic. So we notified the rest of the team that we were concerned that the patient was in septic shock. We made sure that we had good IV access, obtained additional labs, began aggressive fluid resuscitation, and then gave empiric ceftriaxone and vancomycin. The differential at this time was potentially osteomyelitis, septic arthritis, pyomyositis, or necrotizing fasciitis. On my exam, I agreed that the left lower extremity was bothering the patient. The left knee was overall reassuring, just with a small joint effusion, but I could range the knee. The left hip was in a pretty neutral position, so I thought that a septic joint was less likely, but it was difficult to fully exclude at that time. Because of this, I thought a bedside point-of-care ultrasound would be helpful to make sure that the hips were reassuring and that it could exclude the need to obtain a hip arthrocentesis or consult orthopedic surgery emergently in the emergency department. This is a hip ultrasound of the right hip, and as you can see that the femoral neck there, that there's no effusion. And then the involved left hip, this isn't You can't see it quite as well, but the left hip was also reassuring against a hip effusion. So at that time, I thought septic arthritis was unlikely and that it was more likely to be osteomyelitis or another source of infection. We obtained additional labs. The blood gas was overall reassuring, as well as the lactic acid, which was only 1.1. ESR and CRP were elevated, which was consistent with our differentials. And then the creatine kinase was also reassuring, as well as AST, which can sometimes be elevated when muscle is involved. The next steps after resuscitating the patient is we knew the patient would need to go to the ICU because they remained persistently tachycardic. We thought the patient would require an MRI, but at this time was not safe to get an MRI, especially because he would have to be sedated to do that. We thought we had adequate source control at this time and there wasn't a need for additional antibiotics. So the patient was admitted to the ICU. They decided to add clindamycin. An MRI was obtained when the patient's condition stabilized and demonstrated left distal femoral osteomyelitis with a multifocal intraosseous microcollection versus devascularized bone. And there also was a subperiosteal fluid collection that was 6.6 centimeters. Based on these findings, orthopedics took the patient to the operating room for drainage, where they obtained cultures. And the wound cultures and the blood cultures both speciated to be MRSA. This is just a trend of the patient's vital signs. The temperature slowly started to come down during the course of the hospitalization, as well as the heart rate. The patient was tachycardic up into the 200 range for quite a while, which just showed how sick he was. The white blood cell count and CRP also started a downtrend in response to the antibiotics and the surgical procedure. The patient was ultimately discharged on a 6-week course of clindamycin and follow-up in orthopedics and was doing well. The learnings from this case was that I always try to reemphasize to my trainees, especially the fellows, that although it can be important to try to figure out what your differential and ultimate diagnosis are, there are some conditions, especially with sepsis, that you need to resuscitate first. So for this patient, it was key to aggressively fluid resuscitate, give empiric antibiotics, and then obtain more labs to really find out what the source was. I also think point-of-care ultrasound can be incredibly helpful, especially when you don't have a reliable exam. Ultrasound of the hip joint is very easy, and it can help either confirm that you don't think the joint is involved or potentially identify that as the source, which would help narrow your differential and determine the need to involve subspecialists. Also with this patient, it was, although we thought it was a musculoskeletal etiology of the infection, we also thought that it was important to keep a broad differential and then to narrow. And ultimately, we knew the patient would get an MRI and have orthopedics involved in the ICU to help narrow that differential and arrive at the final diagnosis. Thank you very much, and I appreciate the opportunity to speak with you today.
Thank you. The last case will be again with Dr. Drebin. He will present one case, interesting case, 23-month-old with short bowel syndrome, presented with the history of lethargy. Welcome back.
Hello, my name is Tim Drebin, and I am an associate professor of pediatric emergency medicine at Cincinnati Children's Hospital. It's an honor to speak with you today about an interesting case that I had. This is my funding. I have no conflicts of interest to report. The title of this talk is How Short is Your Gut? The history of present illness is a 23-month-old male with a history of short gut syndrome was transferred from the gastrointestinal clinic with lethargy without fever. The past medical history is the patient has short gut syndrome secondary to midgut valvulus malrotation as an infant. He had 28 centimeters of small bowel resected, currently has a central line, and is TPN dependent. The initial vital signs in the emergency department were as above. The patient generally was lethargic, would move a little bit to painful stimulation, but wasn't moving much. Mom said that the child normally is able to walk around and have a normal developmental milestones. He had generalized weakness. couldn't sit up on his own and was unwilling to walk. The reflexes in the lower extremity were normal. The differential at that time was broad. Sepsis was on the top of the differential, given that children with short gut syndrome and who have a central line are at high risk of central line infections. Also encephalopathy, a possible metabolic versus infectious. Could there have been an ingestion, a trauma, seizure, stroke? However, there did seem to be no asymmetry to the movement. Could it be a Guillain-Barré syndrome or a transverse myelitis? The differential at that time was very broad. The initial evaluation and management, we obtained blood cultures and extensive labs, gave the patient fluids, and then we also ordered antibiotics just because we were unclear what was going on and sepsis was high on the differential. But at that time, we got the labs back, and the blood gas showed that there was a metabolic acidosis with a pH of 7.25. You can see the electrolytes here and an anion gap of 28. The lactic acid was interestingly normal at 1.7. We got an ammonia, which was also normal, and the CBC, as you can see there, was reassuring. Again, so that cannot exclude sepsis, but it was odd that the white blood cell count was overall reassuring. What to do next? Fortunately, the hepatology attending came down to the emergency department who knew the patient. He said, "This is D-lactic acidosis. Please do not give antibiotics. Instead, give a lactated Ringer's bolus and start sodium acetate through the fluids." And I said, "Really? No antibiotics? I mean, he's altered, not at baseline, has a central line, short gut, seems to be at high risk. Is there a downside of covering?" I said, "Nope, he will be fine. Just do as I say." We planned to admit the patient to the ICU, given that he was altered and we knew that the floor would not be comfortable with the patient. And the ICU team said, "Really? No antibiotics? What's the downside?" I said, "His exam has improved. We started the fluids with acetate, and the patient's mental status has continued to improve as the fluids have been running down here." The ICU team said, "Really? No antibiotics? So that seems a little crazy." But I said, "Look, the hepatology attending thinks this is fine, and the patient's condition is improving with these therapies," which does seem a little inconsistent that if this was sepsis, I would think he'd be getting sicker at the time. So this shows some of the labs from the patient's course. As you can see, the initial pH was low, and then it's steadily increased to normal at 7.4. The bicarb also started to improve over time, and then you can see that the anion gap started to trend down as well with the IV fluid administration. And then we got the D-lactate bath. That was a send-out lab, so it took a little time, and it was elevated at 7.97, which is above the normal limits, confirming the diagnosis of D-lactic acidosis. So this is the first time I had encountered D-lactic acidosis. That was not previously on my differential, and I learned a little bit more about the difference between L-lactic acidosis, which is what we commonly see, where pyruvate is converted to L-lactate through lactate dehydrogenase. And that's usually what we're measuring when we're looking for septic shock, and that's what is our common lab that we obtain for clinical reasons. However, D-lactic acid can occur in patients with short gut syndrome because they're at risk of impaired digestion in the small bowel, leads to increased delivery of sugars to the colon, and there's excessive fermentation by gram-positive anaerobes, which reduces the pH in the colonic lumen. And this can result in bacterial overgrowth. And then, as you can see here, you can get the eventual accumulation of L-lactate converted to D-lactate. D-lactic acidosis can result in neurologic changes, so that's one of the defining features that patients have a metabolic acidosis. Their lactate is normal, and then you do the send-out lab, and their D-lactate is elevated, and D-lactate is neurotoxic. This is just a case series of patients with D-lactic acidosis. As you can see, the sample size is pretty low. It's very uncommon, sample size of 29, but altered mental status occurred in all 29 patients, so that's one of the most predefining things. Patients can have slurred speech, ataxia, gait disturbance, so all of what we were seeing in this patient fit with the diagnosis. A summary of D-lactic acidosis. It's an anion gap metabolic acidosis, normal conventional lactic acid, as we saw in this patient. The D-lactic acid should be greater than 3 millimoles per liter. And the treatment for this is fluid resuscitation. We added sodium acetate, and then to treat the bacterial overgrowth, which is what the hepatology team did. The learnings from this case is that yes, you have to maintain a broad differential in children with short gut syndrome. It's easy to jump to septic shock, and it's probably no one would have faulted anyone for giving antibiotics in this situation, especially because it was an uncommon presentation. However, D-lactic acidosis is a risk factor in these children, so it will now definitely be on my differential. Also, I think it's really important that with some of these presentations and children that are so complex with so many comorbidities, consultants are our friends. So it's not, it's wise to reach out to them early to say, is there anything else that we should be considering in our differential? In this situation, it was really helpful for the hepatology attending to help narrow the differential and also prevent unnecessary antibiotic exposure, given these children are exposed to a lot of antibiotics over their lifetime, given that they're at high risk of needing antibiotics. So in this situation, the consultants was very helpful in narrowing the differential, initiating also the appropriate therapy early, and then the patient's condition improved, and hopefully his outcome improved as well. I want to say thank you for letting me speak with you today. Again, it was an honor, and please reach out if you have any questions. Thank you very much.
Thank you, Dr. Driven. It's a very interesting case. Now, if you have any question about that, all the 6 cases, we can just put in the box and we try to answer that question. Now, Dr. Muhammad, do you have any comment about this one?
Yes, thank you very much, Hamid, and thank you. Many thanks to our speakers and also our attendees. I think if you like, we can continue. Dr. Saleh, you have any question? I can see you are.
Thank you.
So we can start like in 5 minutes with the last session with you, Hamid. We have the last, I think, 3 lectures, and Dr. Hamid will be with you. We'll start in 5 minutes. What do you think, guys? Like in 45. Is that okay with you?
It's okay.
Yeah, I can see many people, they are saying, okay, we can start in 5 minutes. So Hamid, in 5 minutes, we can start, and Khulud, you can start, please, in 5 minutes.
Session for second day. We'll start by Dr. Prof. Mohsen. Prof. Mohsen, he is Sayyid Injad. He's a professor of emergency medicine and pediatric, and at David Geffen School of Medicine at UCLA. He is also served as the director of the Institute of the Health Service and Outcome of Research at the Landquist Institute for Biomedical Innovation at Harvard, UCLA. He will be presenting a very important non-traumatic surgical case in the emergency for children and how to manage what's a good approach for this patient. Welcome back, Prof. Mohsen.
Hi, I'm Dr. Saidinejad. I am a professor of pediatrics and emergency medicine at the David Geffen School of Medicine at UCLA. I also serve as the director for the Institute for Health Services and Outcomes Research at the Lundquist Institute for Biomedical Innovation at Harvard UCLA. Today, I'll be speaking to you about non-traumatic surgical emergencies in children. Here's my outline, and these are the conditions I'll be discussing. So I'll start with acute appendicitis. This is one of the most common abdominal surgical emergencies in children throughout the world. And it is critically important for appendicitis to be diagnosed on time and early in order to avoid some of the complications that arise from late diagnosis, such as perforation, which results in peritonitis, abscess, septic shock, and even death. So normally appendicitis is more common in children who are in the adolescent age group and also in the young adults. However, it's important to recognize that appendicitis can occur at any age, and even smaller children are at risk for developing appendicitis. So it's very important to have high index of clinical suspicion and be able to consider the diagnosis of appendicitis in order to be able to make a timely diagnosis. And despite all the technological advances, surgical skills, diagnostic methodologies, appendicitis still remains a significant cause of morbidity and complication in children. So as you can see here, appendicitis rates differ in different parts of the world, and it is important to recognize that children in different parts of the world are affected disproportionately. Here, as you can see, the age standardized prevalence rate for appendicitis in 2019 was anywhere between 1.9 to 51 cases per 100,000 population. In Bangladesh, Bhutan, and Peru, they had the highest rate of appendicitis, whereas Ethiopia, Kenya, and Indonesia had the lowest rates of appendicitis in children. Here again is the same representation that shows you that the countries that are in the Latin America and the Andean regions have the highest area prevalence of appendicitis, and also countries that are high income within the Asia Pacific and Central Latin American countries are also at higher rate of appendicitis. And on the flip side of this, the East Sub-Saharan Africa, Western Sub-Saharan Africa, and Oceania had the lowest rate of pediatric appendicitis. This is the demographic variables by age and by gender. As you can see, that appendicitis is most common in young adulthood. The rate is really increasing between 10 years to 25 years. And there is slight predominance of females in that age group, but overall, appendicitis is a little bit more common in males than female, as a 1.4 to 1 ratio male to female. So in order to be able to diagnose appendicitis accurately, obviously you have to consider the age and gender. You have to consider the duration of pain. It is important to recognize whether or not the maximal point of pain and tenderness is in the right lower quadrant. And also it's important to notice that this pain exacerbates and worsens with movement. Often appendicitis patients do have guarding and rebound tenderness. Fever is also a helpful hint, as is vomiting and diarrhea. Leukocytosis with left shift with increased neutrophils is also among the consideration for appendicitis. So in order to investigate for appendicitis, we often do a complete blood count with a C-reactive protein and erythrocyte sedimentation rate. We'll do a urinalysis. We do use appendicitis scoring tools quite often, and there's many of them. I'm not sure if you all use appendicitis scoring tool, but they are part of the diagnostic information that you need. You do also have to consider the imaging. Ultrasound is becoming more common, even though ultrasound is extremely user dependent. At my institution, we're not very good at visualizing appendix. We're good with many other things, but at my institution, I really can't trust ultrasound too much. In the ideal scenarios, appendicitis can be diagnosed with ultrasound in as many as 65 to 70% of times, given a highly trained ultrasonographer. CT is kind of a diagnostic of choice, but the concern is also with radiation, because a CT abdomen and pelvis with IV contrast is about 5 millisieverts of radiation, and in a small child, every 300 to 600 CTs, you can cause one case of solid tumor, so that's a lot of radiation. MRI, the problem obviously is the time, cost, and a radiologist who can actually read MRIs very well. So that's the challenge with those modalities for imaging. There are a few different types of appendicitis calculators. I like the pediatric appendicitis risk calculator that you see here under MedCalc. It actually has a score for male versus female, looks at duration of pain, looks at white count, neutrophil count, presence of pain with walking, maximal tenderness being in the right lower quadrant, guarding, and migration of pain, usually from the periumbilical to right lower quadrant abdominal pain. So it's pretty straightforward, and it's a decent score to use. There are also consideration with respect to antibiotics that you prescribe when you do see appendicitis. It is often surgical, especially in smaller children. In adults, there are trials that have recently been published that show kind of a wait and see with antibiotics, but in children, we still consider a great deal of these cases to be surgical. Penicillins are one group of medications that we use. If you consider perforation, you should use more of the newer generation, more comprehensive penicillins. Gentamicin, metronidazole, clindamycin are also options, and cephalosporins as well. Some places use even the newer generation cephalosporins, like the imipenem group carbapenem group, such as ertapenem. But at my institution, we use ceftriaxone with metronidazole as a 2-agent. So just think about the risk of perforation when you're considering that. Very important to consider the analgesia that goes with that, and vigorous intravenous hydration, and nothing by mouth. Intussusception is the next one I wanted to talk about. The incidence of intussusception is between 26 to 38 out of 100,000 live births. It is more commonly diagnosed in the first 3 years of life. I have seen myself intussusception at ages like 7 or 8 even, but every one of those cases has had a history of recurrent intussusception, meaning that their first episodes was when they were 2 or 3 years of age. So typically intussusception is most common between 6 months and 36 months, and 60% of those are usually under 1, and 80 to 90% of them are under 2. Certain groups are more affected. In African, Eastern Mediterranean, Southeast Asian origins, more than 80% of intussusceptions hospitalization were in the first year of life. As you can see, as it gets to the Americas, that proportion decreases. Europe is even lower, and Western Pacific is even lower than that. So for intussusception, always have to consider anatomic predisposition. It's just certain ways the bowels are progressing in the abdomen. You have to consider things like infectious etiology. If you have mesenteric lymphadenitis, that can consider as lead point for the ileocecal intussusception, and 30% of the cases where you have this, there is a preceding viral illness that contributed to the mesenteric adenitis. Intestinal inflammation itself, people who have inflammatory conditions are at high risk. Those where there is altered peristalsis, like a Henrich-Scholl purpura, could be a risk for intussusception, and those who have functional abdominal pain, bowel disorder, constipation, and things of that nature can also be at higher risk for intussusception. There's additional consideration for intestinal pseudo-obstruction as well with functional abdominal pain. And again, the table that you see on the right shows a little bit more about things that can increase your risk of having intussusception, and that includes certain viral illnesses that increase the risk, as well as celiac and cystic fibrosis. Typical diagnosis of intussusception is in children under 2, of course. Acute onset, abdominal pain that's extremely colicky. Sometimes there's vomiting at the onset of pain, but that does not necessarily need to be present. Children often are described as moving their knees to their chest in excruciating pain, crying and irritable, and then it resolves within a few minutes by itself, and they return to normal activity. But a lot of times they are describing sleepiness and lethargy in between episodes. And this picture you see to the right, the current jelly stool, again, I have rarely seen that happen. So it is listed in the many textbooks that this is a feature of intussusception, and also palpable such like mass, which I have probably felt once or twice in the many years I've been a pediatric emergency medicine physician. So typically, there is no underlying cause identified. So idiopathic is the most common. Usually it's benign. There is no underlying major structural problem. You just need to have the high index of suspicion. In terms of imaging, you could do a plain X-ray and look for target sign. Again, these are rare. Most of the times you are not going to see a target sign, but that does not mean the patient doesn't have intussusception. So it's a very low sensitivity. Ultrasound is very, very good. It's both sensitive and specific. You can do an ultrasound even when the patient is in between periods, when there is no active intussusception going on. Also, ultrasound is non-invasive, and therefore is considered a diagnostic modality of choice. And you can do CT or MRI, but usually that is not done to diagnose intussusception. It's done when you're concerned with some other major intra-abdominal pathology, And incidentally, you find that the root cause of the problem was intussusception. So that is not a diagnostic purpose, but sometimes it's a discovery from a CT and an MRI that leads you to find an intussusception. In terms of management, ileocolic intussusception is most common type. Is usually ultrasound-guided fluoroscopic pneumatic reduction or hydrostatic enema. So it doesn't have to always be a surgical emergency, but it could be when it's not successfully reduced. So when it's successfully reduced, it has a chance of recurrence. So you admit them to the hospital for 24 hours of observation. Surgery is always needed to be on standby in case it re-recurs and doesn't reduce, or it doesn't reduce the first time. So that's why I included that in non-traumatic surgical emergencies, because I've had a few cases where they had to go to OR to surgically repair the problem. Next, we're going to talk about hypertrophic pyloric stenosis. This is about 2 to 5 out of 1,000 live births, so not uncommon, and it varies by demographics. So whites are at higher rate of pyloric stenosis than Asians and Black. Female to male ratio is male to female ratio is 4 to 1, so males are much more likely to have pyloric stenosis. Usually, we say firstborn male between 3 to 8 weeks of age. There is usually polygenic familial link, so it's not an exact familial link, but there are indirect links that allows people within their family to be exposed to that risk. There is some literature that suggests that potential postnatal exposure to erythromycin can increase the risk of pyloric stenosis, and other factors such as bottle feeding have been reported, preterm birth, cesarean section delivery. Again, I've said about firstborn babies that are 30 to 40% of the cases. I'm not sure why, but that's a common theme. And also, it is thought that smoking during pregnancy increases the risk by 1.2 to 2 times. I think smoking increases the risk of everything. So this is just one other element to consider with smoking. So with the pyloric stenosis, the typical story is that it starts with vomiting. It starts to become more and more frequent. It's non-bilious because it's proximal to the ligament of Treitz, so it's always non-bilious. Usually the right age baby. It's projectile and forceful. And typically the baby, especially in the beginning, is very hungry and really wants to drink. But then over time, as they vomit, they become really dehydrated. They become irritable. So the first early phase is not an ill-appearing agitated baby. It's actually a well-appearing afebrile baby who sucks vigorously. But then later stage, they become dehydrated and they have metabolic alkalosis, lethargy, and they don't look so well. So that's a later case of unattended to hypertrophic pyloric stenosis. In terms of labs, the electrolytes will show hyponatremic, hypokalemic, hypochloremic metabolic alkalosis, And in terms of imaging, ultrasound is the diagnostic of choice. It's the measurements of the pylorus with a thickness of greater than 3 millimeters, transverse diameters of greater than 14 millimeters, and a length of 15 millimeters. So if you remember the term pi, 3, 1, 4, 1, 5. So 3 millimeter thickness, 14 millimeter transverse diameter, and 15 millimeters length. So that's kind of a cool way to remember that. And again, the ultrasound, you can see hypertrophic pyloric stenosis on the right. Most important elements is to provide hydration, correct electrolyte balances, and pyloromyotomy is the way to correct this. More and more now they're doing this laparoscopically. It is curative, has few complications, few sequelae. Both the laparotomy or laparoscopy have pretty good safety profile, except as you can imagine, the laparoscopic is much cleaner, less invasive, and less risk of post-op complications. Then we're going to go on to malrotation. So malrotation happens in about 1 in 6,000 live births. The majority of them do not present with any symptoms for most part. There's a 2 to 1 male to female ratio. And most common type is when the intestines don't rotate as they should after gastrulation. And 2 per 1,000 for upper GI is when they discover them, when especially in a patient whose exam is not clear, and it's a diagnostic choice to rule it out. 30% of the cases of malrotation happen in the first month of life. Usually more than half of them show up by 1 year of age. There is also cases reported of malrotation in the adults, but that is extremely rare. That's why there are case reports. And 75% of them should show up by the age of 5 years. So even though the majority of them are in the first month, you can go on and not know about it for a couple of years. Usually it's a genetic mutation in the BCL6 gene, which basically causes abnormal location of the cecum and the fibrotic band from the cecum to the retroperitoneum that passes over the duodenum, and that kind of constricts and causes obstruction and decreased blood flow. So essentially that part of the gut is strangulated. And it is associated with other conditions such as congenital heart disease, congenital diaphragmatic hernias, omphalocele, and other complex anorectal malformations. Usually the typical presentation is bilious emesis in a smaller child with abdominal distension, and sometimes they present in hypovolemic shock, and there is signs of peritonitis, and occasionally you do see hematochezia. Again, I have not seen every case of this being hematochezia, but it is reported to be a feature. I've had a few malrotations where there was no hematochezia in them. In terms of imaging, plain radiograph, which again is hard to see every time, shows the double bubble, classic double bubble sign, air-filled stomach and proximal duodenum, but beyond that there is no gas, so essentially everything stops at the proximal duodenum, and those areas are more prominent. The ligament of Treitz is usually on the right side of the abdomen instead of the left, so if you can make that anatomic connection, you will know, and that kind of results in a corkscrew duodenum, which is basically areas where contrast doesn't fill, and has a beak-like appearance if there is a volvulus that is also associated with a malrotation, and then there's what they call the absence of a C-loop of the abdomen. Ultrasound usually or CAT scan show absence of retromesenteric and retroperitoneal segment of the duodenum. Again, I think for this one, most often I rely on upper GI series. This is not one that I have had great experience with ultrasonography as the primary mode, but in our program, we do a lot of ultrasonography, being that our EM residency program is very engaged with ultrasound, so sometimes residents do actually look for it, and sometimes we do see, but officially upper GI is the way we diagnose these. In terms of investigation, CBC with differentials, lactate, electrolytes. The picture of the electrolytes will be hyperkalemia, hyponatremia, hypochloremia, and metabolic acidosis. That pretty much, other than hyperkalemia, the rest of it is similar to pyloric stenosis because of the vomiting. The treatment for that, I'm not going to go into that. I'm not a surgeon, but it's the LAD procedure, which first looks for a volvulus that needs to be reduced. It takes out the mesenteric bands if they're there, and place small bowel on the right and large bowel on the left of the abdomen. So basically replaces the positioning. They always do an appendectomy because the structure are too close to the appendix, and they can put the appendix at risk for inflammation. So they take that out just to get it over with. And it's not a corrective, but all they do is basically, it's kind of like when books fall out of the shelf, you put them back. It's not a correction, but it's rather repositions the bowel in a way that it decreases the chance of it twisting on each other, which is an important thing to do, but it's basically causing the bands to be taken out and then the position of the bowels to be taken to the normal position that they should be in. Next, I'll talk about testicular torsion. That usually is a surgical emergency. Scrotal pain that usually is somewhere around 0.5% of all the emergency department visits. Of all the scrotal pain complaints, about 15 to 25% of them will end up being testicular torsion. Again, depends on where you are. In children, especially, that number holds true. In adults, not so much, because they have many other issues that cause scrotal pain. But in children, it's pretty straightforward. Most common is a bimodal distribution, first year of life, and then between the ages of 12 and 18 are common findings. Certain anatomic problems, such as you can see on the right, the bell clapper deformity is a risk factor for developing torsion. Somebody who's had an orchiectomy has a single testicle. If it's not pinned properly, that also has a risk for torsion of the remaining testis. Annual incident, as you can see, is almost 4 per 100,000 per year for boys under 18 years of age. And the diagnosis, obviously, a lot of it has to do with history and physical. Timeliness is very important. We usually say 4 hours. We want to be able to diagnose this within 4 hours. And if the exam is consistent and highly suggestive of testicular torsion, you don't need to get any imaging. You need to get as soon as possible to a urologist for correction. I have done manual reduction of testicular torsion before. Sometimes it works, sometimes it doesn't. But if you want to do that yourself, make sure the patient has a little dose of Versed or something, so kind of calm them down. And then you have to make counterclockwise turns. Each turn you make is a half turn, so you have to make at least 4 turns, which means 720 degrees. If you can successfully do that and you have ultrasound on, sometimes you can see that the flow immediately starts coming in. It's a very satisfactory feeling, at least temporary. But they still need to go to OR and get surgical pinning. If you don't have a clear-cut diagnosis of testicular torsion, but you're questioning it and you're considering it, then the next thing to do would be Doppler ultrasonography of the testicle and of the scrotum. And if you do not see blood flow that's consistent with surgeon, that's an exploration. You need to talk to urology. If you see normal or increased blood flow that is consistent with inflammation or of the torsion of the appendix testis, then nothing further is needed. If you're considering epididymitis, of course, UA, and then try to treat that if there is anything that's found there. And the differential diagnosis is not that wide, but there is some other consideration to make here, and the table to the right is going to talk about those. I would say epididymitis is the closest, most important that you want to consider. For testicular torsion, usually it's an acute onset of unilateral pain, and 20% of these patients show up with abdominal pain only. So it's important to do a testicular exam every time you have somebody with abdominal pain. Typically, you would have some nausea, may or may not have vomiting. There may or may not be preceded by trauma. Again, I put this under non-traumatic surgical emergencies because most of the times there is no trauma that they're aware of. So it's technically considered non-traumatic. And overlying skin changes, it's more of a later finding. You might not see it in the beginning. But one thing that it is pretty important to consider is if you see a horizontal testicular position or lie, and the testicle appears to be high riding, that is consistent with a torsed testicle. So that should be part of your abdominal exam. Absence of ipsilateral cremasteric reflex. Again, some people are not able to get that demonstrated. So if you can, and you can demonstrate is negative, no cremasteric reflex, that helps. And sometimes the intermittency of the pain can suggest intermittent testicular torsion. So those are a very important consideration. Again, this is the picture on the right that shows a normal lying testicle versus a high riding and horizontal lying testicle. In terms of investigation, likelihood is based on, actually there's this scoring system called TWIST appropriately. So testicular swelling gets 2 points, hard testicle gets 2 points, no cremasteric reflex gets 1 point, high riding testis gets 1, and nausea vomiting gets 1. So if you have a score of 5 or greater, that positive predictive value of that for torsion is pretty high, and you consult urology. If the score is 0 to 2, negative for torsion, 100% negative predictive value, then you don't have to do anything. Now, if you're comfortable with that, this is a really good way to do this, but If you're kind of falling into the 3 to 4, which is a lot of times where we fall, then you have to do investigation and try to get urology consult. We tend to stay on the side of caution, and unless it's 100% negative, we don't say. I mean, if the score is not 0, I guess what I'm saying is that we don't stop there. In terms of investigation, ultrasonography with color flow Doppler is the way of choice. So you get 90 to 95% sensitivity. Again, this is operator dependent, but a lot of sonographers are very good at getting this for you. So it's not as bad as appendicitis. Nuclear medicine scan, which is not available, especially in odd hours and not in every institution. It is sensitive 95% if you can get it. But since ultrasonography is so sensitive anyway, I don't see why one would go to to nuclear medicine scan. MRI is only good for alternative diagnosis, incomplete torsion. It's also expensive and not easily available. Surgical exploration, I would say, is the gold standard, but this would also be done because of the need for testicular salvage optimization, or if you need to do orchiectomy. Bottom line is you go look, and if it's torsed, it's torsed. So that is the most accurate, but not every patient can get to a point where they have to go to OR. So that is not practical in every case. And then here's again several pictures showing the inflammation, the lack of blood flow, the horizontal lie on the lower B, and basically how ultrasonography is able to diagnose testicular torsion. Last one of these I wanted to talk about is ovarian torsion. It's 3% of all gynecologic emergencies. Incidence is about 6 per 100,000. Usually it's women of reproductive age, 10 out of 100,000. It's rare in the non-reproductive age, and rotation of the ovary over the adnexa causes ischemic changes in the ovary that usually involves both the fallopian tube and the ovary. And the risk factor is when you have an ovarian mass or cyst greater than 5 centimeters. So sometimes these patients that come in with ovarian torsion that we have seen before, we know they've had a history of either polycystic ovary, or we've had large ovarian cysts or masses. So that index of suspicion with that historical element together is very important. So recurrent abdominal pain in the lower abdomen without a clear explanation of anything else should be considered a red flag, especially reproductive age. Fever may or may not be present. Nausea, vomiting, usually present, but doesn't have to be present. And just like testicular torsion, the pain is often sudden onset and not really gradual. Investigations, we do HCG, CBC, electrolytes, and then imaging modality of choice is really ultrasound with flow Doppler. And we do MRI actually if ultrasound is equivocal, and we usually don't do CT for many good reasons, and radiation, and it's not really diagnostic. I've rarely had a CT being the diagnostic clinch for ovarian torsion. Again, our ultrasonographers are really good at this. Usually it's a good, easy skill, and it has good accuracy. In terms of managing, preferred is laparoscopic. It's again easy, cleaner, less complications, better recovery. But laparotomy might be more definitive because you might have a better field of view and can get around the entire scope of the problem, but it does have more complications and prolonged recovery time. And then just to conclude, there are other non-traumatic surgical emergency, which I'm not really going to get into, but foreign body in the esophagus or airway sometimes requires surgery, especially if it's magnets or multiple button batteries. Acute necrotizing enterocolitis, that could be its own talk by itself in children who are premature. Meckel's diverticulum is another one, Hirschsprungs, and incarcerated hernias. Those are additional non-traumatic surgical emergencies. So with that, I will conclude. And if you have any questions, please feel free to email me, and I'll be happy to answer those for you. And again, thank you so much for listening. I really, really appreciate this time.
Thanks. Dr. Mohsens, for your lectures. And I would like to introduce the next lectures about make it safe procedures. Should be not painful procedures from Catherine Remick. Catherine Remick, she's a professor of pediatric and surgery, preoperative medicines, associated chair quality innovations and outreach directors, National of EMS for Children Innovations and Improvement Center at Dalhouse Medical School at the University of Texas at Austin Medical Director. Welcome, Dr. Catherine. You can start now, please.
Hi, my name is Kate Remick. I am a pediatrician, a pediatric emergency medicine physician, EMS physician, and I will be speaking about how do we create a pain-free or relatively pain-free care within the emergency department setting. First off, I have no disclosures, and I assume responsibility for the scientific validity of the content of this presentation. My objectives are to describe the importance of pain assessment and management in the emergency department, to become familiar with how to assess and reassess pain in pediatric patients of all ages, and to understand some of the best practices for reducing pain in pediatric patients in the emergency department. Failure to assess and manage pain in a child can have long-lasting effects. In fact, it has been shown that these long-lasting effects can actually impact a patient and family's reaction, not just to the current medical care, but also to future medical care, and has been associated with long-term pain syndromes, anxiety, and the like. It's important to recognize that pain is the #1 reason why patients come to the emergency department, and failure to treat acute pain can and will lead to mistrust and potentially chronic pain. About 80% of all pediatric ED visits are indeed related to pain, and this is really the one symptom that brings them in to the emergency department. Additionally, trauma accounts for a large proportion of all of our pre-hospital transports in children. And only about 50% of EMS patients experience pain relief before arrival to the ED, despite being in the care of pre-hospital providers. Moreover, when it comes to comparing children versus adults, in general, children receive less pain medication or less pain treatment than the adult counterpart. Part of the reason for this may be that pediatric pain is often under-recognized and undertreated. Children often don't report pain or don't describe it well. And in general emergency departments, where so much of the focus is on the adult population, because adults often make up the largest proportion of patients, children are less likely to have pain assessed, less likely to have pain administered, and less likely to receive it quickly. And this can lead to worsening anxiety and distress that can then exacerbate the pain even more and make it increasingly more difficult to treat. The long-term effects of pain include increased ongoing metabolic rates and sometimes as far as cardiopulmonary instability. Prolonged pain can also depress the immune system and increase the risk for wound infections and/or poor physical health. It can lead to hormonal changes that affect brain function and also can increase pain receptor activity so that over time, pain becomes more and more intense. And lastly, prolonged pain can lead to emotional distress that makes many patients feel anxious and powerless, and it can lead to significant fear and subsequently poor adherence to medical treatments and recommendations. There are a number of potential barriers to pain management in the emergency department. Some people believe or have misperceptions that young children are less sensitive to pain, or perhaps that pain is a valuable life lesson, it's important to experience it. Or lastly, that if I provide opioids to my patient, that it'll result in increased addiction in the future. Unfortunately, or fortunately, none of these beliefs are in fact true. When it comes to practice, there are some concerns that are expressed as well, that sometimes in pediatrics, it can be really difficult to assess pain. And there may be some concerns about what happens if I administer this pain medication. Will the child stop breathing or slow down their breathing, or will there be other adverse effects? Sometimes there's limited knowledge of the techniques that are used in children to minimize pain, and or concern that perhaps they're masking the diagnosis. This is a patient with whom I suspect appendicitis. Will giving pain medication mask the potential diagnosis of appendicitis, and then I'm likely to send them home without appropriate treatment? Again, none of these concerns are actually true. So pain really should be considered the fifth vital sign and a diagnostic indicator to help guide pain evaluation and help guide diagnostic accuracy. Most importantly, we need to have awareness of pain so that we can make appropriate treatment decisions and reassess whether or not the pain is persisting or whether it's beginning to wane. Pain truly is the fifth vital sign, particularly because it is the primary chief complaint in 78% of all pediatric ED visits. Additionally, over a third of children at some point in their lives will sustain a fracture before the age of 16, which is associated with significant amounts of pain. And half of patients in these particular situations rate their pain as moderate to severe, yet only about a third receive any form of analgesia. It's important to recognize that when a child is feeling fearful or anxious, that this only leads to worsening pain experience. You cannot do adequate pain management without dealing with the accompanying fear. How we present ourselves, how we talk to patients who are experiencing pain, and how we coach them through the management of that pain response is critical. There are a number of strategies that can be used that help make an ED experience much more child-friendly and much less painful. Examples that are demonstrated here are intranasal administration of medications rather than through an IV or a shot, the placement of numbing medication on the hand to numb the skin prior to insertion of an IV catheter, distraction techniques, and lastly, sweeties or sugar-containing solutions that can help to distract the youngest of patients or infants. There are pain scales that have been developed for the younger pediatric population. In children under the age of 4, the recommended pain scale is called the FLAC scale, which stands for Faces, Legs, Activity, Cry, and Consolability. Each of these is given a score from 0 to 2 for a total value of 10, similar to numeric scales. In children who are at least 4 years old and up to 12 years old, the FACES scale may be used. This requires a child to understand social emotional development, where they can see an expression on a card and relate that to how they believe that person feels. This is why it's not recommended for children under 4 years of age. Simply looking at the face, the child is able to rate how they feel and therefore rate their pain on a scale of 0 to 10. In older children who are at least 7 years old, a verbal or numeric scale of 0 to 10 may be used. It can be helpful to print off these scales or use quick buttons, badge buddies that can be linked to identification cards for quick reference by any of your healthcare staff. Improvement in pain is associated with improvement in pain treatment. Not surprisingly, when we treat, the pain gets better. For patients who receive analgesics or opioid medications, we see an obvious increase in pain improvement or improvement with pain management treatment, as evidenced here. So let's speak a little bit more about these pain assessment tools. The Faces, Legs, Activity, Cry, Consolability Scale looks at each of these items and creates a numerical value based on the assessment. For the face component of this scale, what we're looking for is any signs of a clenched jaw or quivering chin, any distress in the face, or an expression of fright or panic would receive a score of 2. For the legs, consider kicking or marked increase in spasticity or tone or constant jerking of the legs, again, would receive a score of 2. Activity scale is really looking for any kind of severe agitation, head banging, shivering, breath holding, gasping, or any kind of splinting, all of which would suggest a score of 2. Cry, continual, steady, inconsolability, outbursts, or constant grunting would also be given a score of 2. And then lastly, consolability. If a child is difficult to console, pushing away the caregiver, resisting any comfort measures, again, this would be given a score of 2. Each of these components is added up to provide an overall score from 0 to 10. The Faces scale has been described, but again, the intent of this is for a child to simply point to the face that most relates to the level of care that they are experiencing. And again, in children over 7, the numerical rating score may be used. Here's a depiction of the Wong-Baker Faces scale. There are a number of different versions of this. Any and all are fine, but it's important to recognize that when a child scores 4 above, that this is considered to be moderate pain and really should warrant consideration of analgesia administration. While we often think of pain management as pharmacologic treatment, a number of other non-pharmacologic tools can also be used, including distraction techniques, such as giving children access to music or videos through small electronic devices. Sometimes simple small talk can be enough to distract a child from experiencing or focusing on their pain. Using a calm demeanor can be helpful as it helps to relieve anxiety that a child might be feeling. Making sure that the family or the caregiver is involved. And in the case of any kind of fracture, placing splints helps by decreasing the amount of movement around the fracture site. Allowing the patient to choose the position of comfort is also very important, as sometimes there are certain positions that may aggravate the pain that they're experiencing. And lastly, in infants, oral stimulation and physical contact can also be very helpful in decreasing the pain experience. Do not underestimate the impact of bubbles or other distraction tools. As demonstrated here, you can see that simply showing videos like this, or lights, sound, games, music, and even simply blowing bubbles made out of soap slime can really be distracting for a child and help them to get outside of the pain experience and be able to engage more easily with the healthcare environment. Virtual reality is a growing tool that's being used in the emergency care setting, where children are truly given videos that they can place over their eyes and head and believe that they're somewhere else, perhaps on an adventure through, an ice cave or wherever they might choose to be. But this really takes them away from the feeling of being locked in a healthcare facility. In the case of fractures, we often turn to the RICE's interventions: rest, ice, compression, elevation, and of course, splinting to minimize movement around the fracture site. Here's an example of a child being placed in a leg immobilizer. Most important, perhaps, is communication to the child. We should never lie to a child and always tell the truth. A needle does indeed hurt more than a simple mosquito bite, and that's true every single time. Always explain what you're going to do right before you do it. and try to use language that a child understands. Some organizations have gone so far as to create glossaries of terms that are described in language that even young children will understand. An IV, for example, is described as a small tube or a straw that's placed in your vein to get blood and give you medicine and give you water. This is language that a child can understand, as opposed to believing that perhaps a needle is stuck in their arm, or that they're getting a shot, or really not knowing what an IV is by any stretch of the imagination. These are some examples of other ways that we can replace our common words. So rather than saying something as we might to an adult, like, tell me when you're ready, instead saying things like, now when I count to 3, blow the feeling away from your body. And this is really a means of trying to get the child to engage in distraction techniques. Another example, rather than saying, I'm sorry, and apologizing, instead, you can turn to the child and say, you are being very brave. This is a form of encouragement. Other word replacements. It'll be really fast. Well, what is fast to you and what is fast to me? This can be difficult for a child to understand, because for them, fast might be less than a second. But for us, fast might be less than 30 seconds, which for them may feel like a forever. So instead, something like this. We're going to count to 5 together, and that's how long it will take. This gives them very specific information about when it's going to end, and allows them to try to address their fear or pain during that short period of time. When you have a beginning and an ending, then it's easier to manage the middle. And last, it is over, which really creates a negative focus. And instead, trying to praise the child for the great work that they did, and saying things like, you did a great job doing the deep breathing and holding still. And this really praises the child for their ability to manage their own anxiety and or pain during some of these procedures or events. When it comes to the very young infant, typically up to about 3 months of age, oral sucrose solutions can be very helpful and soothing. This is one such solution. It's called Sweeties. The idea is that you dip a pacifier into the solution and then allow the child to suck on it, and it creates some comforting because of the sugar response. It has been shown to be effective in reducing discomfort, and you can use it with, again, the pacifier. There's a number of commercial products as depicted here. Topical anesthetics cannot be overemphasized. These are critical, particularly when IV access is needed. IMLA and LMX4 are both topical agents that are mixtures of lidocaine that can be used over the skin, and when applied for 30 minutes or longer, they achieve a maximal effect where the skin is numb, and in most cases, children won't even feel the placement of an IV catheter. A Sanera patch is another alternative. This is a patch that has a 20-minute maximum effect, so a little bit shorter. And again, it's a mix of lidocaine and tetracaine, and it can be used both for IV placement, lumbar punctures, incisions and drainage, and even for joint aspirations. LET is a topical anesthetic that can be used instead on open wounds and lacerations. It too reduces pain as it's a lidocaine mixture, and typically is given in multiple applications over a period of time. It's often applied onto a cotton ball and then covered over the wound. And once it is allowed to sit there for up to about 30 minutes, then it creates numbness around the wound side, allowing for suture repair without further medication administration. A last option is small lidocaine wheels that can be done in the epidermis, so an intradermal injection right before placement of an IV. Typically, it's conducted 1 to 3 minutes prior to IV placement, and it's best to not just use straight lidocaine, but to actually buffer it 1 to 10 with a sodium bicarb and or warm it so that it lessens the acidity of it and the burning sensation of the initial injection. There are a number of medications that can be administered during the course of the ED visit that can help to decrease anxiety, decrease pain, and in some cases even decrease any kind of memory of the event. Nitrous oxide is one such medication. It's administered as a gas, and typically it comes in pre-mixed to make sure that we avoid decreasing the amount of FiO2 to less than 21%. So we always want to make sure that we maintain at least 21%. And now nitrous oxide is provided in pre-mixed doses, where it can either be given at less than 50% for analgesia or anywhere between 51 and 70% for sedatives. Typically, this is used in children over about 2 to 4 years of age, has very fast onset, and allows the child to actually apply it themselves. They can put the mask up to their face. In doctor's offices and dental offices, this is often used in the outpatient setting. And sometimes even the gas is sprayed with a nice odor or scent that allows the child to breathe in smells that smell like, chocolate or bubble gum or things of that nature. The effects do rapidly dissipate, so it's easy to administer, and it has a very low complication rate as long as there is a fixed setting for the percent of nitrous oxide in the solution. There is no one specific analgesic agent or intervention that's been identified as the best choice or the optimal choice in the emergency department for all scenarios of pain management related to musculoskeletal injury. So here are 3 examples of cases. Each of these is a 3-year-old child. The first is a boy who's struck on the forehead against his coffee table and has a large full thickness laceration that requires repair. The second is a 3-year-old boy who fell and struck his head on a cement floor. He had an impact seizure. His level of consciousness waxes and wanes, and he needs to undergo a CT scan to evaluate for possible intracranial hemorrhage. And last is a 3-year-old boy who has a Gartland type 2 supracondylar fracture that requires closed reduction and or splinting, but is experiencing significant pain. So let's talk about some of the potential options. So acetaminophen is typically given orally, doses of 10 to 15 milligrams per kilogram, and it can be given every 4 hours. There is also an opportunity to provide rectal administration, can come in rectal suppositories, and then also IV form, although this tends to be more expensive than most other IV medications for pain management. Non-steroidal anti-inflammatory agents such as ibuprofen may also be used for mild pain, and this is typically administered at 10 milligrams per kilogram per dose. The caveat here is that it's not to be used in children under 6 months of age because of renal dysfunction. Similar non-steroidal anti-inflammatory agents include naproxen, given at 5 to 7 milligrams per kilogram per dose, and ketorolac, which often goes by the name brand Toradol, which can be given intravenously or intramuscularly, and typically has a maximum dose of 30 milligrams. It can be used for 5 days or less, but should not be used with other non-steroidal anti-inflammatory agents. Codeine is another alternative, and it is a prodrug that's metabolized to morphine. Unfortunately, the challenge with codeine is that there is genetic variability in the rate of conversion and the experience or the effect of the medication on pain. In addition, it has led to some fatalities, or has been implicated in some fatalities, even with routine dosing. And for this reason, codeine is really not considered to be one of our first-line agents anymore. Instead, we've moved to more active medications such as oxycodone and hydrocodone. Oxycodone is administered as a single agent, typically The dose is 0.05 to 0.15 milligrams per kilogram. The initial maximum dose is typically 5 to 10 milligrams. 10 milligrams in a older child or teenager, and it comes in a variety of tablet sizes and oral solutions. Hydrocodone is typically administered in combination with acetaminophen. The dosing is 0.15 milligrams per kilogram every 4 to 6 hours. And again, the maximum dose is 10 milligrams, and it's also available in solution form. Morphine can also be given. This is a metabolized version of codeine, more effective, less dangerous. It can be given orally at 0.2 to 0.4 milligrams per kilo. Max dose here is about 30 milligrams, but typical doses are closer to the 10 milligram range, and it's supplied in oral solution. There are a number of intranasal medications that include fentanyl, typically given at 1 to 2 micrograms per kilo, ketamine, typically given at 3 to 5 milligrams per kilo, dexmedetomidine, 2.5 micrograms per kilo, and midazolam, which is often given at 0.2 to 0.3 milligrams per kilo. Fentanyl can be used up to at 1 year of age and up. The typical dosing as mentioned is 1 to 2 micrograms per kilogram as an initial dose, and it can be given IV intranasally or intramuscularly, and it can be repeated every 5 to 10 minutes up to a max individual dose of 100 micrograms. The typical onset of analgesia is 5 to 10 minutes, and it'll last up to 1 hour, though in many patients it's closer to 20 to 30 minutes. Ketamine is another alternative for analgesia, typically given in 0.3 to 0.5 milligrams per kilo. For sedation, it's given in a higher dose of 1 to 2 milligrams per kilo, or even 3 to 4 milligrams intramuscularly. The onset is typically within 5 to 8 minutes, and it lasts about 30 to 40 minutes, depending on the child. We found that in younger children, they tend to metabolize this medication much more quickly, and therefore recurrent administration is also often warranted for procedures. Midazolam is more of an anxiolytic. It does not have any analgesic specific properties, but is often used in conjunction with other pain management. The dose is 0.1 to 0.4 milligrams per kilogram. It can be given in a variety of routes, intranasal, intramuscular, intravenously. Typical onset is 5 to 10 minutes, and it lasts about 20 to 40 minutes. And then dexmedetomidine or Precedex is a medication that's often administered for pain management, typically in intensive care unit settings as even a continuous sedative or pain medication. It's typically given IV 2 micrograms per kilo, followed by an infusion, or it can be given intramuscularly or intranasally at the displayed doses. Most important is that we make sure children remain safe when we administer medications. It's critical to really think about weight-based dosing in these children and making sure that we're using length-based tapes or other tools to help us identify the most appropriate dose for this child based on weight and or height. So going back to our 3 cases, the 3-year-old boy who struck his forehead against the coffee table, the 3-year-old who fell and suffered a concussion, or the 3-year-old with an elbow fracture. For the first child, simply providing lead over the open wound and allowing it to sit for 20 to 30 minutes with the addition of distraction techniques such as video games, music, bubbles, can be sufficient to allow for complete surgical correction or suturing without any pain. For the second child who suffered a concussion and now has level of consciousness that's waxing and waning, his pain management may be best with Versed, fentanyl, and or dexmedetomidine to help address his pain. And then lastly, for the child with a supracondylar fracture that requires a closed reduction, these patients really need to be given significant sedation in order to not experience pain associated with these procedures. Nitrous oxide can be very helpful, as well as IV ketamine and or fentanyl administration. If there truly is a significant degree of closed reduction or pushing on a closed fracture, fentanyl alone is likely insufficient and better to go with a medication like ketamine or nitrous oxide. Regardless of which pathway is chosen, ideally we should be working towards standardization of pain management in the emergency department such that all providers and all patients are receiving the highest quality care. This is an example of a pain management decision support tool that could be used in any emergency department or pre-hospital setting. First and foremost is to use an age-appropriate pain scale to assess pain. Second is to consider narcotic analgesics to relieve moderate to severe pain, particularly in a child with a severe injury. Reassess pain every 5 minutes to evaluate for improvement, any adverse effects, or any ongoing persistent and significant pain that would require redosing or subsequent dosing of medications. Lastly, I'd like to share that there are tools out there to help guide. This is the Pediatric Education and Advocacy Kit that was developed through the United States National EMS for Children program. This is a free open access toolkit with pain assessment and treatment guidelines for the pediatric patient in the emergency care setting. It includes video clips, podcasts, infographics, and decision support guidelines that can be adopted in any emergency department. So my final points for creating a relatively pain-free environment for children in the emergency department is that we need to realize that untreated pain is a common occurrence in emergency care settings, and it can lead children to have increasing fear, anxiety, or lack of adherence to treatment recommendations provided by medical professionals. Treating pediatric pain generally requires a multimodal approach that includes assessing and treating pain early, using non-pharmacologic treatments in the beginning for distraction, comfort, and the like. And lastly, identifying the most appropriate pharmacologic treatment based on age and severity of injury. And all of this is really the key steps to making a commitment to an ouchless or relatively pain-free emergency department. And with that, I'm happy to take any additional questions. Thank you so much for taking the time to listen to this particular talk about reducing pain in the ED.
Thank you, Dr. Kit Rimac. This is very important to be familiar how to make that procedure and decrease the anxious and phobia by not painful procedure. So it's very important to be more familiar what's the good option in your department. Next speaker, Prof. Mariana Goshel. She will talk about traumatic orthopedic in emergency and how to manage what's the good approach for that cases. Thank you. Next, welcome, Prof.
Hi there, my name is Dr. Marianne Gaucher-Hill, and I'll be speaking to you on traumatic pediatric orthopedic emergencies. I'd like to thank the Saudi Pediatric Association for having us join you at this wonderful conference on pediatric emergency medicine. I am a professor of clinical emergency medicine and pediatrics at the David Geffen School of Medicine, and I'm interim CEO of the Lundquist Institute for Biomedical Innovation. All right, let's get started. We'll go to our first slide. First of all, I have nothing to disclose. And next, I'm going to talk to you about fractures in childhood. So things you need to consider are age and mechanism. Obviously, fractures are going to vary by age and ability to move, walk, and run. You want to always consider possible intentional injury, especially for young children under the age of 2. Consider soft tissue injury, open or closed, meaning because that will change your management. Fractures involving joints, as that will modify splinting techniques. Your exam must always include neurovascular function and consider x-rays of the joint above and below the area of injury. So some of the common fractures that we see are going to be typical green stick fractures, etc. The fractures that are concerning for abuse or intentional trauma is multiple fractures in different stages of healing, and any fracture other than the skull or clavicle in the newborn period. And even that a fracture of a skull could obviously be a sign of child abuse as well. So you really need to consider the mechanism, etc. Going forward, multiple fractures, again, in different stages of healing is going to be important in all age groups. When you look at rib fractures, any rib fracture in a 1-year-old and any rib fractures or fracture without a trauma history presenting with evidence of healing, it should be considered. A humerus fracture under the age of 3, other than a supracondylar fracture, is concerning for child abuse. And again, multiple fractures of long bones, it should be considered. So these are some of the fractures. It's a healing femur fracture on the left, a skull fracture complex, a singular linear skull fracture is more typical for a accidental trauma or non-intentional. And then, but complex fractures are concerning for abuse. Rib fractures, which is shown in the chest x-ray. And here you see a humerus fracture, which is new, and a healing fracture of the forearm that is concerning, obviously, for child abuse. This is your typical bucket handle, and this is your chip fracture, and those are also concerning for abuse. All right, let's talk about the most common fractures. These are green stick fractures, about 50% of them. 50% of fractures in children are green stick fractures. The classic that you can see is when one cortex of a long bone or a bone in the forearm is fractured, but the other cortical surface is not. A torus fracture is probably the most common that you see there, lead pipe and a bow. The bowing fractures are the most concerning. For classic green stick fractures, pain control, closed reduction, you don't always need to complete the fracture, but that is a consideration, and that would only be done in collaboration with orthopedics and then immobilize. This is the bowing fracture that I was talking about, and the way these present is that the arm looks deformed, and when you get the x-ray, you don't see a cortical break. These are microfractures. They may not show up on plain films, but if you compare from one side to the other, it looks visibly deformed. But again, there's no obvious cortical break. You need to think about a bowing fracture. And this is true. You can also do comparison views. In terms of a torus fracture, how do you treat those? This is a very classic green stick fracture. You can see in the upper radiograph with the arrow. That's the most common. You'll just see a buckle. These are often called buckle, and there's multiple views here for you. If it's in the distal forearm, really you can just use a wrist splint, and these heal pretty quickly in several weeks, and the time that you would take them out of it certainly for bathing, you can remove it. And these are pretty stable fractures, typically at least 2 weeks, and it can be up to 4 to 6 weeks. So let's talk about Salter fractures. You can see normal and the physis is intact. A type 1 is a fracture that goes through the physis. So that's a split. Type 2 goes through the physis and into the metaphysis. This is above, as you can see there. That's the most common. Type 3 is down in the lower left. That is less common, and it goes through the physis and into the epiphysis. And then what you see, type 4 is through. It's through both the physis, the metaphysis, and the epiphysis. And then a type 5, which is the rarest but most concerning, is a crush injury, and I'll show you some examples of that. So what you see here is a type 1 Salter fracture, just showing widening of the physis. So this is what you would see. This is a great example. If you look at the normal side and then this side, you see marked widening, okay, of the physis. This is a typical type 1, which is probably very, very common because, type 2s are the most common. And here you see through this is obviously, you can see here through the physis and into the metaphysis, through the physis and into the metaphysis here. This one is in the forearm. This is a double bone fracture. This is not a Salter fracture, but this is a Salter fracture because it involves the physis. For these, growth arrest is really unlikely. And here you go. Type 3, through the physis and into the epiphysis. And growth arrest can occur if it's markedly displaced, as in the diagram here. So that is concerning. This one is really non-displaced, so growth arrest is pretty unlikely. Growth arrest can occur depending on the how far the fragment is from aligning with the physis. So the most important thing is good alignment. If it can't be assured with closed reduction, then open reduction is necessary. Here's an example of a type 4. It is through the physis into the metaphysis and into the epiphysis as well. And this is an example, type 4 Salter fracture. So these can cause growth abnormalities. The one that's most concerning is this one, is Salter 5. And you can see there's bone on bone and that the physis has been crushed. And you can see by the white area, and this is bone crushing bone. And this has a poor functional prognosis. These all obviously are going to be managed by an orthopedic surgeon. So let's take a look at these and say, is this a Salter-Harris fracture? And what type of Salter-Harris fracture? And again, it goes through the physis, into the metaphysis, and into the epiphysis. Salter-Harris type 4. All right. We have a 16-month-old. Mother brings her in because child refuses to bear weight. Child has no medical problems, hasn't been ill. There's no history of a fall. Vital signs and exams are normal, except that the child limps when weight bearing on the left. So this is a classic history for a toddler's fracture, and sometimes the radiographs are quite subtle. I'm going to show you where the fracture is on this particular case. You can, if indeed the radiographs are read as negative, the child continues to limp, you can have a radiograph repeated 7 days post-injury, which may show the actual fracture. Bone scan can aid in the diagnosis, but it's you'd have to place an IV and it causes pain for the child. So we typically in our shop use radiographs and close follow-up. Here's some other examples of toddlers' fractures. You can see some are more obvious than another. And these occur, they were described by Dunbar, but these occur because the child is just, they're walking, but they want to run. And so they have significant kinetic injury, but they may plant their foot and change which direction they want to go. And that results in a spiral fracture that you can see on these radiographs. Key thing is pain control, a below the knee walking cast for 3 weeks. And if you're not sure, you could splint and repeat in 7 to 10 days. You can do a bone scan or a rapid MRI. Again, that can be problematic because the MRI, you may need to sedate the child. And then you just need to consider other injuries. Okay, this is a 7-year-old boy brought in by paramedics after a fall off his bike. And you can see he has significant swelling around the elbow. He holds his right arm in slight flexion, obvious deformity or swelling, and distal neurovascular is intact, and trauma is otherwise intact. If you look at his x-ray, what you see here, this is an anterior humeral line. What you see is that this is off. If you draw a line straight down from the anterior portion of the humerus, it should bisect the capitellum. And you can see here, there is an anterior sail sign, and there is a posterior fat pad sign. So this is the anterior fat pad, which can be normal, but a posterior fat pad is always abnormal. And again, this shows kind of notching. So this is going posteriorly. And always on every film, the radial head should line up with the capitellum. It does here, so there's no radial head dislocation. It's just drawing the anterior humeral line. It does not bisect the capitellum. So this is an example of a supracondylar fracture demonstrated on this X-ray as well. It's a distal humeral metaphysis just above the condyles. And the typical mechanism is what we call a foosh or a fall on an outstretched hand. And the posterior displacement, as I mentioned before, is most common. One of the concerns, especially with significantly displaced supracondylar fractures, are potential for median and radial nerve injuries. Also, ischemic injury can occur because we all know the nerves and the vasculature run together. So this is a diagram demonstrating the fat pad signs, and with a supracondylar fracture, you can see bleeding into the fat pad, which results in what is more dark. And here's an anterior sail sign and a posterior fat pad sign. The posterior fat pad sits in the olecranon fossa, and with significant bleeding, that fat is pushed outward. And you can see here in the diagram, the bleeding causes the fat to go outward, and you can see that as darker as compared to the other soft tissue. So posterior fat pad it indicates that there has been injury, not always a fracture, but a fracture needs to be considered. I mentioned this before, that the radial head should always line up with the capitellum on every single view, and this is an example of that, regardless of age. You see in each of these 4 radiographs, there are different views. The radial head should line up with the capitellum, and that means that there is not a radial head dislocation. Here's the anterior humeral line. You can see in the diagram, it should bisect the capitellum, and you can see with this, the radiograph on the right, that it does not bisect the capitellum. So very, very important. If it does not, then you need to consider a supracondylar fracture. Here's another supracondylar fracture, again, drawing the anterior humeral line. The other radiographic finding, this is, we call the figure of 8 or the teardrop. You can see how it is uniform. This one has been displaced, indicating a likely supracondylar fracture. This is how we categorize them in terms of the different classes. A type 1 supracondylar fracture or Gartland type 1, those are generally splint, long arm splint, and refer to an orthopedic surgeon for follow-up and casting. You could cast in the ED as well. A type 2, you see the notching that occurs with the posterior displacement. If it's a type 2, you would need an orthopedic consult. Emergency physicians can reduce these as well, but closed reduction would be necessary. And then type 3, these are ones that require operative repair, either anterior displacement or the most common, which is a 3A, is posterior displacement. These are the ones that are most likely to have neurovascular injury. So which classification is this? You see the posterior fat pad sign, anterior sail sign. There's some deformity here and notching. So it's beginning to be posteriorly displaced. So this would be a type 2, and this you can see posterior displacement. This is a type 3A. Okay, here's a quiz. Which of these is a Montesia injury? Remember I said that the radial head should always line up with the capitellum. A Montesia injury is a proximal ulna fracture associated with the radial head dislocation. So which of these is it? It would be A, and you can see, whoops, let me back up one. You can see that the radial head does not line up with the capitellum. So this is a Montesia injury, a fracture dislocation. Very important not to miss this because it causes significant morbidity. Again, always line up. It does not. This is a Galeazzi. That was the other X-ray that was shown. This is a fracture of distal 1/3 of the radius with a dislocation of the distal ulna. And this is why it is so important to get 2 views, because you can see the dislocation here. What is this? Notice very subtle but present proximal ulna. And does the radial head line up? The answer, it does not. So again, Montesia injury. You don't want to miss this. Again, it should line up on every view. All right, I took you through a journey here of common pediatric orthopedic trauma injuries. We've learned how important it is to get multiple views, and you need to always consider child abuse in this particular setting. I'm going to go ahead and turn on my video again. And I thank you for your attention. And please go ahead and email me or through social media at mgaushi-hill. And otherwise on WhatsApp, we will get questions and I'm happy to answer them. And with that, we'll stop. And thank you so much.
Thank you, Prof. Mariana. This is the last lecture in this session. If you want to add any question, you can add the box and can be answered soon, inshallah. If you have any comment from Dr. Muhammad.
Thank you, Hamad. Thank you, Saleh, for covering these 2 days with us. And inshallah, by now we finish our 2nd day, and we are looking forward to see you again tomorrow morning. And if there is any question, as Dr. Hamad mentioned, You can leave all your questions, all your comments in the box. By the way, there is a few questions here keeps repeating our attendees. They keep asking about the lectures and the presentations, how they can get it. I think it was sent on the answer box or in chat, actually, the link to the future vision. It has all the lecture of yesterday. It's already now downloaded in the YouTube of Future Vision. I can see it now. And for the lecture of today, within the next few hours, it will be there, inshallah. For tomorrow also, it will be there. It will be there for almost like 2 weeks. Okay, so for those who wish to, who miss few lectures or miss today or yesterday, they can go back to this YouTube channel of the company and they can review these lectures. The other question, what time this will have the CME hours in Mumaris? This is from the Saudi Council. Already the names submitted automatically. By the end of tomorrow, okay, they will calculate, it should be more than 70% your attendance, and it will be automatically entered in your Mumaris link, your Mumaris in Saudi Council. But it has nothing to be done with the company, but it will be there, I can assure you, okay, within 2 days after the conference. If there is any other question, please feel free, okay? I put this morning my X address, which at alfayfi911. You can ask me any question. We can also for future activities or conferences or anything. We will, people also asking about the USE CME hours. Okay. Also, we will send, you will have a certificate also from the Future Vision. We will send it to all the attendees. It will have the Saudi Council CME, AAP CME, the ASIP CME, and it's already signed by Professor Marianne Goshi, and I think it will be officially accepted because we sent them this certificate for approval and they did approve it already. Any other question, please feel free to send me any question. Dr. Hamad here, Dr. Saleh also will be with us. And for any question, feel free to ask, please. And we will see you tomorrow at before 8 o'clock, inshallah. Thank you again. Assalamu alaikum wa rahmatullahi wa barakatuh.